and good evening to all the colleagues and my friends. On behalf of Cheng General Hospital, it's my pleasure to welcome you to the Cheng Live 2020. This year, the Congress has been switched to virtual meeting due to the pandemic of COVID-19. In fact, it may give us a different way of thinking how to meet together. Therefore, this year we have a great opportunity to work in partnership with Mayo Clinic to facilitate expert forum to discuss HCM disease. We have also invited experts from Beijing Fuwai and the Xijing Hospital. I believe it is a grand event worth looking forward to seeing your outstanding experiences. We have set 2 programs. Today, we are focused on hypertrophic cardiomyopathy, HCM. Tomorrow, we will discuss more about the complex and high-risk indicated procedures. I wish all the participants from different areas enjoying these 2 days meeting and apply to your work to benefit our patients. Thank you.
Okay. Now we will start our program, and I'm the cardiac surgeon from Xijing General Hospital, and let me introduce my colleague in this section, the co-moderator, Dr. Cao, the chief of the cardiologist, and Dr. Tzeng, he is a pediatric cardiologist and also the chief of the section, and Dr. Lin, a senior cardiologist from Xijing General Hospital, and Dr. Zhang, he is the EP man from the Xijing General Hospital. And we also have many friends from Mayo Clinic, Dr. Ommen, Dr. Schaff, and Dr. Nishimura. And today, the first speaker is Dr. Ommen. Dr. Ommen is the grandmaster of the hypertrophic cardiomyopathy. Now he is the director of cardiomyopathy clinic in Mayo Clinic. And he also a great leader and participant to set up the guideline of hypertrophic cardiomyopathy. Today his topic is the guidelines update 2020 in HCM. And now we welcome Dr. Ommen for his great talk.
Hello, my name is Dr. Steve Ommen from the Mayo Clinic. I'm the director of the Hypertrophic Cardiomyopathy Clinic here, and I had the honor of being the chairman of the writing committee for the new Hypertrophic Cardiomyopathy Guidelines. It's such a pleasure for me to be able to speak to you today, and hope your day is going well and this whole session is helpful for you. This is my first time getting to talk about these new guidelines, so let's go through what the big changes are, and then the rest of the speakers will be talking about some of the details. I will point you to 2 resources. One is the American Heart Association, and the other is the American College of Cardiology, which both have apps and online tools that break down all of the guidelines into bite-sized chunks, and each of them will have a risk calculator to help understand the risk of sudden cardiac death in the context of the new guidelines. I think you'll find those useful. So let's break down these guidelines, and really the best format to go over these is really the top 10 take-home messages. These were the 10 points that the writing committee felt really set these guidelines apart and were the reasons why we got together. I'll go into each of these in slightly more detail, but we focused on bringing the patients into discussion by sharing decisions with them for fully informed treatment and diagnostic discussions. For the first time in a guideline, we promoted the concept of hypertrophic cardiomyopathy centers as being the optimal care for patients. We refined the diagnostic testing strategies for family screening. We refined some of the cardiac imaging recommendations, particularly around the use of cardiac magnetic resonance imaging. Sudden cardiac death risk assessment remains one of the most challenging aspects of the management of hypertrophic cardiomyopathy, and we've seen an evolution of risk factors, and we'll talk about that in more detail. This includes a discussion of sudden cardiac death risk in children, which is the first time this has appeared in our guideline document. Invasive therapies for those patients who have drug refractory symptoms is discussed. The management of atrial fibrillation and heart failure get new updated guidelines. And then importantly, the recognition of the beneficial aspects of healthy exercise, but still the potential risks of participation in higher intensity sports are all discussed in the guidelines. So let's talk about these a bit more. First is this concept of shared decision making. This isn't really earth-shaking. Many of us, have been practicing shared decision-making for years. That means you talk to the patient about what their goals are for why they're coming to see you for a visit. Do they want more longevity? Do they want better quality of life? What trade-offs are they willing to have? Do they want to take more medications? Are they willing to have operations? Shared decision-making is the process of making sure that is a dialogue between you and the patient, and not just dogmatically telling a patient that they must get a certain procedure or they must not go a certain route, but it's a discussion, a dialogue in the patient's best interest. As part of that, I think it's worth pointing out, and this is the figure from the guidelines that breaks down the class of recommendations, class 1, 2A, 2B, 3. That many people make the mistake of thinking that a class 2A indication means that a patient must do that diagnostic procedure or must go down that therapeutic pathway, and that's not the intent of the guidelines at all. In fact, even a class 1 recommendation isn't meant to convey you must do this, but rather that the bulk of evidence is highly in favor of that particular therapy or diagnostic test. But again, it's the discussion with the patient to tell you if a patient has a class 1 indication or a class 2A indication for an MRI, but they are highly claustrophobic and don't want to have sedation to get that MRI done, you can have that dialogue and decide how much it would change your therapy, and then you can decide together. Just like we discussed with patients the risk of having a certain operation done, and then patients decide after that informed discussion whether they want to proceed or not. Bringing this type of shared discussion to all of the nuanced discussions for the management of patients with hypertrophic cardiomyopathy is particularly important. Moving on, the concept of the multidisciplinary hypertrophic cardiomyopathy center. It's been talked about for years. It's been promoted on some patient advocacy websites. But the guidelines committees have historically stayed away from this. The reason for that is there's some political ramifications of saying that there should be centers of excellence around any particular disease. It may come off as suggesting that primary cardiologists don't have the skills or knowledge to do something. It comes across as self-serving because often the writing committee members are from academic medical centers. And those are all super important points. But the concept of the hypertrophic cardiomyopathy center doesn't mean that patients only go to an HCM center. Rather, it means that there is a constant dialogue between the local cardiology team that the patient must get care from. They must get care from the local cardiology team, and that team must be part of their ongoing care. They can initiate evaluations, they can continue evaluations, and do many of the initial steps. But when you get to important or nuanced discussions, that's where it's more helpful for the patient to be able to talk directly to someone with more expertise in hypertrophic cardiomyopathy. And one of the best examples of that is during the guidelines writing process, every one of the class 2B level of recommendations in the document took hours of debate and dozens of email to come with the exact wording for that recommendation. If it takes the people who work with HCM every day that much discussion to come up with how to word that recommendation, that indicates to me that's probably one that the patient is going to want to be with one of those experts as well so they can get all of the nuances. And then even more importantly, for some of the procedures that are specific to patients with HCM, surgical myectomy, alcohol septal ablation, it is super important, and there are data to prove this out, that people who do this all the time have much better outcomes, and those patients really deserve a discussion with those proceduralists about the pros and cons of each of the therapies, not just one of the therapies, but both of the therapies, before they make a decision if they want to go on to more advanced care. This is the construct. We borrowed this from the Valvular Heart Disease supplement about valve centers of excellence, but again, you have the patient and their family at the middle of this diagram. They're the ones that we have to keep focused. There have to be cardiologists that they can talk to every day in their own communities about symptoms, care advances, etc. But when that care gets nuanced, or when that care gets advanced, then involving the HCM centers, whether they're at a primary HCM center or a more comprehensive HCM center, those centers also must communicate back with the whole team to make sure everyone is on the same page. We even put forth some ideas that if you're going to do these invasive procedures specific to HCM, we put target outcomes. These are the outcomes that the top centers are able to achieve both for myectomy and ablation. And in order to do this, that means you have to be following your metrics and your outcomes. Someone can't achieve these if they're doing 1 or 5 or 10 of these a year. They need to be doing a lot of these procedures so that they can maintain and achieve excellent outcomes for the patients who deserve it. Next, we turn our attention to screening of first-degree family members. As we know, this is a genetic condition, and we've been recommending screening for years. But as you'll see on the next slide, what we've done is we've advanced that screening. We're re-emphasizing the importance of genetic testing, as well as changing some of the timing of testing for younger family members in patients with HCM. So in this flow chart on the left, if you're considering genetic testing, the first box up there says families with a known pathogenic or a likely pathogenic genetic variant. If the family doesn't know their variant, either because they've never undergone testing or because they don't have a pathogenic variant, then that family is obligated to undergo clinical screening with ECG and echocardiograms on a periodic basis. And we'll talk about that. It's in the table on the right there. But if the family does know their pathogenic variant, then you look at that first family member, and if the family member has that variant, then they have HCM and they follow the clinical pathway. But if a family member does not have the family's pathogenic variant, then no further clinical or genetic testing is recommended for that patient. The only caveat is that every few years, one needs to go back and verify that that family's variant is still considered pathogenic. We've seen some variants downgraded to lesser certainty that's a disease causing. If their variant gets downgraded, then that patient must move over, that patient and family member must move over to the clinical screening. But if the family's variant is confirmed to be pathogenic or likely pathogenic, then again, no further ECG or echo are needed for that family member. The bigger change was when we recommend onset of screening. There was some confusion about the way they were worded last time when we said that screening should start no later than the onset of puberty. That's still true, but what we've called out here in this chart table on the right is in the first row that children and adolescents from families in whom the genotype status is known, or they have very early onset or multiple sudden cardiac deaths in the family, that screening of those children can happen at any age, as soon as the first proband, the first patient in the family is identified, and should be repeated every 1 to 2 years. Children and adolescents from families with less malignant presentations of hypertrophic cardiomyopathy can be screened at any time, but no later than the onset of puberty, and again screened every 2 to 3 years. Adult-age family members start screening at the time of diagnosis in the first family member, and it's repeated every 3 to 5 years. Now again, these are for patients who are undergoing clinical screening, not if they are a gene-negative family member of a family that knows their positivity status. Cardiac imaging was redefined. Echocardiography remains the most key feature of this, but we refine when cardiac magnetic resonance is needed, particularly when echocardiographic imaging is suboptimal or in patients in whom SCD risk is uncertain. This whole assessment of sudden cardiac death risk now includes markers that Dr. Cha is going to talk to you about in her talk, but adding in low EF, apical aneurysms, gadolinium enhancement, incorporating that into our other risk model, as well as incorporating in the sudden cardiac death risk score as a way to fully inform family members about the magnitude of their risk, but not decide whether they get a defibrillator or not. The percent risk does not make the decision. The patient makes the decision. We also refined the risk factors in children, and you can see that in this table that's from the guidelines, that the childhood risk factors have an asterisk, and the blue boxes going down the center there. In particular, non-sustained ventricular tachycardia has more weight in children than it does in adults. But again, make sure you discuss with patients the pros and cons of defibrillator placement, as well as the context of their risk as you're helping them make this decision. Septal reduction therapies, myectomy and ablation, we talk about those in more detail. We give use cases where surgery might be favored, where ablation might be favored, and where earlier intervention, particularly with surgery for patients who have other high-risk features, are now warranted based on the data available to us. This is a diagram of the management of obstructive hypertrophic cardiomyopathy going through medical therapy progression to advanced therapies, including the septal reduction therapies that are outlined in the document. We talk about how atrial fibrillation is a class 1 indication for oral anticoagulation for our patients, regardless of the CHADS-2 VAS score. There's no use calculating it in HCM as the risk for stroke is sufficiently high that we recommend anticoagulation. We talk about how to manage heart failure. These are largely patients who have heart failure with preserved ejection fraction and should be managed as such if they don't have outflow tract obstruction. An important distinction among hypertrophic cardiomyopathy is that we consider heart failure with reduced ejection fraction when the EF is less than 50%. This is different than the general population of heart failure patients. And lastly, we have data now that affirm the beneficial effects of exercise as part of a healthy lifestyle for patients with HCM. And while we know historically that there is likely increased risk of sports participation among patients with HCM, recent studies focusing on the HCM patient have failed to demonstrate excessive risk. That means that elevation of risk is probably small, but it's certainly not zero, and it is unquantifiable. So this is a complicated discussion with the patients about whether they want to continue to pursue high-intensity exercises. That was a quick run-through on the top 10 take-home messages from the guidelines that we just published. Each of the next speakers is going to go into more detail on how you put these into your practice, and I'll be happy to talk to you at any time to answer questions or concerns. Thank you so much, and enjoy the rest of the program.
Thank you, Dr. Ommen. And any question from our panelists?
May I ask a very simple question that the pulmonary hypertension is associated with hypertrophic cardiomyopathy very frequently, and the prevalence is pretty high. And I didn't see any mention about this particular subject. Is there any particular reason for this?
Yes, that's a very good question. So we do address pulmonary hypertension in the fact that if we start seeing patients with outflow tract obstruction who have even moderate pulmonary hypertension, we now consider that a potential indication to go forward with surgery, for instance, because that can prevent them from getting to irreversible pulmonary hypertension. So we did add it there. We didn't choose to discuss pulmonary hypertension management in general, in part because that's covered in the heart failure guidelines, and there isn't anything particularly unique about managing advanced pulmonary hypertension in this set of patients. But we do consider severe left atrial enlargement, repetitive atrial fibrillation, pulmonary hypertension as newer indications for surgical intervention, and not just waiting for the patients to get to a class 3 or 4 level before you go ahead and intervene on those patients.
Dr. Ommen, I enjoy your talk very much. And we know the intensive exercise can be a risk for the patient with hypertrophic cardiomyopathy. So the treadmill exercise test can be an evaluation tool for the patient with HCM?
So it probably is reassuring to the patients, but we're not sure it should be reassuring because many of the people that, if you hear about athletes dying, they've been participating and exercising and training for years and years and years at a high level, and all of a sudden on that last day something happened. So a single treadmill exercise test really can't be used to reassure a patient. On the other hand, if that patient has ventricular tachycardia while they're exercising on your treadmill, that probably is a sign that they probably should avoid the highest intensity exercises.
Dr. Tzeng, from the pediatric view, any question?
Yes, I'm pediatric cardiologist. I'm focused about the pregnancy. As the guideline showed, for the pregnancy, the woman with hypertrophic cardiomyopathy, fetal echocardiography may be considered for diagnosis of the fetal HCM. But if the mother is a pregnant woman with hypertrophic cardiomyopathy, do you recommend to do the genetic screen at that time? Thank you.
Good question. So that's going to, in the U.S., that's going to vary from patient to patient. So some families will do genetic testing before they decide to have a child to even decide whether they want to do that or not. If they get diagnosed during pregnancy, some families will get genetic testing. There are others, again, in the U.S. who will choose not to get genetic testing, in part because there are some insurance ramifications of having a genetic diagnosis. So some families would choose not to do that. But we would talk to each family about it, offer them the opportunity, but rarely, there are case reports of families doing in vitro genetic testing of a fetus when the mother is known to have HCM or the father is known to have HCM, but that's not a routine practice.
Okay, thank you. I agree because we do the genetic counseling prenatally. After pregnancy, probably it's unnecessary at that time. Yeah.
Right.
Thank you.
Dr. Tzeng, from the EP view, any question?
Thank you for your talk. I have two short questions. The first one, there are significant discrepancies of LV ejection fraction measurement among echocardiography, MRI, and nuclear medicine. As you mentioned, your cut-off point of systolic dysfunction will be LVEF less than 50. So what is the gold standard of LVEF measurement for patients with HCM?
So I had a hard time hearing you. Let me repeat what I think I heard your question was, and then you can verify for me. So I think that you mentioned CMR and the degree of and how we use that for risk stratification, and you also mentioned the ejection fraction of less than 50% as a potential indication for sudden cardiac death, and perhaps why did we choose that cutoff? Is that what your question is?
Sorry, I repeat my question. My question is, when we classify patient into the left ventricular systolic dysfunction, the LV ejection fraction measurement, what is your recommendation? You use echocardiography, cardiac MR, or nuclear medicine?
So we generally use echo for the vast majority of patients. For many patients, they do end up getting CMR as part of their initial evaluation risk stratification. We will use the ejection fraction from that as well. We do not routinely do nuclear assessment of ejection fraction, so it's usually the echo and or MRI that we use to classify patients.
Thank you. My second question is that in the guideline, you mentioned there are some patients have exercise-related symptom, and you recommend to do exercise-based echocardiography. But what is your comment on the exercise right heart catheterization and measurement?
So we generally Well, we like to do exercise tests on many of our patients the first time I see us to establish a baseline, even if they're asymptomatic. In part because many patients also don't really have great insight into whether they're having symptoms or not, because they generally come on gradually and they might not notice a big change in their life. So we can compare their exercise capacity versus age expectations. The other reason to do exercise testing for patients who have symptoms is if you have not detected a resting or easily provoked gradient during the usual echocardiogram, then doing stress echocardiography, specifically exercise echocardiography, can help you determine whether dynamic obstruction is present at the time the patient is developing symptoms, and that can then determine your therapeutic pathways for the patient.
Thank you.
Dr. Lee, you accept it?
Well, sorry, I've got a short question for you, Dr. Ommen. That we often encounter RV failure. I mean, whether the patient is experiencing pulmonary hypertension or not, and there are also some sort of anatomical complications such as ventricular aneurysm and so forth. But I've noticed that they didn't categorize all these patients very specifically, such as the surgical treatment never specifically aimed at left ventricular aneurysm. Seems that to me that nobody is trying to handle this sort of tricky scenario. So can you brief us in to the rationale for this?
Yes, I think that's an important point, and hopefully Dr. Schaff will mention a little bit about the apex during his comments. But the apical aneurysm probably is the result of long-standing subendocardial ischemia that then results in a scar out at the apex. That can be very arrhythmogenic. It can also be thrombogenic, and so we've seen complications from that. We have resected apical aneurysms for people who are having frequent ventricular tachycardia and for patients who have a residual obstruction between the aneurysm cavity and the rest of the ventricle that's going to make that continue to be worse and put a lot of strain and stress on that apical aneurysm. And so by going in through that aneurysm, we can relieve any mid-ventricular obstruction and then reduce the size of the aneurysm. And hopefully Dr. Schaff will make some comments about that during his time.
And Dr. Wuban, I will ask, is there any scoring system to evaluate this kind of patient?
Scoring sheet to evaluate which kind of patients? What? I didn't hear the end of your sentence.
Any scoring system to evaluate certain cardiac death?
Yeah, so there is a risk calculator tool that was developed by our colleagues in Europe that, putting into patients' demographics and some of their clinical features, can give you a 5-year estimate of their risk for sudden cardiac death. We have proposed using that not as the sole determinant of whether a patient gets a defibrillator or not, but rather as a way, when I tell a patient that they have a risk factor, whether it be massive hypertrophy or a family history, that means their risk of dying suddenly in the next 5 years is 7%. Whatever the calculation is in their demographics. And that gives the patient more, something to hang on to. It's hard to just say, I have higher risk. That leaves the patient not really knowing what that means. But by giving them a number, it puts it in context for them and can make them more confident in decisions they make about a defibrillator. So that risk calculator tool is available right now on the American Heart Association application that I showed on that second slide today. It's downloadable in app stores. And the American College of Cardiology will also have a version of that coming out this month in December.
Okay, we also have a participant from the Mayo Clinic, Lady Linda Brown. She is a clinical practice director. And may I ask you how to evaluate the patient with HCM, the daily exercise strength in your daily practice?
Are you asking me, or are you asking Jane Linderbaum that question?
I'm asking about Linda Brown in daily practice. How to evaluate the patient could tolerate the exercise strength.
Well, I mean, so I think the way the practice often works is Jane is often our patient's first contact if they're having symptoms at home or trying to get seen at Mayo, and she's an experienced clinical provider and really gets to know these patients well, and then she can escalate their care to Dr. Nishimura or myself when they have HCM. But in terms of the exercise testing, we do that for all of our patients. In terms of exercise as part of daily life, we generally do recommend it for all our patients, but if they're having class 3 symptoms that limit their ability to do that, then that's a signal to us that we need to do more and often advance their care, such as doing a myectomy or consider ablation in select patients.
And certainly there are some patients where we start that assessment before they even arrive on site by learning about their current activity tolerance before they even arrive on the clinical site to help us expedite their care when they are seen face-to-face.
Thank you. Any question?
Okay, I have one question about about the cardiac screen and pediatrician. Some of cases among children it's symptomatic. Most of cases in adult is symptomatic, so it's totally different. So, do you recommend EKG screen in cases without symptoms in public?
Yeah, that's a really important question, and it does vary from family to family. So, some families want to know everything about the rest of their family, and it might have implications. So if we diagnose a 5-year-old child as having an abnormal EKG and maybe increased wall thickness, that family might treat that child differently. They might not enter competitive sports, which are very common starting at that age around here. So they might change the way and the hobbies that child gets exposed to. Other families will do exactly what you just said, and that is if the kid is doing well and is healthy, let's wait and screen them later on. And so that's part of that discussion that we have. We have a genetic counselor who's involved in all of our patients, and the clinicians talking to the patients about when and how to best screen their children. But it is a complicated discussion, as you're implying.
Last question from Dr. Li.
I appreciate your exploring this topic to us. That I have a purely different aspect of the administrative questions. That how do you organize all these resources on such a rare kind of disease, even in Mayo Clinic? I mean, the prevalence rate is very low. I mean, how do you organize the leaderships and to provide you all these resources? And is there any cost-effective analysis on this? I mean, I'm very curious. That's what it is. Thank you.
That's a great question. I think we can all thank Dr. Jamil Tajik for establishing the subspecialty clinics at Mayo, and particularly within cardiology. So it is a resource-intensive practice. There's no doubt about it. But in terms of overall cost-effectiveness, I think that the outcomes that we have with our patients, from when they come, that we are selecting the right patients to go on to surgery, and the outcomes that Dr. Schaff and Dr. Drain are able to achieve with, like almost, non-existent complication rates and high success rates are a testament to this team approach we have with people who focus solely on this. And more anecdotally, when patients enter our system because they weren't known or there was a referral pattern that had them see a different cardiologist or a different cardiac surgeon through some route, those patients always ended up having a more complicated course. And so streamlining the care to those of us who do it all the time really is part of the efficiency and the value that Mayo Clinic provides to these patients. So, but there's no doubt that it is a resource-intensive model, but that it kind of is what the Mayo brothers set up 150 some years ago now.
Okay, thank you, Dr. Ommen. Now we will move to the next. Dr. Cao will introduce the next program.
Good morning, good evening. The next speaker is Professor Nishimura, and Dr. Nishimura is a professor of medicine, Mayo Clinical College of Medicine and Science, and Judd and Mary Morris Layton Professorship in Cardiovascular Disease and Hypertension, Mayo Clinical School, and the Mayo Clinical College of Medicine and Science. And he is also a chair of Division of Structural Heart Disease, Department of Cardiovascular Medicine, Mayo Clinic, Rochester, Minnesota. So Professor Nishimura is going to give us a talk. The title is Current Clinical Evaluation of the Patients with Hypertrophic Cardiomyopathy. Dr. Nishimura, please.
So Dr. Ommen has just given you a beautiful overview of his new 2020 ACC/AHA guidelines for the management of patients with hypertrophic cardiomyopathy. What I'd like to do is, from a clinician standpoint, go over what we feel is the clinical evaluation of the patient with hypertrophic cardiomyopathy. And in order to do that, I'd like to say a few words about the clinical presentation and some of the clinical pearls we've picked up over the years in treating thousands of patients with this disease. Say a few words about what is hypertrophic cardiomyopathy now in 2020, and then some general guidelines as to how we're going to evaluate the patient coming to our office with hypertrophic cardiomyopathy, such as the overall general concepts, what we do for symptom relief, and what we do for prevention of sudden death. Now, when we talk about the clinical presentation of patients with hypertrophic cardiomyopathy, they'll either come to us with an abnormal electrocardiogram, some may come with the onset of symptoms, some may come because a heart murmur was heard on auscultation, and some patients will come because their family history is positive for hypertrophic cardiomyopathy, they had their screening, and all of them then would have the diagnosis of hypertrophic cardiomyopathy made by two-dimensional echocardiography and Doppler. Now, when we see this yellow box here, what that kind of represents are the clinical pearls that we've picked up over the years in treating these patients. Now, let's first talk about the abnormal electrocardiogram. There are some electrocardiograms like this that are obviously hypertrophic cardiomyopathy, but then you might get some moderate abnormalities of the electrocardiogram, and the question is whether or not this is truly hypertrophic cardiomyopathy. What I want to bring to your attention in some of these other electrocardiograms is a study that our group has done using artificial intelligence. So they've actually used a convolutional neural network-enabled electrocardiogram and applied it to thousands of our patients with hypertrophic cardiomyopathy and ran it through the network, and were able to predict which patients from a 12-lead electrocardiogram might have hypertrophic cardiomyopathy. So for instance, in this electrocardiogram here, as it ran through the neural network, indeed, even though by eyeball we couldn't tell this is hypertrophic cardiomyopathy, the artificial intelligence was able to tell us that indeed there is a 90% probability of having the disease.
The clinical implications of this is now we have a tool for widespread screening using artificial intelligence and just the plain old 12-lead electrocardiogram to detect whether or not hypertrophic cardiomyopathy is there. Now next let's turn to just a couple pearls about the heart murmur. As we know, about 2/3 of patients with hypertrophic cardiomyopathy are going to have that systolic murmur consistent with the left ventricular outflow tract obstruction. But many patients, it's difficult to know whether or not this murmur is due to the dynamic outflow tract obstruction. Now, classically, our textbooks have said you should Valsalva the patient, you should exercise them, so on and so forth. But what we found in our own practice is that it's this maneuver from taking their stethoscope, having them squat down, hearing the murmur decrease in intensity, and then as they stand up, the murmur gets louder and louder and louder and goes from a and increases in intensity. And this is very highly sensitive and specific, very highly accurate for determining whether or not your systolic murmur on examination is the dynamic murmur of hypertrophic cardiomyopathy. Now we go to symptoms, dyspnea, angina, and syncope, that triad of symptoms that you've learned about as present in patients with hypertrophic cardiomyopathy. But if you actually go through the history, some subtle clues are in these patients with symptoms due to a dynamic outflow tract obstruction, they will tell you that there's a marked increase in symptoms after heavy meals or after alcohol, much more than you would suspect from a patient, let's say, with dilated cardiomyopathy or a patient with angina pectoris. So that's a clinical pearl about making the diagnosis of hypertrophic cardiomyopathy if a patient comes in with symptoms. And finally, there's this family history. We want to be able to screen all first-degree relatives because this is an autosomal dominant transmission, and the current guidelines are going to be every year as a teenager and every 5 years as an adult. Now, next, let's turn and say a few words about what is hypertrophic cardiomyopathy from the clinical standpoint. And in the past, we would always diagnose it as severe hypertrophy of the myocardium in the absence of a known etiology. Now, what we're finding, though, as we see thousands and thousands of these patients, is that the hypertrophy is not necessarily just in the basal septum. The hypertrophy can be anywhere in the myocardium. It can be the entire septum, as shown in the upper right. It could be in the free wall in the lower left. It could be concentric hypertrophy, as shown in the bottom middle, or it could be hypertrophy involving only the apex. The clinical implication of this is that the diagnosis by two-dimensional echocardiography is hypertrophy anywhere, but you do not need systolic anterior motion of the mitral valve because a third of the patients might not have dynamic outflow tract obstruction. And because of hypertrophy anywhere, you do not need that asymmetric septal hypertrophy. Dr. Lin is going to be discussing the imaging approaches to hypertrophic cardiomyopathy, and we'll go into this in more detail. Now, what we've been finding, though, is essentially hypertrophic cardiomyopathy is almost always a genetic disorder. This was discovered about 20 years ago by Marriott and Roberts, and it's probably, in most instances, we find that there are over 11 defective sarcomeric genes with over 2,000 different mutations and a couple of the non-sarcomeric genes. But what is probably the underlying pathophysiology is that you've got this gene mutation which causes a poison polypeptide, and you then end up with altered sarcomeric structure and function. And what we're seeing on echocardiography is a compensatory hypertrophy to the altered sarcomeric structure and function. Now, the implications of this genetic basis of hypertrophic cardiomyopathy is that probably in the next 4 to 5 years, our diagnosis is actually going to be made by genotype. and it's going to be the clinical severity is going to be made by your clinical examination, echocardiography, and MRI scanning that Dr. Lin will be talking about. So we talked about the overall clinical presentation and how these patients come to us and some of the kind of clinical pearls that we like to present to you. We talked about what is hypertrophic cardiomyopathy, and it really is a genetic disorder. What I want to kind of go over from the clinical standpoint now is how we evaluate these patients and what do we do, and what do we tell the patients who come to us with the diagnosis of hypertrophic cardiomyopathy. And we're going to break this down into general concepts. We're going to break this down into how we relieve symptoms if present, and then say a few words about prevention of sudden death, what Dr. Chaw is going to further elucidate in the later talks. So, general concepts for discussion with the patient and family on hypertrophic cardiomyopathy who present with hypertrophic cardiomyopathy are this. Is number one, make sure that they avoid competitive athletics. They need to continue to have a regular exercise program so they keep themselves physically fit. But you want them to avoid any type of competitive athletics in which they're really pushing themselves, in which the myocardial oxygen demand might exceed that of the supply and cause an ischemic cascade. They need to continue to keep themselves well hydrated at all times, and that means a lot of the fluids need to go in, and we recommend 3, 4, 5 liters per day. As we said before, they need to screen all first-degree families. And I think the thing to remember is that in the past, we've always talked about hypertrophic cardiomyopathy as a deadly disease. But it turns out that as we've studied this, that most patients will actually have an excellent prognosis. And the survival for most patients is going to be comparable to that of an age-matched, sex-matched control population of patients who do not have the disease. Now, next let's turn to relief of symptoms. So you've got a patient coming to you who's complaining of significant symptoms of shortness of breath and angina. And in order to determine how to relieve that, we have to understand the basic underlying pathophysiology. Now, we know that the pathophysiology of patients with hypertrophic cardiomyopathy is complex. There can be myocardial ischemia, there can be diastolic dysfunction, there can be the arrhythmias, and there can be severe mitral regurgitation. But the majority of patients who come to you are going to have symptoms because of a dynamic left ventricular outflow tract obstruction. Now, we know it's caused by systolic anterior motion of the mitral valve. It'll be present in about 2 out of 3 patients who have hypertrophic cardiomyopathy. And as stated before, it's the major cause of symptoms because the obstruction itself can cause ischemia. It can cause pressure overload on the left ventricle, resulting in dynamic diastolic dysfunction. And distortion of the mitral valve apparatus can actually then lead to significant mitral regurgitation. It's nice to know then that if you relieve obstruction, you'll improve diastolic filling, you'll reduce mitral regurgitation, and you'll improve symptoms. And this is important because a number of years ago, people were thinking that obstruction wasn't that important for patients with hypertrophic cardiomyopathy, but we clearly know now that the obstruction can produce severe symptoms. You relieve the obstruction, and you can significantly improve the symptoms. So shown here is a patient who had a very high gradient at the baseline state. And by just decreasing the gradient, not only do you decrease the obstruction, but look at the dramatic reduction in left atrial pressure, knowing that you're going to then improve their symptoms. So what we want to do in the clinical evaluation of these patients who present with symptoms is search for obstruction, because we know that effective treatment of the symptoms is going to be based upon our ability to find severe obstruction. Now, when we search for obstruction, what we have to do is we have to look for that systolic anterior motion of the mitral valve, which is associated with a late peak in left ventricular outflow tract velocity. But some of these patients, actually a third of these patients, may present with symptoms but not necessarily have obstruction at rest. So what you then have to do is look further at your echocardiogram, because you now understand that the mechanism of systolic anterior motion of the mitral valve are elongated leaflets and excessive coaptation length. And if you see those long leaflets, even in the patient who doesn't have obstruction, you know they have the potential for having obstruction, because it's actually those long elongated leaflets that get pushed into the left ventricular outflow tract by the septal hypertrophy. So then you'll end up with that systolic anterior motion of the mitral valve. So if you have a person with symptoms, but they do not have significant obstruction at rest, go ahead and look for those elongated mitral valve leaflets. And if you see that, then go ahead and try to provoke obstruction with either Valsalva maneuver, exercise testing, or amyl nitrate. And you'll need to be able to determine whether or not you have provocable obstruction to know whether or not they would be candidates for septal reduction therapy. So if we have our patients, they come to us, they're severely symptomatic, the first approach would be medical therapy. And at Mayo Clinic, we like to use beta blockers. We like to gradually increase the dosage to get resting heart rates in the 50 to 60 beats per minute. If they're intolerant of the beta blockers, in the past we'd always go to calcium blockers or even disopyramide. But now with continued symptoms, because our septal reduction therapy is so good and so effective, we'll go right to myectomy or ablation. I will say that a few words about mavacamten. It's one of the new drugs that's being evaluated right now. It works directly on the actin-myosin filament and might have some very, very important additions to therapy in the future if our trials show that it can be an effective, safe drug for these patients with symptoms and severe outflow tract obstruction. But if you have a patient who's significantly symptomatic, who has already been on a dose of beta blockers and has continued symptoms, those are the patients that you want to consider for septal reduction therapy by either septal myectomy or septal ablation. So in patients with left ventricular outflow tract obstruction, either at rest or during provocation, severe limiting symptoms, unresponsive to medical therapy, septal reduction therapy is very, very effective in restoring quality of life. And Dr. Schaff and Dr. Liu will be discussing these options further. Now, there's one other type of myectomy that I know Dr. Schaff will talk about. But we have a number of patients now who are coming to us who develop an apical aneurysm and midventricular obstruction from probably what starts out as an apical variant of hypertrophic cardiomyopathy. And they can have significant symptoms of angina, they can have significant arrhythmias, they can be at risk for embolic events. And Dr. Schaff has developed this beautiful surgery in which he goes in, resects the apical aneurysm, resects the midventricular obstruction, and the patients do very, very well afterwards. So I'm just whetting your appetite for what Dr. Schaff is going to be presenting to you with septal myectomy. Now, we talked about general concepts, we talked about symptoms, we talked about how we relieve symptoms, but every patient who has hypertrophic cardiomyopathy, irrespective of whether or not they have symptoms or are going to have myectomy, need to undergo risk stratification for sudden death. Now, sudden death in hypertrophic cardiomyopathy is interesting because the initial studies at referral centers showed a very high annual mortality of up to 7 to 8% per year due to sudden death. But we've subsequently seen that in unselected populations, there's a much lower mortality, which I had said before is comparable to that of the general population. And the clinical dilemma is that even though they have a low annual overall mortality, hypertrophic cardiomyopathy is the most common cause of sudden death in the young. So what we need to do is we need to be able to try to risk stratify these patients. Now, sudden death is unpredictable. Years will go by without any symptoms, without any warning, and all of a sudden death may occur. We know that AICD can be life-saving, so the question is, can we predict who is at risk for sudden death? Now, this patient here, significant, severe septal hypertrophy, severe hypertrophic cardiomyopathy, and a brother who died suddenly, a young person. There's no doubt that this patient is at high risk for sudden death and should get themselves a defibrillator. But what about the patient with a septal thickness of only 20? Or what about the older 65-year-old man with syncope? And what about the patient whose second cousin died at age 55 of unknown causes? We need to be able to predict which patients are at risk for sudden death. Unfortunately, we have Dr. Young-Mei Cha, who's going to be discussing further with you how to try to predict patients who are at risk for sudden death so that they can have an implantation of an automatic defibrillator and hopefully their lives can be saved in the future. So what we've done in this session is talked about the clinical presentation and some clinical pearls we've used over the years. We've talked about what is hypertrophic cardiomyopathy, the fact that it is a genetic disorder, and then the overall evaluation, the general concepts that we talk about, symptom relief, and prevention of sudden death. So thank you very much for your attention.
Thank you, Dr. Nishimura, for your excellent talk. Is there any questions from our panelists? So, Dr. Nishimura, I have a question, two questions for you. And the first one is regarding the cardiac murmur. If the patient standing from the squatting, the murmur gets louder. So can the intensity of the murmur reflect on the severity of obstruction? And the second question is, how do we differentiate? Because we see a lot of patients with left ventricular hypertrophy. So how can we differentiate the hypertrophic cardiomyopathy from LVH secondary to hypertension or exercise adaptation?
Yeah, both are very excellent questions. And I really push the cardiologists in the United States to be able to use their stethoscope, because the murmur of hypertrophic cardiomyopathy is one not to miss. And no matter what is seen on the echocardiogram, you're talking about the intensity of the murmur. If the intensity of the murmur gets much, much louder, they have a dynamic outflow tract obstruction that's causing their symptoms, which we do need to treat. So thank you very much for that question, because the physical examination is just such an important part, especially if you have many, many patients coming in and you don't have time to do all these testing on everybody. Simply listening to them for that murmur with the changes with maneuver is going to be very, very highly sensitive and specific. The other question is a very important one, because there are other causes of increased wall thickness on echocardiography. And the definition of hypertrophic cardiomyopathy is actually significant increase in wall thickness in the absence of a known etiology. Now, with that being said, I would say that anybody with a wall thickness greater than 15 millimeter should be considered as having hypertrophic cardiomyopathy unless something else is going on. And one of the big mimickers we're seeing now, I know Grace Lynn is going to talk about, are the infiltrative cardiomyopathies, such as amyloid heart disease, that we have to be able to differentiate. And I'll leave it up to Grace to talk about that. She'll also talk about the difference between hypertrophic cardiomyopathy and the athlete's heart. But that's very important, because some of these highly trained athletes can have increased wall thickness that looks like hypertrophic cardiomyopathy, but there's aspects that Grace is going to talk about. So it's very, very important. But I think bottom line is, if you're wall thickness is greater than 15 millimeter, you must consider it to be hypertrophic cardiomyopathy until proven otherwise. Thank you for your question.
Professor, thank you for your talk. My question is for patients who was drug refractory and also at high risk for sudden cardiac death. If this patient received septal reduction successfully, there's no more outflow tract obstruction, do these patients still need AICD implantation?
That also is a very excellent question. We feel that a good myectomy septal reduction will decrease the risk of sudden death, but it will not eliminate the risk of sudden death. So if you have a patient who's already at high risk for sudden death, for instance, the young woman I showed you with the very thick hypertrophy and the family history, you should still consider placing a defibrillator. I will repeat, we do think it decreases the risk of sudden death, a good myectomy, but I know it does not eliminate the risk because we've had a few patients who've continued to have ventricular arrhythmias. Very important point.
Thank you. So another question is that for patients both indicated for septal myectomy and AICD implantation, would you recommend patients to receive both procedure sequentially, or you might recommend one to receive one procedure first and wait and see to receive another for a couple of months?
I'm sorry, could you repeat that? You were talking about two procedures, and I
two procedures if patient both indicated for AICD implantation and septal reduction. So
right.
As you mentioned, would you recommend patient to receive both procedures simultaneously?
Oh, yes. In our practice, what we do is we do the septal myectomy first, and Dr. Schaff would be able to talk about it in his talk. But when the septal myectomy is done, many times the defibrillator lead can be displaced. So we will perform the septal myectomy first, several days after the surgery, then place the AICD. So it's all done within the same hospitalization.
Thank you for your excellent talk. I mean, I have a very brief supplement for the mechanism of SAM that, to my knowledge, is sucked into the flow tract by Bernoulli effect, right? The speed of the flow is not pushed into it as I recommend in the early days of my practice. And the other small question will be, how much is the percentage that you ever palpated the heart, you feel the multiple apical impulses in your patients? It's a very simple maneuver that is augmented to your auscultations. There's a lot of cardiologists didn't even bring in their stethoscope for clinics. How do you do that?
Absolutely. I agree that a proper physical examination is essential. And I would say in about 80% of patients in the United States, realizing that the body surface area is much bigger than what you see, if the body surface area is not big, 80% of the patients, you're going to feel that abnormal apical impulse. And I tell my fellows that you can make the diagnosis of hypertrophic cardiomyopathy by palpation and not necessarily even need your stethoscope. So I really like your statement and your question. In terms of the mechanism of systolic anterior motion of the mitral valve, it's actually been controversial. And when I was training, we were taught that it was the Venturi effect that would suck the mitral valve into the outflow tract. But subsequent studies looking at the velocities, these various velocity vectors, show that there's actually not only a suction, but the elongated leaflets are pushed in the outflow tract as a mechanism. So I really think it's a part of both, but it does require then for us to look at the mitral valve leaflets as abnormalities of hypertrophic cardiomyopathy in addition to that of the septum. But a very nice question, because I think many of us are intrigued with that pathophysiology.
Thank you so much.
Because we are running out of time, I have to close this section. Thank you, Dr. Ommen and Dr. Nishimura, for your very outstanding talks, and thank you all of our colleagues to participate in this section. So I would like to close this section, and let's move to the next section. Let's welcome Dr. Hsiung and Dr. Cheng to moderate the section. Thank you.
Good morning and good evening, ladies and gentlemen. It's a great pleasure for me to welcome you to the next session this morning. I'm Dr. Yun-Hsuan Tzeng from Xijing General Hospital. Beside me is the other moderator of this session, Dr. Ming-Chon, also from Xijing General Hospital. The panelists of this session including Dr. Wang Hao from Fuwai Hospital in Beijing, Dr. Wen-Yu from Tri-Surface General Hospital in Taipei, Dr. Wang, Dr. Mei-Han, Dr. Ren-Shyan Liu from Xijing General Hospital. The next topic will be presented by Dr. Grace Lin. Dr. Lin is the Director of Heart Failure Clinic, Division of Circulatory Failure at Mayo Clinic in Rochester. And her topic is Contemporary Imaging in Hypertrophic Cardiomyopathy. Let's welcome Dr. Lin.
Hello, good evening. Thank you for inviting me to participate in this great conference about treatment for hypertrophic cardiomyopathy. I feel very privileged to participate with all of you tonight. My name is Grace Lin. I'm a cardiologist and advanced heart failure and transplant specialist. I'm an associate professor of medicine and director of heart failure services here at Mayo Clinic in Rochester, Minnesota. I'll be speaking tonight on contemporary imaging in hypertrophic cardiomyopathy. I have no disclosures relevant to the presentation tonight, but I do have a few research-related disclosures, which are listed here for you. So over the next 20 minutes, I'm going to talk to you a little bit about how we approach imaging in patients with hypertrophic cardiomyopathy. The mainstay of imaging in hypertrophic cardiomyopathy really is echocardiography. We use this for diagnosis of patients with hypertrophic cardiomyopathy to identify the specific phenotype and structural abnormalities, including those of the mitral valve and mitral valve apparatus. Echo is very useful for hemodynamic assessment of these patients at the time of diagnosis and at follow-up, and as well for intraoperative and for intraprocedural guidance for patients who will be undergoing septal reduction therapies. Cardiac MRI is another very useful technique which is complementary to echo. It can give us some additional structural information about patients with hypertrophic cardiomyopathy that we sometimes can't see very well with echo. In addition, in some patients in whom echo images are quite difficult, cardiac MRI may be an effective alternative. So during this talk, I'm going to focus primarily on imaging for the diagnosis of hypertrophic cardiomyopathy, and more specifically how we can characterize the different structural abnormalities and hemodynamic changes that we might expect in HCM. So I'd like to just briefly restate the imaging criteria for hypertrophic cardiomyopathy. The diagnosis of hypertrophic cardiomyopathy by echo or cardiac MRI can be defined as a hypertrophic, non-dilated left ventricle, absent any other causes of hypertrophy. We think of this as patients who have a maximal end-diastolic wall thickness anywhere in the heart, oftentimes in the septum, but anywhere in the heart, of at least 15 millimeters or more. In those patients who are family members of patients diagnosed with hypertrophic cardiomyopathy, a maximal end-diastolic wall thickness of 13 to 14 millimeters, a little less than 15 millimeters, would be adequate to suggest that that family member also has hypertrophic cardiomyopathy. Now, there is significant morphologic heterogeneity in patients with hypertrophic cardiomyopathy. We often think of these patients as having asymmetric septal hypertrophy, as Dr. Nishimura mentioned in his talk, and in fact, the vast majority of patients will have this pattern, about 70%, where the septum is hypertrophied out of proportion to the rest of the heart. It usually starts at the base and can extend to the apex, although there is some variation in the pattern of asymmetric septal hypertrophy, where some patients will have this sort of more sigmoid appearance, where it's thicker at the base, and other patients will have a more consistent thickening all the way through from base to apex. But patients may have other patterns as well. In some cases, the thickening could be more exclusively to the lateral wall, in some cases concentric, in some cases down at the apex, and in some cases more predominantly at the mid-ventricle. Now, we can see all of these different types of structural abnormalities in hypertrophic cardiomyopathy readily by echo. So you can see the two patients at the top of the screen have the more conventional asymmetric septal hypertrophy, again, the pattern we might expect in the majority of patients with hypertrophic cardiomyopathy. We can also see those patients who have a more mid-ventricular component, as you can see over here, where this patient has obstruction primarily at the mid-ventricle, and patients who have a more apical pattern of hypertrophy. When we have difficulty seeing these patterns by echo, sometimes adding contrast can enhance the images. So in this case, this patient's been given echo contrast. Here's the left ventricle by Mayo convention for imaging here on the left. You can see that contrast fills into the cavity and really quite nicely delineates that apical pattern of hypertrophic cardiomyopathy. Now, I want to take a few minutes to talk about the patients with a mid-ventricular obstruction, because this might be a group of patients that is important to identify because they can be at somewhat higher risk for more adverse outcomes from hypertrophic cardiomyopathy. Now, in these patients, sometimes adding contrast can really help to delineate the area of thickening or of obstruction here at the mid-ventricle, while it's also showing us this apical aneurysm that can occur in these patients. So you can see here the non-contrast enhanced image, where we do get a sense of this akinetic apex, which is aneurysmal, but when we give the contrast, we can really see how well this area fills in and how thin the ventricle is out here at the apex compared to down here at the mid-ventricle and even down here at the apex. Now, this group is of particular importance because patients who have a mid-ventricular obstruction, about a third of these will have this phenotype where they have this apical aneurysm. The aneurysm is thought to occur because of chronic wall stress and resultant ischemia. The patients are at risk for developing thrombus within the aneurysm. Some patients will develop monomorphic ventricular tachycardia. The patients are then at risk of sudden death as well as stroke from the intracavitary intracardiac thrombus. As well, patients could develop heart failure that leads to patients can develop systolic dysfunction that leads to heart failure, and overall, these patients are at increased risk of mortality. It's estimated that the patients have at least a threefold increased risk in adverse outcomes related to hypertrophic cardiomyopathy. When you consider the risk of sudden death and cardiovascular mortality, the risk is probably fivefold. So really a very important group of patients to be able to identify. So there is some variability in terms of the structural abnormalities that occur in these patients with midventricular obstruction and an apical aneurysm. Many patients will have this hourglass appearance, as this patient does, where you can see this aneurysmal apex and a kind of narrowing down here at the midventricle where we're seeing some color flow by Doppler indicating an obstruction. And in fact, if we Doppler with CW Doppler, you can see that this patient has a 28 millimeter gradient through that midventricle. Now, in those patients with a very large aneurysm and this hourglass appearance, we can usually see this pretty readily by echo, and if we enhance with contrast, we can see it even better. But there are some patients that will have a very small apical pouch, and those can be missed by echo. In such cases, cardiac MRI can aid in the diagnosis. By cardiac MRI, we can sometimes see these very tiny pouches out of the apex, and the pouches are usually fibrotic. Because they're fibrotic, they'll often enhance with contrast in a pattern that we would describe as late gadolinium enhancement. So you can see here at the rest of the ventricle, it's sort of darker. Out at the apex, you'd expect to see some white within the myocardium that suggests it's enhancing with gadolinium because that area of the myocardium is fibrotic. In other patients where you might have difficulty imaging the heart by echo, sometimes cardiac MRI can be a useful alternative. In cardiac MRI, you can see a very distinct difference between the dark myocardium and the bright blood within the cavity, so you can really get a nice demarcation between the myocardium here and the blood, and really get a very accurate measurement of the septal thickness. And in some patients by echo, that can be quite difficult. So you can see this example of a patient with asymmetric septal hypertrophy, nice delineation of the septum here, as well as this patient with an apical variant hypertrophic cardiomyopathy, where you see similar to that contrast-enhanced image by echo that we looked at before, the bright blood in the cavity and this very sharp demarcation between the myocardium, which is black, and the bright blood here. Some of these patients may also have RV involvement as well, hypertrophic cardiomyopathy, and the structural changes are not limited to the left ventricle. The right ventricle in some patients can be quite difficult to see. And by cardiac MRI, we can see the free wall of the right ventricle very nicely, and we're looking for patients that may have a greater than 8 millimeter involvement of the free wall, suggesting that hypertrophic cardiomyopathy also involves the right ventricle. Now, the structural changes that we see with hypertrophic cardiomyopathy are not limited to the myocardium. Now, the structural changes that we see in hypertrophic cardiomyopathy are not limited to the ventricle alone. In some of the patients, we may also see some abnormalities of the mitral valve and the papillary muscles, which can also contribute to LV outflow tract obstruction. So in this case, cardiac MRI can also be useful to give us a better image of the papillary muscles and any associated abnormalities than we might be able to see on echo. So, for example, this patient has split or bifid papillary muscles, which you can see very nicely in this long axis image of the heart, which is similar to some of the apical images that we can get by echo. So there are a number of different structural abnormalities of the mitral valve and papillary muscles that we can see in patients with HCM that would contribute to left ventricular outflow tract obstruction. The abnormalities are often in the insertion of the papillary muscle, so the patients may have a papillary muscle that inserts directly onto the anterior mitral leaflet. In some cases, the papillary muscle inserts directly onto the septum or the free wall, and some patients may have this split bifid or double bifid papillary muscle as we saw on the MRI image. In other patients, the insertion is normal. What we see is merely a hypertrophied or particularly thickened papillary muscle, but in some cases we may see other accessory papillary muscles as well. In other patients, the papillary muscle and the insertion might be completely normal, but the patients have abnormal mitral valves. In hypertrophic cardiomyopathy, we sometimes will see mitral valves that are longer than expected. In about a third of patients, they may be longer than 17 millimeters. In addition, the coaptation point of the mitral valve is different than it is in normal patients. The coaptation point is often more central rather than at the leaflet tips. It's these abnormalities of the papillary muscle and the mitral valve leaflets that will contribute to systolic anterior motion of the mitral leaflets, abbreviated as SAM, which then contributes to left ventricular outflow tract obstruction. So let's look at a few echo images. So if you look at this parasternal long axis over here, again, you can see this patient has a pattern of hypertrophy that probably would be more consistent with an asymmetric septal hypertrophy. If you look right here at the mitral leaflets and watch the image play, you can see that the leaflets push up against the septum. So that motion during systole, the forward motion up into the anteroseptum, is systolic anterior motion of the mitral leaflets. What that will typically give us is mitral regurgitation. And we'll try to get this image to play here. That should show us posteriorly directed jet of mitral regurgitation. Now, it's important as you evaluate these patients to also look for intrinsic mitral valve disease. In some cases, we can be fooled in seeing a patient has significant mitral regurgitation and attributing all of this to systolic anterior motion of the mitral leaflets and assuming that that will be corrected once the left ventricular outflow tract obstruction is corrected. So for example, let's look at this patient. Again, from the parasternal long axis, you can see that the patient has a hypertrophied ventricle with a pattern that suggests asymmetric septal hypertrophy. And if you're to look just here at the mitral valve leaflets, on this parasternal long axis, you might be fooled into thinking that this patient has just systolic anterior motion of the mitral leaflets. However, when we get to the color images, here in this apical view, we have an apical four-chamber, again Mayo convention with the left ventricle on the left. Look at the pattern of mitral regurgitation by color Doppler. And notice that the jet is anteriorly directed rather than posteriorly directed as we might expect from a patient who has mitral regurgitation solely due to systolic anterior motion of the mitral leaflets. On closer inspection, we can see this patient actually has a flail segment of the posterior leaflet also contributing to mitral regurgitation. So this abnormality would be addressed at surgery, and it's important to make sure that we identify any other intrinsic abnormalities of the mitral valve when we're considering therapies for these patients. Now, this pattern of hypertrophy resulting in a narrowed left ventricular outflow tract and a hemodynamic effect that can cause left ventricular outflow obstruction, together with abnormal mitral valve leaflets and abnormal mitral valve apparatus, results in systolic anterior motion and LV outflow tract obstruction. And this is something that we can readily measure by echo. And in fact, approximately 75% of patients with hypertrophic cardiomyopathy will have a dynamic left ventricular outflow tract obstruction. To identify and quantify the degree of obstruction, we can use CW Doppler. So by putting a cursor through the left ventricle and through the LV outflow tract, we can look for this fast velocity. In this case, this patient has an LVOT velocity of 6.4 meters per second. The CW, or continuous wave Doppler envelope, has this very typical pattern, whereas a fixed obstruction that we might expect from aortic stenosis will have a rounded shape. This is a dagger shape, late peaking CW envelope consistent with a dynamic outflow tract obstruction. So in this case, peak LVOT velocity is 6.4 meters per second, which gives us a peak left ventricular outflow tract gradient of 164 millimeters of mercury. Now, one technical aspect to consider as we're evaluating these patients in the echo lab is to be sure that we've measured the LV outflow tract velocity, giving us the peak LVOTO gradient rather than the peak MR velocity, and the two can be sometimes difficult to separate. So take, for example, this patient that I saw recently in the echo lab who has both significant mitral regurgitation as a result of SAM as well as a dynamic outflow tract obstruction. So if we look here in the first signal, we can see mitral regurgitation at 7 meters per second. It has a very typical appearance for mitral regurgitation that's nice and rounded, but underneath you can almost get the sense that there's this triangular or dagger-shaped signal. Now, as the sonographer is imaging and tilting the ultrasound beam back and forth, we start to see the sharp triangular shape come into focus. The MR signal starts to fade away, and in the last image here we can see in very sharp focus this dagger-shaped signal, late peaking dagger-shaped signal that is the peak LVOT velocity of 4.6 meters per second, giving us a dynamic left ventricular outflow tract gradient of 85 millimeters of mercury. So as we see these patients in the echo lab, we need to look for obstruction, and particularly if we see a patient with SAM and we see a patient with asymmetric septal hypertrophy, where we expect or suspect that the patient should have a significant obstruction. And the threshold that we look for is 50 millimeters, because this is the threshold that we might use clinically to determine whether or not a patient should have additional therapies such as septal reduction therapy. So as we're looking through the echo with Doppler, we look for a resting gradient of at least 50. So if we have a resting gradient of 50, we've identified obstructive physiology. If not, then we need to start thinking about some provocative maneuvers. One is to ask the patient to Valsalva. If the patient Valsalvas and the gradient is 50, then we're done. If not, then we might go on to give another provocative agent, which is amyl nitrate, again to look for a gradient of 50. If we're still unsuccessful with these initial provocative maneuvers in the echo lab, we can then subject the patient to exercise and look for a stress-induced gradient of greater than 50. And finally, if none of these measurements by echo are successful in identifying a gradient that we suspect to be higher than 50, we might then consider invasive measurements with hemodynamic catheterization. It's important as well as evaluating for dynamic outflow tract obstruction to consider diastolic dysfunction in patients with hypertrophic cardiomyopathy. These are patients with a restrictive cardiomyopathy. Initially, they present with symptoms similar to heart failure with preserved ejection fraction, and eventually some patients may develop systolic dysfunction. So as they develop increasing filling pressures, they'll have increased left atrial pressures and then decreasing cardiac output that leads to dyspnea and fatigue. Well, it may be difficult to evaluate the cardiac output because of the dynamic outflow tract obstruction, resulting in increased flow velocities through the LVOT. We can, however, evaluate for abnormalities in LV filling pressure and increased left atrial pressure. Again, in some of these patients, because of mitral regurgitation, it might be difficult to grade the degree of diastolic dysfunction, but we can certainly look for it, and we can certainly evaluate as to whether the LV filling pressures are increased, as we might expect in patients with hypertrophic cardiomyopathy. We also need to be aware of lookalikes and mimics, that is, other patients that have left ventricular hypertrophy that will result in this thickened ventricle resembling a patient with hypertrophic cardiomyopathy. Recall that one of the criteria for diagnosing hypertrophic cardiomyopathy is a thickened ventricle without any other cause of hypertrophy. So if we look over here, in this corner we have a patient with hypertrophic cardiomyopathy, but every single one of these other patients that's shown on the screen also has a thickened ventricle. So you might suspect that any one of them has hypertrophic cardiomyopathy, but in fact Fabry's disease, renal failure causing a type of amyloidosis, hyperoxaluria, amyloidosis from light chain disease or transthyretin, and mucopolysaccharide storage disorders can also result in a thickened hypertrophy ventricle that resembles one with hypertrophic cardiomyopathy. Now, the mimicry can go even beyond just the structural appearance by 2D echo or by cardiac MRI. Here, in fact, is a patient with AL amyloidosis who had a thickened ventricle with asymmetric septal hypertrophy and an LV outflow tract obstruction. So if you look here first at the pulse wave Doppler, you can see this characteristic dagger-shaped or triangular-shaped signal. With continuous wave Doppler, we can see that the velocity is high, 3 meters per second, but not perhaps high as the threshold that we would have expected. This probably gives us a gradient around 36. With Valsalva, again, we can see that the signal starts to have this dagger-shaped appearance. Now we're reaching 5 meters per second, and by comparison, you have the mitral regurgitation here. But this patient has a fairly significant obstruction at rest that increases with a provocative maneuver, suggesting that this might be a patient with hypertrophic cardiomyopathy. So in fact, this patient was referred for consideration of septal reduction therapy. But with echo, we have some other imaging techniques at our disposal which might help us differentiate from patients that have hypertrophy or thickened ventricles for reasons other than hypertrophic cardiomyopathy. So this is strain imaging, another way that we can look at some contractile function in patients. This pattern happens to be from the patient that we were just looking at with the outflow tract obstruction. So here you can see that this patient has well-preserved strain at the apex, where you can see this bright red area, but not so good contractility or strain here at the mid-ventricle or down here at the base. This pattern with preserved function at the apex, the so-called cherry on top, is a pattern that's very typical for infiltrative disease such as amyloidosis. So this patient was in fact ultimately diagnosed with AL amyloidosis by endomyocardial RV biopsy. In contrast, hypertrophic cardiomyopathy gives a different pattern. In hypertrophic cardiomyopathy, the strain tends to be most abnormal in the areas that are most hypertrophied. So this patient has hypertrophic cardiomyopathy with asymmetric septal hypertrophy, and you can see that the strain is very abnormal, shown here in blue, at the basal septum. In contrast, this patient has an apical variant or apical pattern of hypertrophic cardiomyopathy where the strain is very abnormal at the apex but normal everywhere else, almost the exact opposite of this patient who had AL amyloidosis. So strain echocardiography is a very useful technique in the echo lab that might help us to differentiate the reasons for hypertrophy of the ventricle, to identify those patients who have reasons for thickened walls other than hypertrophic cardiomyopathy. By cardiac MRI, we also have some additional techniques at our disposal to help us differentiate patients who have thickened walls for other reasons. One of these ways is by giving contrast or gadolinium to look for fibrosis. So, for example, a patient with AL amyloidosis would have diffuse nulling. So instead of having an area of patchy fibrosis, you would see that the ventricle, which is normally black, would be quite grayed out, suggesting that the amyloid is diffuse and spread out throughout the myocardium. In hypertrophic cardiomyopathy, we look for patchy fibrosis. So the gadolinium, which is extracellular, will hang out or hang up in places in the myocardium where you see fibrosis or scarring. This will occur in a non-coronary pattern and can really occur pretty much anywhere and in any pattern in patients with hypertrophic cardiomyopathy. As you can see in this composite image, the fibrosis can be mid-myocardial, can be transmural. Typically, we'll find it in the septum as well as in the left ventricular lateral wall, but we can find it in other areas as well, such as in the right ventricle, in the insertion points of the right ventricle onto the septum, and within the papillary muscles. Now, the degree of fibrosis or late gadolinium enhancement is also important, as this gives us some idea of sudden death risk. Now, I won't go too much into this because Dr. Chow will be giving you a lecture on sudden death risk and assessment in patients with hypertrophic cardiomyopathy, but I just wanted to point out that as the amount of late gadolinium enhancement increases, the risk of sudden death increases. In this group of patients, of around 1,300 patients who were followed after assessment of the degree of late gadolinium enhancement, a threshold of about 15% seems to confer an increased risk of at least twofold for risk of sudden death. Finally, I just want to close by talking a little bit about intraprocedural or intraoperative support with echo for patients undergoing septal reduction therapy. So for patients who are undergoing surgical myectomy or determined to be candidates for surgical myectomy, we use preoperative and intraoperative transesophageal echo. The preoperative transesophageal echo is to confirm the pattern and severity of septal hypertrophy, to identify any abnormalities of the mitral valve and papillary muscles that might need to be corrected. Post-procedure or post-operative, we would evaluate for the residual gradient, any residual mitral regurgitation. We would assess for the occurrence of a ventricular septal defect or the presence of aortic regurgitation. We also can use echo to support patients who are undergoing alcohol septal ablation. Now, the preferred imaging is usually transthoracic echo, but you can also consider intraoperative transesophageal echo or intracardiac echocardiography as well. Pre-procedurally, we would confirm the absence of massive hypertrophy and abnormal mitral leaflet or papillary muscles, or any patients that might need to have a surgical approach to septal reduction rather than alcohol septal ablation. We can also assist in identifying the location of septal perforators by administering intracoronary contrast using a myocardial contrast echo technique. Post-procedurally, we would also assess for any residual obstruction. We would evaluate for the extent of septal infarction, for any residual mitral regurgitation, any post-procedural pericardial effusion, or for the occurrence of a ventricular septal defect. So just to summarize, imaging in hypertrophic cardiomyopathy. Echocardiography is a very useful technique for diagnosis of patients with hypertrophic cardiomyopathy. We can identify structural abnormalities that would occur or are expected in HCM, including thickened left ventricular walls. We can often use echo to distinguish hypertrophic cardiomyopathy from other causes of ventricular hypertrophy. We can look at structural abnormalities of the mitral valve and papillary muscles as well. Echo is useful for procedural guidance and follow-up for patients who undergo septal reduction therapy. And cardiac MRI is a useful and complementary technique. In addition to identifying structural abnormalities that might not be readily visible by echo, the administration of contrast or gadolinium enhancement can help us to identify fibrosis, and that may be a useful adjunct to determine sudden death risk in patients with hypertrophic cardiomyopathy. Thank you very much.
Thank you very much, Dr. Lin, for your excellent lecture. Is there any question or comments from the panelists?
Yeah, I have a question, Dr. Lin. Can you hear me?
Yes, I can hear you.
Okay. We found out that some POCM patient which had the muscular band from the septum connecting to the apex, which when we do the echo, sometimes we would be mismeasured the thickness of the septum. Have you found that kind of problem?
Yes, it's a great question. I'm an echocardiographer primarily, so I always think echo is the best imaging technique. But I think some of these abnormalities, particularly when we're looking at papillary muscle structures or these anomalous muscle bands, especially when it goes out to the apex, and then some of the ones that insert down into the left ventricular outflow tract abnormally, can be difficult to see by transthoracic echo. And you could try contrast enhancement in those patients, but oftentimes I think for those patients, the cardiac MRI would be a preferred technique to make sure that you can adequately measure the thickness. In addition to the different cuts that they're able to obtain that we can't obtain by echo, I think the bright blood and black myocardial interface makes it much easier to get a more accurate measurement of the thickness.
Okay, thank you.
Let me interrupt for a few seconds. The panelist was Dr. Wang Hao from Fuwai General Hospital. He's the best echocardiographer, as far as I know, so from Fuwai General Hospital. We have one question from the audience. He just asked, in the near future, is echocardiogram can replace the rule of MRI in evaluation of hypertrophic cardiomyopathy? Dr. Lin, what do you think?
It's a good question. So, can echo replace MRI? I would argue that echo was first, and MRI is moving into supplanted. But I think echo is always going to be a useful technique for patients with hypertrophic cardiomyopathy. It's the most versatile technique that we have. It's the most readily available. You can move it to the patient, or you can't do that with a cardiac MRI. And I think in most cases we get very, very good structural information and better hemodynamic information that we can get with, at least with current MRI techniques. Where I think MRI is beneficial is where we're looking at some of these myocardial differences. So if we're looking at mimickers, so Dr. Nishimura mentioned athlete's heart, which I apologize, I left out of the talk. I think when you are thinking about athlete's heart versus hypertrophy from hypertrophic cardiomyopathy or infiltrative disease, then I do think that cardiac MRI is maybe superior because you can give gadolinium, and in an athlete's heart, you might expect there not to be any gadolinium enhancement abnormalities, whereas by MRI, hypertrophic cardiomyopathy patients should have right gadolinium enhancement. And then similarly, infiltrative diseases will have a completely different pattern. So I think from that standpoint, MRI is superior, but in general, for most structural imaging for hypertrophic cardiomyopathy and hemodynamic assessment, I think echo is still the preeminent strategy.
Thank you, Dr. Lin, for your answers. Because our schedule is very tight, I think it's time for us to go on to the next topic. The next topic in this session is on risk stratification for sudden cardiac death in hypertrophic cardiomyopathy, and it will be presented by Dr. Yong-Mei Cha. Dr. Cha is the professor of medicine at Mayo Clinic College of Medicine and Science. Let's welcome Dr. Cha.
Hello, good morning. My name is Yong-Mei Cha, the electrophysiologist at the Mayo Clinic, Rochester. I appreciate this opportunity to discuss the risk stratification for sudden cardiac death in patients with hypertrophic cardiomyopathy. The cause of potential sudden cardiac death is multifactorial. Genetic substrate is a risk factor, yet currently we have not reached a consensus on which mutation is the high risk to predict sudden cardiac death. Ventricular substrate including LV hypertrophy, myocardial disarray, and myocardial scarring all contribute to the sudden arrhythmic death. Concomitant coronary artery disease with subendocardial ischemia and microvascular ischemia also are risk factors. In addition, autonomic dysfunction, which was associated with the outflow tract obstruction with elevated sympathetic tone, certainly play a significant role as a trigger of ventricular arrhythmia. In this month, the new 2020 ACC AHA guideline for the diagnosis and the treatment of patients with hypertrophic cardiomyopathy is published, and Dr. Steve Ommen is the chair of this document. For ICD indication, the document indicates that if patient has history of a VT-VF, these patients are the class 1 indication for ICD. If patient has any one of the following risk factors,
good morning, everyone. It is good
in first degree or close relatives at age equal less than 50, left ventricular hypertrophy greater or equal to 30 millimeter in any LV segment, arrhythmogenic syncope within 6 months, or LV apical aneurysm or EF less than 50% is the candidate for considering a class 2 indication to receive ICD. Patients with evidence of myocardial fibrosis greater than or equal to 15% of LV mass or documented non-sustained VT is also a candidate as a class 2B indication for ICD. If patient has no above risk factors,
尊敬的各位专家、教授，你们好，我来自西京医院超声医学科以及西京医院。
I would like to review each risk factor, for primary sudden death prevention. family history of sudden
尊
cardiac
敬的各位专家、教授，你们好。
So this is a Mayo Clinic study. It included 177 consecutive patients with HCM with mean age 45. All these patients had received prophylactic
尊敬
ICD
的各位专家、教授，你
for
们好。
sudden death prevention. Some of these patients had family history of sudden cardiac death in first-degree relatives. The result showed that the patient with a family history of sudden cardiac death had a similar arrhythmic event as the patient who had no known history of a family sudden cardiac death. In addition, the study only select the patient with the family history as a single risk factor compared to those patients without family history of sudden cardiac death. As you can see, the final incidence of arrhythmic event was similar between the two groups. The event rate is between 2 to 3 per 100 patient year. This is a patient of mine, 30-year-old gentleman with HCM, septal thickness 27 millimeter. Patient has a brother who died suddenly, for which we offered this patient an ICD. This was only 4 months later. Patient had an event of polymorphic VT, then ventricular fibrillation. Of course, the ICD saved his life. Let's look at the LV wall thickness and sudden cardiac death. This study clearly showed the relationship between the thickness of the LV wall and the incidence of sudden cardiac death. For every 5 millimeter increase in the LV wall thickness, there was incremental incidence of sudden death per 1,000 patient year. Patients with the LV wall thickness greater than 30 millimeter had much higher incidence of event compared to the other groups. Let's look at the syncopal and the risk of sudden cardiac death. And this is a study included about 1,200 patients. The study grouped the patient into 3 categories. The first majority group was the patient without history of syncopal, and as a reference or control group. The second, the group patient include 153 patients who had unexplained syncopal. As you can see, the arrhythmic subsequent arrhythmic event rate was almost 15 per 1,000 patient year with a relative ratio 1.78. The third group was the neurally mediated syncopate group. And this group patient has similar risk as the patient without history of syncopal. Further, the study looked into the timing of the syncopal and the risk of sudden cardiac death. As you can see in the right side figure, if patient has unexplained syncopal within 6 months before the initial evaluation, and this group patient had much higher, precisely 5-fold increase in risk compared with the patient without syncopal. Older patient, age greater or equal to 40, with a remote episode of syncopal, did not show any increased risk of sudden cardiac death. Now, the new document proposed EF less than 50% is a risk factor. This is the new study published this year in JACC. The study included almost 2,500 patients. Majority of these patients had a normal ejection fraction. 118 patients had EF less than 50%. And these patients, as the cardiac MRI shown here, there was apparent myocardial scar with delayed enhancement around the myocardial wall. Of these 118 patients, the authors divided them into New York Function Class 1 or 2 group versus New York Function Class 3 or 4 group. So in patients with the mild heart failure symptoms, all these patients survived, but 10% of these patients had ventricular arrhythmia requiring ICD therapy. In patients with a severe heart failure, New York Function Class or 3, 1/3 of them died of heart failure or post-heart transplant. The other 2/3 of patients survived from the heart transplant or ICD therapy. So in this group with the severe heart failure, the ventricular arrhythmic event was 25%. Further, the study compared patients with a normal EF versus EF reduced below 50% in terms of arrhythmic event rate. As you can see, patients with the normal EF, the event rate was 0.5% per year, while the patient with reduced EF, the event rate was 2.4% per year. So further, the frequency of arrhythmic event was 17% in EF 35 to 49%, and it was 19% of event rate in EF less than 35%. So this result indicates that the event rate was quite similar, regardless the patient EF is severely reduced versus mild to moderately reduced. So that is this is why the document recommend the patient to receive ICD if the ejection fraction is less than 50%. Look at the LV apical aneurysms in relationship with arrhythmic sudden cardiac death. And this is another new criteria for ICD implantation in the new document. The study included near 2,000 patients with HCM. Of these patients, 93 patients had LV apical aneurysm identified by either echocardiogram or cardiac MRI. With a follow-up of 4.4 years, 3% of the patients died suddenly, and the sudden death event rate was 4.7% per year. I would like to emphasize that the event rate in about 5% per year rate is very similar to the patient population the patient population with ischemic cardiomyopathy who received ICD for primary prevention. We know non-sustained VT is a risk factor for sudden cardiac death or cardiovascular death. This is a meta-analysis compiled multiple studies showing If patient has history of a non-sustained VT, this patient has a twofold increased risk of sudden cardiac death compared to the patient without a history of non-sustained VT. Young patient had independent risk factor for sudden death. If if a non-sustained VT is frequent, longer, or faster, the risk might be higher. LVOT VT is not a risk factor. Look at the last risk factor of late gadolinium enhancement and the sudden cardiac death event. This study included near 1,300 patients with a 3 years follow-up. As you can see in the right side figure, the extent of late gadolinium enhancement was associated with the increased risk of sudden cardiac death event. So the hazard ratio was 1.46 per every 10% increase in myocardial fibrosis. On the left side figure, as you can see, if the myocardial fibrosis burden is greater than 15%, the patient would have a twofold increase in sudden cardiac death event risk compared to those with fibrosis burden less than 15%. This is one of our patients, a 67-year-old female with HCM. Patient complained palpitations. Cardio MRI showed evidence of delayed enhancement. And the patient wear a Holter, which showed no evidence of non-sustained or sustained arrhythmia. However, we provide the patient a prolonged recording with the body guarding for a month. And then the recording caught this episode of monomorphic ventricular tachycardia. Fortunately, this episode was self-terminated. So I like this diagram from the new document that specifically gave us a workflow for the patient selection for ICD indication. If patient has had a previous VT, VF event, then class 1 indication for ICD. If patient has any one of the risk factors, including family history of sudden cardiac death, massive ventricular hypertrophy, unexplained syncopal, apical aneurysm, or EF less than or equal to 50%, these patients are qualified for class 2A indication for ICD. If patient has non-sustained VT or extensive scar detected by cardiac MRI, and these patients would be qualified for ICD with the class 2B indication. Of course, if patient has no above risk factors, then ICD is not indicated. So after the decision is made, the patient is willing to have ICD, which is recommended by the physician. The next step is to decide what ICD we should select for the patient. So this is the new guideline, indicate that if patient just received ICD for sudden death prevention, then single chamber, either transvenous or subcu ICD would be adequate. If patient has bradycardia require atrial pacing, then patient would need a dual chamber ICD, or patient has reduced EF and the left bundle, then this patient may deserve a CRT-D device. I would like to emphasize the availability of alternative ICD the sub-Q ICD, which was approved by FDA in 2012. And in our practice, 1/3 of the patients receive sub-Q ICD are patients with hypertrophic cardiomyopathy. As you can see, the generator is located in the axillary area, and the coil is completely subcutaneous location. So when patients develop a VTVF, this lead can detect arrhythmia. Then the shock coil, as you can see, is just along the left side of the sternum and deliver the shock to defibrillate. So that has the benefit of to avoid intravascular lead complications. And this is a chest X-ray showing the generator location and the coil location in the PA view and the lateral view. Sub-QICD is not for everyone. If patient has bradycardia requiring pacing, if patient need a CRT for heart failure, or patient has documented monomorphic VT requiring ATP, and these patients are not candidate for sub-QICD. I would like to introduce the new technology, extravascular or substernal ICD. So this figure showed the substernal ICD has the generator located in the left axillary area, similar to the sub-Q ICD. However, the generator is much smaller. The coil also tunneled subcutaneously to the xiphoid, but at this point, the lead dived into the anterior mediastinum. As you can see, it's behind the sternum, okay, and it served the similar purpose of defibrillation. On the lateral view, you can see the lead is just between the pericardium and the sternum. So that require a smaller energy to defibrillate. And finally, when we meet with the patient and have shared decision-making for ICD, we need to have a full discussion about the benefit of ICD versus the risk of ICD. As we all know that the benefit of ICD on average will deliver appropriate therapy about 2.3% per year. However, the ICD may carry the risk of lead perforation and lead dislodgement, infection, lead malfunction, and the potential inappropriate ICD therapies. So we need to share with the patient and to determine indeed the benefit of ICD is overweighing the risk of the ICD and to get the best benefit of a device therapy. Thank you for your attention.
Well, we thank you, Dr. Chow, for the excellent presentation. But unfortunately, Dr. Chow has something come up. He's not at the scene. So I would like to, our panelists, or from the audience, any questions? Or start with Dr. Lin. Do you have some comments on the sudden cardiac death with ICD, with hypertrophic cardiomyopathy?
Thanks for Professor Chow's excellent talk. Yeah, it's said that the Professor Chow is not available here, but I would like to give our panelists or our audience or some comments, because it's quite different about the management of prevent sudden cardiac death in Taiwan and in Europe or in US, because in Taiwan, as the limited of the government insurance, we have no indication for primary prevention in our hypertrophic cardiomyopathy patients. So it's very hard to, in Taiwan, to do the primary prevention for the ICD implantation. So, but actually we have some, painful experience that the patient's initial presentation in sudden cardiac death, and not return of, yes. So I think it's maybe we needed to find another way to cover this patient, to how to make an optimal management to prevent sudden cardiac death in Taiwan. Yes.
Dr. Wang.
This is Dr. Wang from Xijing General Hospital. Thank you for your excellent talk. My question is for those patients with water thickness more than 30 millimeter, they are indicated for ICD implantation because of the increased risk of sudden cardiac death. For those patients if we let the patient do the surgical myectomy, my question is, after surgical myectomy, is possible to avoid the implantation of ICD implantation?
Electrophysiologist or the panelists would like to answer the question from Dr. Wang?
I can give my personal comments. Yes, so far we have not much evidence about the surgical therapy could effectively to prevent the sudden cardiac death. Actually, we have not much about enough data evidence. So the major pathophysiology of the ventricular arrhythmia in HCM patients is the myocardial fibrosis and the disarrangement of the myocardial site. So I think that the pathophysiology is over the whole ventricle. So even we do the interventional therapy, surgical therapy to the septum hypertrophy, maybe the other side of ventricle has the same pathophysiology inside the ventricle. So I think it still has possibility of sudden cardiac death. So if the patient has one major sudden cardiac death risk, I think it's also indicated for the ICD implantation, even after the intervention. That's my personal
comment. Thank you. Dr. Wang.
My another question is the apical type of hypertrophic neurosis prevalent in Asian population. For such apical type hypertrophic cardiomyopathy patient, the wall thickness over the apical side. It has been considered that the apical type has more benign outcome. It's about the ICD implantation. Is in those apical type is indicated or not?
In Asian population, the apical hypertrophy is more frequent than the others population. But because the VT, as the Mayo Clinic's experience, after myectomy, the VT, the risk of ventricular tachycardia is significantly decreased. But so I think if the patient have the indication for the ICD indication, you just ICD. No matter there is apical type or septum type of hypertrophy. Yeah.
Thank you, Dr. Feng, Dr. Lin, and Dr. Wang for your comments. We would like to thank Dr. Lin and Dr. Cha for your great contributions, and I also thank all the panelists and the audience for your participation. I think it's time for us to close this session. Thank you for your attention.
Let's begin the third session. This session is called the Meet the Experts. So we have several experts from two from Mayo Clinic and one from Xijing Hospital in China. The first topic will be given by Dr. Schaff. His topic is the surgical therapy in HCM. Let me make a very brief introduction to Dr. Schaff. I think Dr. Schaff is the pioneer in the surgical treatment of HCM in the world, I think. He's now the professor of surgery of Mayo Clinic College of Medicine and Science, and a full faculty privileges in clinical and translational science in the Mayo Clinic Graduate School of Biomedical Sciences. And he's also the consultant of the Department of Cardiovascular Surgery at Mayo Clinic. I think he had already made a lot of a contribution, and it's because of him we have a lot of collaborations and communications with the team of Mayo Clinic. So please, Dr. Schaff, please.
Good morning. I want to thank the organizers of the meeting for having me speak to you this morning on surgical therapy of hypertrophic cardiomyopathy. I'm pleased to join this distinguished panel, and especially to be with Dr. Wei and my good friend Hao Wang again. I have no conflicts to disclose, but I did want to take a moment and acknowledge the support that the Tsai family has given us for both this meeting and for our research efforts over the last 5 years. Over 20 research fellows have participated in studies on hypertrophic cardiomyopathy supported by the Tsai family, and many of those studies I'll share with you today. So what can we say about surgical treatment of hypertrophic cardiomyopathy in 2020? I'd like to cover some information on which patients and why. I know you've had lots of discussion on indications for surgery. I'll also give an overview of surgical techniques that we use at the Mayo Clinic. I'll speak specifically about management of mitral valve regurgitation and mitral valve anomalies. And if time permits, we'll discuss operation for non-obstructive hypertrophic cardiomyopathy. Now, one large group of patients that are often ignored in practice are those patients with latent obstruction. These patients may be quite symptomatic, but at rest have gradients of less than 30 millimeters of mercury. However, during evaluation with Valsalva maneuvers or other provocations such as inhalation of amyl nitrite, a large gradient is elicited. And the question is, do these patients benefit as much from septal myectomy as patients with fixed obstruction? Here you can see the aggregate pre-bypass provoked gradients in patients with latent obstruction undergoing operation. And here at the bottom are the post-bypass provoked gradients. So surgery can relieve the dynamic gradient just as well as it can a fixed gradient. We always measure intracardiac pressures during operation, and you can see the pre-myectomy pressures on the top. There's very little pressure gradient at rest. However, after a PVC, there's a marked increase in the aorta to LV pressure gradient. And after myectomy, we perform the same maneuvers to provoke the gradient, and you can see there's no gradient in this patient after adequate myectomy. So what are the functional outcomes? As you can see here, patients with latent obstruction reported, about 80% of the patients reported poor or only fair health status before operation. And after surgery, only 10% fell in this category. Most patients are greatly improved, even if they have latent obstruction that's relieved when the gradient is relieved. And the survival of patients who have relief of latent outflow tract obstruction is very similar to the survival of patients who have fixed obstruction. In fact, up to 10 years, the survival curves are virtually superimposable. So we talked about one subgroup of patients that may be overlooked. But what about the timing of septal reduction therapy? How far should you push medical treatment, and when should a patient who remains symptomatic on medicines be referred for surgery? In this particular study, we reviewed 1,300 patients who were symptomatic with hypertrophic cardiomyopathy who presented to our outpatient clinics. We divided patients up into those who received what we called early septal reduction therapy. In other words, within 6 months, they had the operation, and the remaining patients at the end of 6 months had not undergone operation. Now, we started all of our analysis at the end of this 6-month landmark period to exclude any deaths due to the natural history of the disease or to septal reduction therapy. So there were 884 patients that had septal reduction either by surgery. In fact, there were 773 who had myectomy or by alcohol septal ablation. And we compared the outcome to 467 patients who had medical treatment. Now, after the 6-month period, some of the medical patients did go on to have septal reduction therapy. But despite that, we found that patients that had early septal reduction therapy had improved survival compared to those patients who were managed medically or who had persistent medical management. This is the unadjusted survival, and it turns out that when you adjust for known risk factors, that difference in survival is enhanced. So there appears to be a survival advantage to referring patients for surgery early. Again, all patients had medical treatment. The issue is how long you persist with medical treatment before surgical referral. If you look at the determinants of survival of all of our patients, you can see these risk factors played a role. And among the significant risk factors, atrial fibrillation, systemic hypertension, diabetes, advanced New York Heart Association class, and older age, in addition to no early septal reduction therapy, played a role in late mortality. And this impact of no early septal reduction therapy was independent of all of these other risk factors. Now, what about the surgical techniques that we use? The methods that we've used have evolved over the last 20 years. We now have performed over 3,600 patients who have undergone septal myectomy of one form or another. And that was through April a year ago, and now we are very close to 4,000 patients. The transaortic myectomy is performed in the following fashion. Through a low oblique aortotomy, we expose the subaortic septum after retracting the aortic valve cusps and make an incision just to the right of the nadir of the right aortic sinus. We carry the incision up and then leftward over to the anterior leaflet of the mitral valve. We call this the first cut. And I tell residents that after taking out this piece of muscle, which looks like you have it wide open, you'll be successful about 80% of the time. Because when you look in as a surgeon, you don't see the distal extent of the septal hypertrophy. And it's possible to miss residual obstruction in this area. So what we do is we rotate the heart posteriorly with a sponge stick to bring that distal septum into the surgeon's view and then perform a second cut. As I said, we always measure pressures. This is a patient who had a gradient of almost 200 millimeters of mercury after a PVC before myectomy. And you can see that after myectomy, there's no gradient at rest or with a PVC. Now, for the surgeons in the audience, if you remember any slide from my presentation, remember this one. This is a patient who is referred for a repeat septal myectomy, and you can see that during the first operation, the surgeon did not carry the myectomy far enough into the ventricle. That's illustrated in the drawing on the left side. It's important to understand this so that you do the myectomy properly the first time. And also, if you reoperate on the patient, you don't take out more muscle in the immediate subaortic area, because that could lead to a ventricular septal defect. What do we tell our patients before surgery? Well, the risk of the operation is low. It's less than 1% for most patients who are in reasonably good health. The risk of surgery is never zero, but it's one of the safest operations that we do in our hospital. We expect a gradient reduction or a residual gradient to be in the single digits. And we tell patients that there's at least a 90% chance that they'll be improved in terms of their functional capacity after surgery. We've looked at survival after septal myectomy in many, many studies. In this particular study, we looked at the survival of men in blue and women in the light red. The dotted lines are the survival of expected populations without hypertrophic cardiomyopathy. And you can see that for men, the survival of men in blue parallels that expected survival out past 15 years. Survival of women is similar to an age and gender matched population up to about 5 to 10 years, but after that point, the survival of women is less good than the expected survival. And the reasons for this aren't clear. It could have to do with not being referred to surgery early enough, or other risk factors that we really don't know much about. One question that always comes up is whether the genetic status plays any role in the survival. At least in patients who have had septal myectomy, there's no difference in survival whether patients are gene positive, gene negative, or have variants of unknown significance. So the genetic status doesn't seem to play a role in the outcome of surgery. Now, what about septal reduction by alcohol septal ablation? You can see in the blue line the number of operations done at our clinic, and in the red line the number of alcohol septal ablations, which are still done and are very successful, but in general, the patients who undergo alcohol septal ablation are those that have special risk factors for operation, or are very frail or elderly, or perhaps just frightened of an operation. In general, patients who can undergo septal myectomy have more complete relief of symptoms after surgery. And with alcohol septal ablation, there's quite a large scar that's left in the septum. You can see here in this cardiac MR, the area of infarction. In these static images, you can see the area of infarction on the left. However, with a adequate myectomy, there's no scar in the remaining muscle. Now, alcohol septal ablation has some disadvantages in patients that have very thick septums, but also in patients that have very high gradients. This just shows the pre-intervention gradient and the post-intervention gradient. And for surgical patients, it really doesn't matter how high the pre-intervention gradient is, the post-intervention gradient is predictable. However, with alcohol septal ablation, the greater the pre-intervention gradient, the greater will be the post-intervention gradient. And that is reflected in the symptom relief. After myectomy, about 90% of the patients are class 1 or 2, and there are a lower percentage of patients have that degree of functional improvement after alcohol septal ablation, even after repeat interventions. And you can see here that most patients after septal myectomy do not need a second procedure, whereas patients who undergo alcohol septal ablation not infrequently require a second procedure or an operation. Now, what about mitral valve disease in patients with hypertrophic cardiomyopathy? The most common is, of course, mitral regurgitation due to systolic anterior motion, but there are also some intrinsic mitral valve abnormalities that may be part of the phenotype of hypertrophic cardiomyopathy. And we see a moderate number of patients who have intrinsic mitral valve disease who also have obstructive hypertrophic cardiomyopathy. This illustration shows the typical posteriorly directed jet of mitral regurgitation related to systolic anterior motion of the mitral valve. And that's illustrated on the left. You see in panel A the pre-myectomy mitral regurgitation and turbulence in the outflow tract, and after successful myectomy, there's almost no mitral regurgitation and laminar flow in the outflow tract. But what we've observed during surgery is even if you have a central regurgitant jet, if there's no leaflet prolapse, those patients are often improved with septal myectomy alone. And as you can see in the panel B, after myectomy, this patient who had a central regurgitant jet had elimination of the mitral regurgitation when the outflow tract obstruction was relieved. In our experience, jet direction is helpful. It has a positive predictive value of over 90%, but importantly, it has a negative predictive value of less than 20%. In general, the severity of SAM-mediated mitral regurgitation doesn't change our strategy during operation, and we feel that in most cases, the adjunctive techniques on the mitral valve, leaflet plication, augmentation, alveolar suture, etc., are unnecessary if you do an adequate myectomy in terms of the length. So how often do we do something to the mitral valve? In this particular study, we looked at approximately 2,000 patients that had myectomy and excluded patients with known mitral valve disease. So we had 2,000 patients who had what we thought was SAM-mediated mitral valve disease, no intrinsic mitral valve disease, and of those patients, 96% had myectomy alone. Only 4% had anything done to the mitral valve. But interestingly, not all of that 4% was for SAM-mediated MR, because we made the diagnosis of intrinsic mitral valve disease intraoperatively in 33 patients, and then in 12 patients we injured the mitral valve and had to do something to repair it. So if you eliminate those causes of intrinsic mitral valve disease, the chance of doing anything to the mitral valve if you have only SAM-mediated mitral regurgitation is less than 2%. What about other mitral valve abnormalities? There are several. Displacement of the papillary muscle, hypertrophy of the papillary muscle, false chordae are often included, but these can be found in patients without hypertrophic cardiomyopathy. The most important one for the surgeons to note are the abnormal insertion of papillary muscles and elongation of leaflets and chordae. This pathologic specimen shows a anomalous papillary muscle inserting into the anterior leaflet of the mitral valve. And here you can see in this operative video, the forceps are grabbing onto an anomalous papillary muscle just beneath the aortic valve, and this papillary muscle inserts into the body of the anterior leaflet. Now, a papillary muscle that inserts into the body of the anterior leaflet can contribute to outflow tract obstruction, and we call this a type 1 obstructing anomalous papillary muscle. Another type of papillary muscle anomaly can insert directly into the free edge, but this is below the outflow tract. And in general, this type of papillary muscle does not interfere with outflow of blood. And in fact, it probably should not be excised because it contributes to valve competency as it inserts into the edge. We call this a type 3 anomalous papillary muscle. And then there are patients like this one. Here you can see the arrow shows you the anomalous papillary muscle inserting into the anterior leaflet of the mitral valve, which is shown by the second arrow, and it does contribute to outflow tract narrowing. However, you have to be careful and look at this very carefully, because the anterior leaflet inserts into the body, but it also has chordal attachments to the free edge of the anterior leaflet. And this is what we would call a type 2 papillary muscle anomaly. And when you remove this, you just remove the part that contributes to outflow tract obstruction, and you leave the attachments to the free edge so that you don't create mitral regurgitation. How about leaflet elongation? In the panel on the left side, you can see the elongated leaflet with systolic anterior motion and severe MR on the right. Elongation of the leaflets are thought to be part of the phenotype of hypertrophic cardiomyopathy, and studies by cardiac magnetic resonance imaging have shown that both leaflets are larger than normal. The anterior leaflet in patients with HCM are about 7 millimeters greater than normal on average, and the posterior leaflet is also slightly elongated. But does this justify plication or mitral valve replacement? Well, in our experience, no. If we divided all of our patients up into those with elongated leaflets shown here and those with non-elongated leaflets less than 30 millimeters, we see that the preoperative gradients are exactly the same, and the postoperative gradients and the amount of gradient reduction is the same. And then if we plot the leaflet length against gradient reduction, we see that there's no difference in gradient reduction with leaflets of 20 millimeters in length compared to those with leaflets over 40 millimeters in length. So if you do an adequate myectomy, you in general don't have to do anything to the mitral valve. And here's that same patient with the elongated leaflets, and with an adequate myectomy, there's no SAM or mitral regurgitation. Now, there is the possibility of having intrinsic mitral valve disease in patients with hypertrophic cardiomyopathy, and this is patients that have ruptured chordae are a special problem because they can present acutely with pulmonary edema, and management is difficult because management of mitral regurgitation is just the opposite of management of hypertrophic cardiomyopathy. Afterload reduction will make the gradient worse. Increasing afterload will make the mitral regurgitation worse. So when we operate on these patients, generally we proceed early with surgery to relieve the gradient and repair the mitral valve. It's important not to default to mitral valve replacement because it's still important to try to get a valve repair and do an adequate myectomy. We continue to use annuloplasties in about 70% of the patients. And the reason for persisting with repair is that in this patient group, as is true for almost every patient group we've looked at that have mitral regurgitation, the survival of patients who have valve repair is better than the survival of patients who have myectomy and mitral valve replacement. So if you have intrinsic mitral valve disease and the valve can be repaired, it's best to do a myectomy and a mitral valve reparative procedure. So for mitral regurgitation, the take-home points: central regurgitation may be SAM-related mitral regurgitation, and do not default to mitral valve replacement in such cases. Adjunctive mitral valve procedures are used in about 10% of patients, but most of the patients that have something done have intrinsic mitral valve disease. In fact, any manipulation of the mitral valve is necessary in less than 2% of patients if you only have SAM-mediated mitral regurgitation. And inspect carefully for anomalous papillary muscles. I'll finish with a brief presentation on surgery for apical hypertrophic cardiomyopathy, which is probably more prevalent in Asia than it is in the West. It's said to occur in as many as 25% of patients. Most patients with apical HCM are asymptomatic, but when symptoms develop because of diastolic heart failure, it's difficult to manage because it's a mechanical problem. The ventricle, the end diastolic volume, is simply too small. We have, for the last 15 years, explored an operation for ventricular enlargement, illustrated here, where we try to increase the end diastolic volume of the ventricle. Now, for the surgeons in the audience, the important clinical point is that there can be apical displacement of the papillary muscles with apical HCM. So be very careful when you first enter the ventricle to take off this muscle and enlarge the ventricle that you don't injure the papillary muscles. Here's such a case. You can see that the ventricle is being opened, and we plan to enlarge it, but you can see it's just a massive muscle at the apex, and you have to go quite a distance before you find any ventricular cavity. We finally here found the ventricular cavity, and we'll begin removing muscle mainly from the septum. Here we've enlarged the ventricle. We're protecting the anterolateral and posterior medial papillary muscles. And here's what it looks like when we've completed ventricular enlargement. And here's what the ventricle looks like after we close the ventriculotomy. The early studies, the early operations that we did were studied in some detail by Nishimura, who did hemodynamic studies. This particular tracing shows the LV and left atrial pressure tracing in a patient with apical HCM. After surgery, you can see it's the same ventricular pressure. The left atrial pressure is much lower. And we did studies on many more patients, but this was a good illustration. The typical case is shown here. This is a 22-year-old man who had apical and midventricular hypertrophic cardiomyopathy. He was very limited, in fact, was almost bedridden, and his clinical condition was not responsive to beta blockers, calcium channel blockers, nitrates, etc. Had been referred for heart transplant. Echocardiograms are shown here. In the upper left, you can see the long axis with almost no ventricular chamber here. The short axis shows very little ventricular cavity at the level of the papillary muscles. The same is shown on the right. And this is the patient after apical myectomy. I think you can convince yourself that there is a pumping chamber out here. It's larger in the short axis at the same level and is seen over here. This patient had his stroke volume increased to almost normal at 72 mLs per beat after apical myectomy. Now, we've done this operation in almost 150 or 200 patients by now. The mortality overall is 3%. There have been no deaths since 2013. And the issue is what good are we doing for the patient as regards their survival? Well, really, the only option that these patients have is cardiac transplantation. This is the survival of patients at our clinic who have had apical myectomy for diastolic heart failure. And this is the survival of patients with hypertrophic cardiomyopathy who have been listed for cardiac transplantation. I'm sure everyone's aware that not everyone who's listed for a transplant gets one, so this is the mortality, whether or not you received a heart, but you had hypertrophic cardiomyopathy and end-stage heart failure. The survival of patients that have apical myectomy is at least as good and may be significantly better when you get 10 to 15 years out. I also adjusted the survival for known risk factors, and it turns out that the patients who had apical myectomy had slightly more risk factors, and the adjusted survival is even better than the unadjusted survival. And when we compared the survival to patients who actually got a heart transplant, there was some improvement in survival, although it was not statistically significant between 10 and 15 years. I think it's safe to say that the patients that have the apical myectomy do just as well as regards survival as a patient who gets a transplant. Now, we've done this operation for apical hypertrophic cardiomyopathy, and in the last 5 years or so, we've accepted a different group of patients for ventricular enlargement. These are patients that have symmetrical hypertrophy with small LV cavities that really just obliterates during systole. And you can see that slit-like cavity in systole here. These patients don't have the typical phenotype of hypertrophic cardiomyopathy, but they do have small ventricular cavities that can be enlarged, and we have done the enlargement procedure in a subgroup of these patients as well. So I'll finish with these points about apical hypertrophic cardiomyopathy. First of all, the apical phenotype is not always benign. Apical myectomy is an option for selected patients with diastolic heart failure and reduced cavity volume and reduced stroke volume. And certainly when a patient gets to the point where a transplant is being considered, I think an apical myectomy should be discussed. We've documented in studies that I didn't show you that operation improves diastolic function by increasing end-diastolic volume, increasing stroke volume, and decreasing end-diastolic pressure. And symptoms improve following myectomy to enlarge the left ventricle. And as I showed you, the survival appears to be certainly as good and possibly superior to that of hypertrophic cardiomyopathy patients who are listed for heart transplants. I'd again, thank you for the opportunity to participate in the panel, and I look forward to your questions. Thank you.
Thank you so much, Dr. Schaff. And before our discussion, I'd like to introduce our co-moderator, Dr. Jeng Wei. He is the cardiologist and also the associate superintendent of Chengxin General Hospital. And Dr. Xie is the cardiologist from Chang'an Memorial Hospital. And Dr. Cai Fongjun is the cardiac surgeon from also from Chang'an Memorial Hospital. First of all, I'd like to thank you so much. Well, I think we are on the shoulder of the giant, and you are the giant. And, you are the pioneer in the surgical treatment of HCM, especially, the most valuable one is the non-obstructive HCM, because in the past, the treatment of non-obstructive HCM is a big challenge. And in the past 20 years, 30 years, at our hospital, we had done 600 heart transplantations, and 7 of them because of hypertrophic cardiomyopathy. Now we don't do this heart transplant for this kind of non-obstructive HCM now. As you mentioned that, well, you pointed out several good points, and like the prolonged, elongated coda-tendony, the mitral valve, and the treatment during the surgery. You don't do anything to that kind of patient. I certainly agree with that, because from my limited experiences, well, I also found that especially for the non-obstructive type of HCM, when we do the surgery, I usually do the apical approach, and most of the time, and almost, for all cases, we don't need to replace or to do any intervention to the mitral valve, because as you, from your operative picture, you cut the apex, and sometimes the muscle is thick, but it doesn't make any harm to the surgeon, because you just excise the muscle. Then for me, I would identify the pulmonary muscles first, and to examine the structure of the pulmonary muscles, then just need to cut the muscle. And usually I will cut about 15 to 35 grams of muscles from the ventricle. Well, I think it's quite safe, but because, in the past, surgeons are told not to cut so much muscle from the heart. Now we are very, now we are quite confident to cut that much muscle from the heart. So, well, I think before question from our panelists, there is a question raised from the internet. The question is that during surgery, when the heart is arrested and flaccid, the thickness of a myocardium seems not as thick as contracting heart. So the question is, how do the surgeons to cope with this clinical problem? The thickness of the myocardium during the surgery, yeah. How much should muscle be cut? Yeah.
I think a handy gauge is the width of a 10 blade. If you look at the knife blade, a 10 blade is 8 millimeters from the sharp edge to the dull edge. And if you incise the muscle and you bury the knife in the muscle, then you've gone 8 millimeters. Yeah. That's adequate for almost every patient if you just take an 8 millimeter depth of the myectomy. You don't relieve obstruction more by taking it deeper. You relieve obstruction more by taking it further towards the apex.
Thank you. And in the doc, oh yeah, please, yeah.
May I ask a question to Dr. Schaff?
Dr. Wang Shuiyun, yeah, you are the Dr. Wang Shuiyun, right? Yeah. Let me introduce you first. And you are the Deputy Director of the Cardiovascular Surgery Committee of Fuwai Hospital, and also Deputy Director of the Center of Cardiac Surgery for Adults. Yeah, please.
Oh, thank you. Good evening, Dr. Schaff. I have two questions. One is you have showed your last case is a very severe hypertrophic cardiomyopathy patient. Is the basal and the middle ventricular also apex hypertrophy? We can also, of course, we resect this muscle. We call it myectomy. Can we change your name with the left ventricular reconstruction in geometry? What's your opinion? It's the myectomy, but it's the reconstruction, in my opinion.
Right, it's a remodeling or reconstruction, and I didn't elaborate on that last group of patients, but those patients have small ventricular cavities with systolic obliteration.
Yes.
And their ventricles are so small in diastole and then in systole that they can't increase their stroke volume with exercise. And frequently they'll tell you that anytime they exercise, their heart rate goes to 160 before they achieve half of what they want to do. So those patients, just like the apical cases, will be improved if we can enlarge their ventricle. And doing it through the apex, I know that you have experience with this, but doing it through the apex, you really don't reduce the pumping capacity of the heart if you make a reasonable size ventriculotomy, because the apex doesn't move as much as the lateral wall. So it's a fairly benign area of the ventricle to incise.
Thank you. Time is limited. I have the last question about the septal branch. Yes, in the basement, we cut the myocardium. If a large septal branch with the diameter of 3 millimeters, it's something like the coronary fistula, a big fistula. What's the future of this big fistula?
Yeah. It's not infrequent that you see the coronary to cameral fistula. I know of one case in our experience that a cardiologist in another center thought that fistula ought to be closed, and he did it with an embolization technique, but I really don't know. I don't know for sure that there was a true steal. It would be very interesting if you have a case to try to document whether there's a steal, but it can be eliminated with embolization, with a coil.
Yeah,
thank you.
Yes, very good point. Yeah, and just Dr. Schaff, you want to name this kind of surgery. As you mentioned, probably you called it ventricular reduction therapy, right? Volume reduction therapy.
Well, that's right, and I think I'll have to come up with a suggestion for a name, because I think it's important to separate a transapical incision to enlarge the ventricle versus a transapical incision, which we sometimes use for mid-ventricular myectomy.
Yep.
And we sometimes, when I talked about those very long anterior leaflets, there have been cases where I go as far as I can through the aorta, and I'd be interested in your thoughts. Go as far as I can through the aorta, take out muscle as far as I can, come off bypass. There's still SAM, an elongated leaflet, and a distal area of hypertrophy. And we approach that through the apex. And all we're doing through that transapical incision is completing a transaortic myectomy. So the transapical approach can be used for kind of 3 different problems. But I think you're right. We need some name for the enlargement procedure.
Okay, so that with the way down to the aortic valve and the pubic muscles. Yeah, so that's the what from my experience, we can do the excision of the muscle directly from the apex directly to the down to the aortic valve. Even you can see the aortic valve. Yeah. Okay.
You can't. That's a very good point. Yes. We have done just a we have done a basal septal myectomy through the apex.
Yes.
In a patient that had a prosthetic aortic valve, a mechanical valve, who had hypertrophic cardiomyopathy and with systolic anterior motion. Now, the only problem is if the heart's very large. It's very hard to reach the subaortic area through the apex if the heart's very large. But in even the sort of a mid-sized ventricle, you can get to the subaortic area. I agree with you.
Yes. Yeah. So well, I think probably you have any questions from our panelists.
Aside from Chang-Chyi Memorial Hospital, I'm a cardiac surgeon. I did some cases of this myectomy, and every patient of mine will come up with the left bundle branch block. So, what's your experience for these patients in the long-term follow-up? You need a CRT.
Yeah, that's a very good point. We've looked this up. In fact, one of Dr. Wang's former fellows is a research fellow with us, and he published a study on the outcome of conduction abnormalities after myectomy. There's no difference in survival in patients that have a left bundle branch block versus normal conduction. But your point is a good one, and everyone should remember that if the patient comes to surgery with a right bundle, either because of intrinsic conduction disease or because they've had an alcohol septal ablation, and we give them a left bundle branch block, you have about a 30 to 40% chance of ending up with a pacemaker. So if you have normal conduction and the surgeon gives the patient a left bundle, that's not harmful or in any way that we can tell having an impact on late mortality.
Thank you so much. And any other comment from you? No? Okay. So we just spent a little more time on this topic because it's so many questions for Dr. Schaff, and we will proceed to the next topic.
Okay. Following the excellent talk of Dr. Schaff, the surgical outcome seems to be really good, and I think it's the standard of care for hypertrophic cardiomyopathy currently. And we cardiologists always want to do things percutaneously. So the following topic will be delivered by Professor Liwen Liu from Xijing Hospital. She is currently the chief of the Department of Ultrasound and Hypertrophic Cardiomyopathy Center of Xijing Hospital, 4th Military Medical University in Xi'an, Shanxi province of China. She developed the percutaneous intramyocardial septal radiofrequency ablation procedure for HOCM, and had been published in 2018, which is a very novel procedure, and the preliminary result is very promising. So we welcome Professor Liwen Liu to deliver the talk. Let's welcome her.
Good morning, everyone. It is great honor to give you this presentation. I'm Liwen Liu from Xi'an, China, which is famous for the army of terracotta warriors. I work in Hypertrophic Cardiomyopathy Center of Xijing Hospital. My speech is about percutaneous intramyocardial septal radiofrequency ablation for hypertrophic obstructive cardiomyopathy. I'd like to share more about this disease before the introduction to the new approach. Hypertrophic cardiomyopathy is the most common inherited cardiac disease that is inherited in an autosomal dominant pattern. It usually demonstrates left ventricular asymmetric hypertrophy and left ventricular outflow tract obstruction. Pathologic results show us large myocytes, disarrangement, interstitial fibrosis, and faulty infiltration, etc. Epidemiology indicates that the incidence of HCM is from 1 out of 500 to 1 out of 200. Most HCM patients have the symptoms like chest tenderness, chest pain, shortness of breath, or syncope. Some patients have no any symptom. Sudden cardiac death can be the initial symptom for some patients, and stroke, heart failure can occur in every age. Now, HCM is the leading cause of sudden cardiac death among young adults and athletes. According to the research of 813 consecutive patients in our center, it suggests that the proportion of intermediate risk, high risk, and very high risk patients is actually much higher than previous reports. So, I think most patients suffer from the poor quality of life and high risk of sudden death. Surgical myectomy is developed in 1956 and considered as gold standard to treat HCM. During septal myectomy, a surgeon removes excised muscle from the symptomed septum. This allows the blood to empty from the ventricle more easily. Artificial septal ablation is a less invasive method to treat HCM, which is developed in 1983. In artificial septal ablation, the doctor injects alcohol in a septal branch in the ventricular septum. This causes some of the heart muscle cells to die, making the septum thinner. Though this traditional treatment continues to improve in safety and efficacy, they still have some potential disadvantages and complications. So, we aim to develop a minimally invasive treatment for HCM, named Liwen Procedure. Here's an animation of introducing Liwen Procedure.
Liwen Procedure means a new approach whereby imaging technology guided percutaneously inserted intramyocardial diagnostic or treatment device reaching to the target area of the heart to diagnose or treat cardiac diseases. Echocardiography-guided percutaneous intramyocardial septal biopsy and radiofrequency ablation diagnosis and treatment for HCM is one of several types of Liwen procedure.
People must be curious about where I get this idea. I've been reading lots of medical papers to study treatment of HCM. One day, when I saw this picture in a paper about alcohol septal ablation, I immediately related it to RF ablation for HCC. So I was thinking about whether it could happen to insert RF needle percutaneously into hypertrophied interventricular septum in a beating heart. There are some difficulties we met during the development of Liwen procedure. Firstly, where can we insert RF electrode safely into the target? At first, the mortality of our first animal experiment was up to 50%. Then we did a series of animal experiments to determine a percutaneous transepic intramyocardial is the best approach. Eventually, the mortality of animals is dropped to zero in the experiment. Secondly, what should we do when arrhythmia occurs? It's well known that heart is prone to be irritable. RF ablation could cause arrhythmia. In order to protect patients as best as we can, we prefer every ablation with the monitoring of 12 leads ECG. And we analyzed nearly 10,000 copies of ECG to find a warning sign, which helped us reduce the incidence of terminating operation from 4.5% to 0. Thirdly, how do we effectively reduce the hypertrophy? It means we need to ablate the hypertrophy in a proper energy, but no optimal ablation energy can be applied to a heart. So, we analyze the parameter of ablation with hundreds of in vitro and in vivo experiments to determine the optimal relationship between RF ablation and myocardial response. The exploration of over 200 HCM cases makes ablation from one area to multiple areas, and even to what we have done today. The expanded ablation is whole LVS. It can maximize reduction of hypertrophic LVS and significantly relieve LVOT obstruction. It took us so long to get here. Liwen Procedure has been developed nearly 10 years. This idea came to me in 2012, and then we did lots of animal experiments to make it happen. Of course, we experienced the failure from the start, but fortunately, in 2016, we were approved by ethics permit of Xijing Hospital and registered USA clinical trials. And during the same year, the world's first liver procedure was finally completed. Now, over 270 HCM patients are getting better with the treatment. Now, I'm going to explain how I prefer liver procedure with one of my cases. The patient's maximum thickness of LVS was 20 mm. That LVOT peak gradient at rest was 130, and with provocation was 181. She was diagnosed at Holcomb with New York Heart Association 3 class. She decided to accept our procedure. Liver procedure is performed with 3 steps. This is the video that I'm inserting the RF needle. We percutaneously insert the needle towards the hypertrophic anterior interventricular septum of the patient by the guiding of echo. We can see during the insertion, the ECG remains stable and CVT required to keep in 8 to 10. And then we turned on the RF equipment to begin our ablation. The ablation power was increased little by little, from 20 to 40 to 60 watts. ECG was used to monitor the patient during the procedure. Generally, the ECG was stable during the ablation, but we should suspend the ablation when ECG becomes unstable, and then analyze it to decide whether we continue or not. Before performing the procedure, we can see a septal branch of coronary artery in the contrast echo. Immediately post the procedure, we see a blank hole caused by our ablation, which indicates the area of myocardial necrosis. The three septal branch of the left anterior descending coronary artery on CTA disappeared after our ablation. The hypertrophy won't grow back because the blood support of these areas was damaged by the radiofrequency ablation, which can help relieve LVOT obstruction. CMR shows a significant reduction of ablated area in the 2 years of follow-up. The thickness of LVS has become similar to the normal level. The symptoms of the patient are improved. The left ventricular outflow tract obstruction is relieved, and the blood flow is increased compared with the pre-operation. These images occurred after 2 years indicate the patient is getting back to normal after performing liver procedure. The patient's quality of life has improved a lot. New York Heart Association class has improved from 3 to 1. Comparing with these results of pre-operation, 6-minute walk test is increased from 440 to 499 meters, and the stress echo shows that the total exercise minutes and mass is significantly improved. She was excited to share her treatment experience with other HCM patients. The interesting part was that the patient's preoperative ECG showed complete right bundle branch block, but during the follow-up of 6 months to 2 years after the procedure, the complete RBBB disappeared and the ECG returned to normal. By now, our team has finished 275 cases with liver procedure. Most patients get discharged from hospital soon and have a good quality of life. Our patients are from 28 provinces and autonomous regions and Hong Kong. The data recorded our 15 patients which have shown LVOT peak grading at rest decreased from 88 to 11, and LVOT peak grading with provocation from 117 to 25. The maximum symptom thickness is reduced from 25 to 14 millimeter. Mitral regurgitation is reduced from 4.3 to 0.5 milliliter. Stress echo showed the total exercise time is increased. The research was published in JACS. Professor Martin Liang and Professor Hsiung came to our operation room, and they gave us highly apprised of the contribution to the treatment of HCM. Transthoracic echocardiography guided percutaneous intramyocardial septal radiofrequency ablation (HEMISRA) was named after Liwen Procedure in Eurointervention and Chinese Journal of Cardiology. Liwen Procedure is protected by PCT. We are the PI to lead 12 domestic hospitals engaging in multi-center clinical research of Liwen Procedure. We are the only HCM team registered in China and American clinical trials for the interventional research of percutaneous intramyocardial treatment of hypertrophic cardiomyopathy. We also did further research to prove the efficacy of Liwen Procedure with the results of 30 HCM patients over 1 year follow-up. It indicates that LVOT peak gradient at rest is decreased from 93 to 11.6 mm of mercury. LVOT peak gradient and provocation is reduced from 135 mm of mercury to 38.8, which is required from exercise stress echo. Maximum thickness of IVS is seen from 24.6 to 15.6 mm. Left atrial volume index dropped from 50 to 39.9. Other parameters like mitral regurgitation volume, max depression of safety segment after exercise are improved. We compare the results of 1 year follow-up between Liwen Procedure group and the surgical myectomy group in our center. There are no significant differences in the baseline characteristics between the groups. Comparing with the results of surgical myectomy in our center, the patients who perform Liwen Procedure show no complications like intraoperative mortality, mitral valve repair and replacement, permanent pacemaker implantation, stroke, complete left bundle branch block, and ventricular septal rupture. Transfusion volume is 0 mm. The hospital stay is significantly shortened also, and the cost of treatment is much cheaper. Of course, we also have complications. Our 2 patients suddenly had a cardiac death 1 week and 3 days after the procedure, respectively. Another 3 patients required small incision for hemostasis. LVOT peak gradient at rest, max thickness of IVS, and mitral regurgitation volume are similar in Liwen Procedure group and the surgical myectomy group for the results of 1 year follow-up in our center. So, the data indicates similar efficacy between these 2 groups. There are much things the approach can do. It not only treats HCM patients, but also performs intramyocardial biopsy and the treatment of cardiac tumor. By now, we have performed 9 cases of cardiac tumor and 40 cases of intramyocardial biopsy with Liwen procedure. I believe it can be applied to other treatment of cardiac disorders soon. We invent Liwen RF equipment to perform accurately, which provides us with adjustable energy to protect our patients during the ablation. We completed 120 cases of HCM with this new equipment. Moreover, it has a special made needle to take intramyocardial tissue out. And then I will give you a case to explain how we perform intramyocardial biopsy with the new equipment. This is a male patient, 38 years old. He was diagnosed at Hao Wang in a local hospital with chest tenderness and breathless in 2001. His symptoms were worsened. LVOT peak grading with provocation was 53 mm mercury. New York Heart Association is class 3. We did intramyocardial biopsy for him. The first step is we percutaneously and transathletically inserted the biopsy needle to the hypertrophied IVIs under the guidance of echo. And then we press the button to light the biopsy needle into the myocardium, which helps us take the myocardial tissue out. This is a 2 cm myocardial tissue that we took from this patient. Lastly, we removed the myocardial tissue from the needle and sent it to the pathology lab. Before we perform the procedure to the patient, the severe fibrosis in the window of IVS was shown on CMR. And we took myocardial tissues in the same area during the procedure. The pathology results suggest a lot of fibrosis. We continuously perform intramyocardial biopsy on 3 patients and found all patients with low risk of ICD. The score of ICDI of the 3rd patient is only 2.14. But he is very symptomatic. We found both CMR and the result of biopsy showed a lot of biopsy. Myocardial biopsy is also an important predictor of high risk in patients with HCM. So the intramyocardial biopsy can help us make a better evaluation of the risk of ICD of patients. Liwen procedure can be summarized as a new approach of treating and diagnosing cardiac disease without open heart surgery and not passing through blood vessels that can. Good morning, everyone. It is great honor to give you this presentation. I'm Liwen Liu from Xi'an, China. Unfortunately,
88
it
to
had
11.
less complications and
Max Simpson. This is a male patient.
let me tell you the indication of Liwen procedure.
So the intraoperative disease without open heart surgery and not passing through blood with hypertrophic cardiovascular.
Diagnosed with hypertrophic
Severe symptoms refractory to medical treatment
grading and rest
or intolerable to the side effects of medicine.
50 millimeter mercury.
By now, over 6,000 HCM patients are in our center, and more than 2,000 HCM families. We have completed 275 cases of
refractory
HCM.
to medical treatment.
This is our Xijing HCM team,
of medicine.
including 3 clinical treatment groups, 1 stress echo group,
Over 6,000
Jeng consulting group,
our center.
nursing group, and our new group
Families.
that formed this
We
year,
have completed
supervision group.
275 cases of
We work in unity and collaboration
HCM
to
team,
treat HCM patients.
including 3 clinical treatment groups, 1 stress echo group.
This picture was taken in the complication of 200 patients.
Nursing group.
Of course, the success can never be achieved by one person,
Supervision group.
but with help of our strong
We
team.
work in unity.
Please allow me to show the photo of our members in our department.
Collaboration.
I can't make this achievement without their support. I'm appreciative to all efforts of our research group and the department.
Patients. Of course,
Thank you very much for your attention.
achieved by one person, but with help of our strong team. Please allow me to show the photo of our members in our department. I can't make this achievement without their support. I'm appreciative to all efforts of our research group and the department. Thank you very much for your attention.
Okay, thank you very much, Professor Liu, for your excellent talk. And because of the time strain, we can allow only one short question from Professor Xie.
Okay, Professor Liu, thank you very much for your very excellent speech and congratulations. Your very good preliminary result from this Liwen procedure. So I think this procedure idea is very novel and very good. So from the preliminary results show the relative effective and safe regarding this procedure. But it also can be applied to other scenarios, just like a cardiac tumor or biopsy. But I think the long-term follow-up is needed because, as we know, the alcohol septal ablation and pressure gradient will be regained after long-term follow-up. So we will keep on this long-term result. And again, thank you very much for your very excellent speech and study. Thank you very much. Thank you.
Okay, Dr. Schaff is still there. Do you have any comment?
Yes. Thank you. Thank you. Your good question. Liwen procedure, I think need maybe 10 years or more than 10 years to get great database. So need to approve something.
Okay, thank you very much. Let's finish this talk. And the last talk of this session will be delivered by Professor Jeng Linderbaum. Jen Linderbaum was graduated from University of Iowa and got her master's degree from Winova State University in 1997. Since then, she worked as a cardiovascular NP at the Division of Cardiovascular Disease at Mayo Clinic and devoted herself in many clinical programs. Currently, she is the clinical practice director of Department of Cardiovascular Disease and Structural Heart Disease of Mayo Clinic. And she is also associate professor of medicine at Mayo Clinic College of Medicine and Science. Let's welcome Professor Jen Linderbaum to deliver a talk regarding special team-based care, the heart team approach for hypertrophic cardiomyopathy.
Good day. I'm Jane Linderbaum. I'm pleased to participate with this expert panel, and I'm going to speak with you a little bit on special team-based care, the heart team approach to our patients with hypertrophic cardiomyopathy. We're going to cover 3 short objectives. First, to identify roles in team-based care in the delivery for patients with hypertrophic cardiomyopathy, and how do we document and describe our work in comprehensive, authentic, shared decision-making with patients and their families. And finally, how can we optimize and engage the collaborative expertise across the spectrum of care delivery? So our experts have weighed in before me. Dr. Steve Ommen talked to us about the new guideline that was just released in 2020 for the care and treatment of patients with hypertrophic cardiomyopathy. The clinical evaluation of patients was described expertly by Dr. Rick Nishimura, and Dr. Grace Lynn talked with us about the contemporary imaging of our patients with hypertrophic cardiomyopathy. Next, we went over risk stratification for sudden cardiac death with Dr. Cha, and Dr. Schaff expertly reviewed with us surgical therapies for hypertrophic cardiomyopathy. And finally, Dr. Liu went over septal ablation and catheter therapies for patients with hypertrophic cardiomyopathy. So putting it all together, we need to think about how our general heart teams work closely with our hypertrophic cardiomyopathy centers in the diagnosis and management, and certainly testing for these groups of patients. And certainly comprehensive hypertrophic cardiomyopathy centers, provide for us advanced treatment, surgical therapies, and certainly research involvement for our patients with hypertrophic cardiomyopathy. So let's apply this to a case of a 55-year-old woman with hypertrophic cardiomyopathy. And she has a 10-year history, and she's had 2 recent episodes of paroxysmal atrial fibrillation, lasting between 30 and 60 minutes, both spontaneously terminating. During the episode, she describes to you palpitations, shortness of breath, and fatigue. Baseline, she has stable Class 3 exertional symptoms of dyspnea when she's been in sinus rhythm in the past. And she does have a labile left ventricular outflow gradient of about 30 millimeters of mercury at rest. She has no known history of hypertension, heart failure, or prior embolic events. She has no peripheral vascular disease or diabetes, and she's been started on low-dose amiodarone at about 200 milligrams per day. What is the recommended anticoagulation therapy for this patient? A direct oral anticoagulant or vitamin K antagonist. B, aspirin full strength at 325 milligrams per day. C, aspirin low dose at 81 milligrams and clopidogrel 75 milligrams per day. D, prasugrel at 10 milligrams per day. Or E, none of the above. Think about your answer. The best answer is A, a direct oral anticoagulant or vitamin K antagonist. And we think about the teaching points for this woman with hypertrophic cardiomyopathy and atrial fibrillation. We know that patients with hypertrophic cardiomyopathy remain at an increased risk for thromboembolic events. These patients have a ratio for stroke of over 17:1. The incidence of thromboembolism in this population of patients with both hypertrophic cardiomyopathy and atrial fibrillation is increased, and anticoagulation, importantly, is indicated independent of their CHADS-2 VASC score. New in the 2020 guidelines and outlined by us with Dr. Ommen is that direct oral anticoagulants should now be considered as the first-line anticoagulant option, followed next by warfarin. And finally, team-based care and shared decision-making remains integral to our patients with hypertrophic cardiomyopathy. Certainly, medication adherence, activity, lifestyle, all of those factors really are important in our partnership with our patients and their management. So when we talk about shared decision-making, it's difficult in a busy clinic calendar to have authentic shared decision-making and discussion with patients and have them central to their care and participating in their care. I've linked here the Mayo Clinic Shared Decision-Making National Resource Center, which outlines how to provide shared decision-making, some tips, tricks, and tools, as well as video interactions of actual physicians and care team members having discussions with patients and family members. Flashback to 2011 and our initial most recent guideline for hypertrophic cardiomyopathy, and fast forward ahead now to our 2020 guideline, which has significant emphasis on shared decision-making with our patients. When we think about the care discussions in our integrated team, our busy clinical practice sometimes make this difficult and time-consuming. As we think about optimizing care, we do want our patient at the center of their care. Some of the important decisions these patients need to make with their care team, including risk stratification for sudden death, what their functional limitations are, and what is acceptable to the patient versus what are their goals and needs and wants in their care. Atrial fibrillation, for example, the patient in our case study, some patients tolerate this better than others, and that is certainly a factor that needs to be considered in optimizing patients' care. Signs and symptoms of heart failure can contribute to overall functional limitations, and certainly any risk of thromboembolism and consequences are important to patients and family members, and decisions regarding anticoagulation and patients' adherence to regimens are important for them to have an overall optimized experience and understanding of their care plan. When we think about shared decision-making, there's many factors that fall paramount for these patients, specifically genetic testing, education for the patient and family screening, as well as symptoms, sudden cardiac death risk assessment, treatment options, both medical and invasive, including surgical options, and finally participation in competitive and high-intensity activities. Most patients and families with hypertrophic cardiomyopathy are familiar with some, but maybe not all of these important factors that impact their care. Here's another shared decision-making tool. On the left panel, you'll see the hypertrophic cardiomyopathy app, and within that hypertrophic cardiomyopathy app, you'll note the hypertrophic cardiomyopathy shared decision-making calculator. In this sudden cardiac risk assessment calculator, you can individualize this for the patient you're seeing. You'll put in their personal information from their echo report and information you know from their clinical examination. This calculates a sudden cardiac death at 5-year percentage risk score at 6.45 in the patient listed here. Finally, at the bottom in the recommendations section, it'll give you, based on the sudden cardiac death risk factors present, This patient has a Class 2A indication for ICD. And as we think about this, this is a great opportunity for us to actually view this with the patient at the time of the clinical exam and understand with them their knowledge, their beliefs, their priorities, and next steps. When we think about shared decision-making, it's important to understand specifically the risks and benefits of our discussions, what we think are anticipated outcomes based on our clinical knowledge, expertise, and experience, and certainly the patient preferences, goals, and concerns are of utmost importance. Importantly, a red flag thing for all of us caring for these patients include the documentation of the discussion, the risks and benefits present on today's examination and discussion, what we anticipate for outcomes, if in fact the discussion has resulted in a decision, if the patient has a preference, which may or may not be different from the family's preference, and who was present during this discussion. If we're able to document what happens during our discussion and the patient's preferences, that will be helpful not only to the patient, but also to the family, and will often set a nice foundation and groundwork for your next encounter with the patient. So in summary today, we have talked about roles for team-based care delivery for patients with hypertrophic cardiomyopathy. And in the setting where we're seeing more patients on a daily basis, we are forever obligated to work in a team-based dynamic where we can optimize the role of each care team member, including our genetic counselors, our pharmacists, our nursing colleagues, our physician colleagues, our subspecialty colleagues, and our surgical colleagues. We know that the collaborative expertise in our general care areas, our hypertrophic cardiomyopathy centers, and our centers of excellence for high-volume care and surgical expertise will remain important. We know that throughout the continuum, the patients may move across and between these centers, and our collaboration and expertise is important to optimize the care for these patients. And finally, we need to be able to describe and document our discussions and shared decision-making with our patients, and then have in place for patients our screening and surveillance moving forward, so that if their symptoms change or if their family conditions change, they're able to reach back to the hypertrophic cardiomyopathy care team.
Okay, thank you, Jen.
At this point, I'd like to open for questions and discussion for myself or speakers that came before me, and I thank you in advance for the opportunity to participate in this forum. Thank you.
Thank you. Jen, thank you for your excellent talk. Do you have a regular meeting or combined conference for specific patients, such as before the surgery, or choose between the treatment modality?
Yeah, that's a fantastic question, and we do have the opportunity to interact on a daily basis as needed on patient scenarios. And in fact, sometimes we arrange some of the testing before the patients actually arrive, and we have discussions on imaging prior to the clinical examination of the patient and sometimes thereafter as well.
Thank you. Any other question or comment? Okay, if not, I would like to invite Professor Wei to say a few words for this session.
Okay, thank you, all the panelists and especially the Mayo Clinic team. Here, I would like to thank all of you, especially the Mayo Clinic team, because you are already at about midnight and you still keep awake at this time. And I would like to express my thanks to all the members, especially Dr. Schaff. Your team is the world-renowned team of the HCM treatment. So I appreciate all your lectures given today, and I'd like to say goodnight to all of you. Also, I'd like to thank Dr. Liwen from Xijing Hospital. And in the afternoon, we will have some more talks about the HCM, and these include our invited professors like Hao Wang from Fuwai Hospital, and also Yang Jian from Xijing Hospital. We are expecting to your talk in the afternoon. So I appreciate all your enormous experience in HCM, and which made the treatment for the HCM much improved today. So I think that you all have a very, very good contribution to the therapy for this kind of patient. In the past, these patients may passed away, and this is very good chance for us to meet here together and to share our experiences. So I think this is what I want to say. Thank you again, everybody. So thank you again, our Mayo Clinic team, and good night. Thank you.
Thank you. Our pleasure.
Thank you.
Thank you very much.
线上，我会把我们 Panelists 跟大家都介绍。跟我举牌。
你40，有点30。哦，
现在都是中文的吗？对，是的。
是中文吗？
上脸的镜头就是那个谁，看体脂板镜头就是这个。
我的滑鼠。然后2个叶子。所以如果。我有时候要指，我有时候要指，我要指那个指。对对对，所以我这样。这张有点快，有点点。
好，大家午安。接下来这一部分的话，主要是海峡两岸的专家会谈。那我先介绍我们这边的成员，我是振兴医院心脏内科黄建龙医师。那在我右手边的呢，是大家都很熟悉的我们心脏超音波的老师那个熊明生主任。那再来的话呢，是我们心脏血管外科庄义成主任。那再来的话呢，是我们心脏内科的也是我们振兴医院那个资讯部的陈主任陈冠群主任。那在线上的话呢，我们会邀请那个在西京医院，刚才大家有听过他精彩的演讲，就是刘立文教授，等一下也会跟我们参与一起讨论。另外，我们还有邀请阜外医院的那王教授，他等一下也会为我们带来一个精彩的演讲。那我们这个 section 的话呢，主要是谈影像医学在 HCM 诊断的还有治疗上的应用。那今天很荣幸，总共邀请到4位的专家，主讲4个不同的影像医学的观点。那首先的话呢，第一位的话呢是吴美汉主任。那吴主任的话呢，他毕业于阳明大学医学系。那在2003年到04年的时候的话呢，有到美国加州大学旧金山分校 ECS 进修。那16年的话呢，接任台北荣民总医院胸腔循环放射科的主任。那目前的话呢，是我们振兴医院一般放射科的主任，同时也是阳明大学兼任的助理教授。那今天的话呢，他首先为我们带来 MRI 的观点。吴主任，请。
各位大家好，我是振兴医院吴美汉医师啊，我有很荣幸能够来这边讲这个题目，其实是跟大家有点是读书报告这样子哦，那也趁机分享一下我看过刚好来振兴刚好2年哦，那刚好有一些影像上我也是原来我也是不懂啊，然后我又慢慢看，然后一边查那一边学，所以我想说趁机跟大家分享我的经验还有心得这样。那先开始来介绍HCM， 我们就是用 Hypertrophic Cardiomyopathy， 我们就简称 HCM 好了哈。那前面的老师跟专家都已经讲过了 ，HCM 的定义就是说它在diastolic phase 的ventricle wall 大于15 mm， 要排除其他原因哈。那另外的诊断就是它如果是symmetric 就是 septa 比较 posterior wall thickness 大于 1.3 哈。那刚刚也是老师跟教授都有提过的，如果说它是那个家族史的话，1等亲，它的criteria 就松一点，大于等于13 mm 就可以。那如果是小朋友的话，如果是18岁以上，大概是用这个 criteria， 就是家族成员。那如果那个18岁以下的话 ，Z-score 有的是写3.5的是到那个用 body surface area 来除，然后那有的用3.5，有的用2.5，我觉得这可能看 criteria 怎么定这样子哈。那它的那个基因上哈，这个其实就是它是一个那个autosomal dominant 哈，那最主要是跟一个 sarcomere 有关系，而且 sarcomere 是一个肌肉收缩的一个 functional unit 哈，那这个 sarcomere 它跟CV 的底子也很多有关联，譬如说 dilated cardiomyopathy， 它另外就是 retreated cardiomyopathy， 还有就是 LV 的 non-compaction 哈。那另外它有一些成分啊，就是说它这些那个这些 tropomyosin 啊 troponin 啊，或是那个myosin 哈，都是这些sarcomere 的 critical protein 这样子。那它的 HCM 刚刚教授也讲过很多，它的遗传学上就很多的变异哈，它最常见是这个基因哈，就是在30到40% 有在 chromosome 11有这个基因。那另外它刚刚提过它是autosomal dominant， 那跟它的年纪有关系，就是比较年轻的时候表现会比较少啊，到年纪大就越来越多。所以这次有一句话有人提到，不过我们医院其实有经验，就是也有10岁的小朋友，他还是有怀疑是 sarcomere 的 HCM 哈，那一般是青春期以前是比较少见的哈。那它的那个病理上的发现就是这是我们的正常的LV 的 myocardium， 那一般就是在这个 septum 这个地方会变厚哈，那这边就是比较大的gross presage 哈，那定义上还是差不多，就是说它的wall 要厚，那正常可能有人用12，然后那就是我们用15 mm 这样子。那个另外它会合并右心的 hypertrophy 哈，那病理上的诊断就是说它在这个标本里面要myocardium 的 disarray 要至少5到10% 哈，那 原则上是这样哈。那它的显微镜下的观点其实很多哈，大概提过就是 myofibrillary 的 disarray 啊，另外还有冠状动脉的小血管的变化哈啊，另外就是它 interstitial 的 fibrosis 哈，也要有时候看那个病理的报告会看到这样子的叙述哈啊，另外就是比较常见的就是这些那个mitral valve 的anomaly， 刚刚都有提到哈，就是前面的专家都提过，譬如说它的 pulmonary muscle 的 insertion 或是它的 leaflet 有没有什么变异哈？那另外就是它会造成outflow tract 的obstruction， 造成 gradient 这样子。好，那这是刚刚大致介绍 HCM 哈。那另外就是我们的影像上哈，那其实刚刚专家Grace Lin 都有提到，超音波其实是不可取代的，而且是很重要的。我刚刚听这些 mitral valve 跟 pulmonary muscle， 我们 MRI 还是解像力没有那么好了哈，所以我觉得是没有办法取代。不过 MRI 有一些加成的效果哈。那它的那个临床的意义哈，就是说，对不确定诊断的哈，不确定诊断就是它可以比超音波有某个角度上去确定 left ventricular hypertrophy 的定义上啊，另外就是不确定的去排除其他的诊断哈，这是不确定的。那如果说临床已经确定的话，它就是可以找出 high risk feature 哈，就是 high risk 这些 LV 的变大变厚啊，或是说它有那个apical aneurysm 之类的哈，还另外就是它提供在治疗上的处置的方向，譬如看它的 phenotype， 它哪里有肥厚啊，另外那个你要在哪里有 obstruction 啊，另外就是 mitral valve 的 anatomy 也是可以提供哦。所以我们稍微介绍一下 MRI 的 technique 哈，那其实这个都是一般的 routine 哈，我们大概有一个 break blood spin echo， 那大概就是做一些简单的，不过这个就是要 EKG gated 的来做 T1 T2 的 image 哈啊，另外它有一个 gradient 或是 white blood， 就是一般就是在 paper 上常提到 SSFP 哈，就是可以做 Xinin 哈 ，Xinin 就是做一些动态的影像这样子哈。那做完这个我们的full chamber view 垂直的 short axis view 哈，然后就是要做一些 ventricular function 哈。那 ventricular function 我们就是找出 diastolic phase 跟 systolic phase， 然后就去画它 endocardium 跟 epicardium border， 然后这个就相减哈 Simpson row 减起来就是的 myocardial mass。那 RV 跟RV 也是一样，找出它的 end diastole 跟 end systole 去相减就是哈。那要算它的要不要算 pulmonary muscle 哈？那其实有些institute 就看我们看原则上理论上是要把它分开啦。不过有些 paper 就是说，我们只要我们这个 site 都是固定同样的画法来追踪，我觉得就可以了。所以原则上是这样子哈。那当然就是 ventricular function MRI 会比超音波比RV 有它的比较有它的优势这样哦。那另外比较常用到的是 LGE 哈，就是 leg galvanic enhancement 啊，大概就是它原理上就是如果说它这个 interstitial 或者 extracellular fluid 的extracellular space 有什么样的问题的话，有变化的话，这个 contrast 就会leakage 或是 static 在这个 space 里面。那我们一般的 myocardium 它就会 wash out 哈，所以如果说是正常的话，它在这个sequence 它 myocardium 正常是黑的，那如果说 enhancement 它就会变亮这样子哈。那不同的疾病有不同的 enhanced 的 pattern 这样子。那这是我们医院的case 哈，就是这是 short axis view 哈。那正常的那个 LV 的 myocardium 应该是黑的哈。那这是那个hypertrophic cardiomyopathy HCM 的病人，我们可以看到这边有一些亮点哈，有的亮点。那这个就是常见那个 typical 的位置哈 ，right ventricular insertion site 在这个地方跟这个地方，这是最常见 HCM enhance 的地方。那常常都会合并，它 hypertrophy 的地方会比较enhance 哦，有时候会比较淡一点哦。这个也是我觉得我目前还是要在学习的地方哦。那它的 fortune view 可以看到这个地方哦，就是它有 enhancement 这样子哦，就是 LGE 哦，这是一般 typical 的 LGE。那另外常用到的是 T1 T2 mile map 啊，不过这个因为有些机器要新的机器哦才会配备哈，所以有些 paper 慢慢的出来哈。不过大概就是一般的 T1 高的话，都是它 fibrosis information 都会高哈。那 T2 就是最主要是看它有没有水肿，那发炎比较常用的是 T2 的 image 这样子哈。那另外 T1 还有一个 pre-contrast， 就是 native 的 T1， 还有 post-contrast T1， 然后它有一些数值上去算算 ECV， 那慢慢的很多 paper 都会提到这个那不过这些 T1 native T1 这个要跟每个 site 每一台机器都要做一个 normal value， 所以一般是说 ECV 会比较客观一点那这是我们 T1 跟 ECV 的map， 我们可以看到正常在这里那一般的发炎或是疾病都会T1 都会高那只有脂肪或是 fibrin 或 iron 这个会低那一般的 ECV 是都变高的。好，那我们接下来看它MRI 在不确定诊断的 HCM 它的临床的角色就是刚刚各位专家或是大家都提到的问题，就是说我们去怎么样去区别这些by exclusion 嘛，就是要排除其他的疾病，我们怎么样去排除其他疾病那第一个，我们是先确定它是 hypertrophy， 确定它的 LV 的 wall 是厚的那这是有一篇 paper， 其实小小的 paper它就是40个 sarcomere mutation 的 carrier， 它还没确定变厚的就是那样比较小、比较年轻的族群大概21岁然后它的 criteria 是12 mm 或者 z-score 小于 2.5 的小朋友那同时去做CMR 跟 echo， 可以发现说 CMR 跟 echo 的 agreement 其实是还蛮高的不过有40几个里面有4位他在那个 echo 觉得还是蛮正常，不过 CMR 已经开始在变厚了所以它其实是比较 sensitive 那另外 follow 以后这些病人就是慢慢变厚了，所以他如果是看ventricular definition 的话，应该是 CMR 会比较有一些优势那我们接下来看一下 HCM 的一些 morphology classification， 这牵涉到我们等一下的那个鉴别诊断那这个其实也是我觉得有点我觉得个人有点困扰的就是说简单的就是 septa， 就是这是 RV LV RA LA 这是 septum 那简单的就是 septum 的 hypertrophy 就是前面anterior 比较厚posterior 比较薄这是 asymmetric 的所以这个刚刚教授都有讲过 asymmetric 的机会比较大，60%到70%那另外一种是 symmetric 或是 concentric 就是说我们如果做 cross section 沿着 shoelaces 可以看到它是一整圈都是均匀的变厚的，这是 concentric， 那这个会比较多一点。那比较少一点的是 apex apex 就是在那个在 apex 这个地方变厚这样子另外还有一种就是 mid ventricular 或是 mid cavity 的 hypertrophy， 它是在中间变厚，然后旁边就是像哑铃一样所以这两样比较少一点，所以我们先用这两个来做 definition那 concentric 的那所以我们的 CMR 的角色就是排除一些 mimic 就是一些 mimic， 这是 paper 上写，这个比较简单好。第一个我们来看是 concentric left ventricular wall 的 thickening， 就是说它的那个 LV 的 wall 是对称的变厚这样子那第一个刚刚大家的问题就是说跟运动员的心脏如何来做区分那这位20岁的那个长跑那个 runner 他的 LV 其实是变厚的还是变厚的，可是它是 concentric， 不过它的这个变厚它是不会那么厚了因为 usually 是 mild 是比较小一点另外它的 LV 的 volume它是变大的那是变大的，那我们 HCM 的 volume 是变小的另外它就是去量它的 ventricular 的 diameter 那正常是55 mm， 那一般这些人这些运动选手会稍微高一点另外还有一些 criteria 去量它 left ventricular and diastolic 的wall thickness 去除它的 volume 它另外会去除它的 mass 这个有一些数字上好像有一些统计上的意义那另外它的 ECV 是降低的，我们刚刚讲的就是一般我们的 HCM ECV 是升高的那另外就是说它还有一个诊断的 criteria， 就是说这些运动选手你让他不要训练3个月以后这个 LV 的 wall 就会变薄，会降个2到5 mm那 LV 的 diameter 会变成正常这是那个一般的运动员的心脏的做 definition第二个就是常见就是高血压性心脏这个也是它是因为它 effort load 增加，然后造成它的pump 的力量要变大 所以它可能会就是会 concentric 整个均匀的变厚。它也是跟那个运动员的心脏一样，它会变厚，可是一般不会那么厚那它的 chamber 也是变大，可是它最后它的 EF 会被下降的那它的原则上它是它的 LG 理论上是没有 LG 或是没有那么明显这样子那就是 paper 上一位67岁的男性是他有 hypertension， 他还是LA 年纪大了 LA 有变大可是他没有明显的 LGE 这是那个高血型心脏病另外就是我们常见的就是也是一样那个 aortic stenosis 它也是那个overload pressure overload 那它的原则上是它也会变厚啦它也会变厚有时候其实也蛮厚，不太好分别那就是变厚以后它的心肌会一些纤维化，然后 hypertrophy， 然后到最后的 heart failure 它的 LG 它的那个的 intense 地方不太一样那另外就是看它的 Xini 就是它的那个它是沿着 valve 往上，然后另外这些 aortic stenosis 的病人，他常常他的 diameter 会变大那另外它的 LG 是没有 enhance， 那Holcomb 的病人常常是在厚的地方会 enhance， 而且在 mid wall 这样子另外常见的是 amyloidosis amyloidosis 它是 extracellular 的 deposition amyloid 那它常常会合并 pericardial effusion另外就是另外就是 RA 或者是 LA 也会变厚这样，那另外它有 enhance 会比较不一样那这是我们的 case 它也是一样，也是有 prior effusion 有 pericardial effusion， 那它的 LG 理论上paper 上会说它是 nulling 的，不太跟其他不一样，常常都变整个 chamber 会变黑，然后endocardial enhancement。不过我们这个 case 没有非常明显，这是 tissue proof 的另外就是Fabry disease 它是 symmetric 的，那不过它的 enhance 地方是在inferior lateral wall 那enhance 的地方会跟Holcomb 不太一样那这是我们的怀疑的 case 也是一样，它 enhance 在那个 inferior lateral wall 这样子。那另外 sarcoidosis 是一种 inflammation 它大概就是acute ET2 会升高，那另外它的 enhance 会在 epicardium， 那有时候 RV 也会enhance。另外就是Sombers 这个 echo 不好看，可是我们是 MRI 很好看。那 non-compassion 其实 MRI 也是很明显的看到它的 trabulation 是变厚的。那这个 echo 上有时候会比较有困难，不过这个跟经验有关系。那另外这个是 endomyocardial fibrosis 那它可能就是会有一些 enhancement， 它 enhance 它有时候它会有一些 Sombers， 然后 endocardium 会 enhancement， 所以一个 triple layer 这样子。那如果是确定诊断的那我们刚刚讲的这是这个 type 这是我常常打报告的时候要拿出来参考的，就是把它分得比较细一点的那它可能就是 normal， 可是 normal 的跟那个它 burn out 的时候，有时候就会都是一样的，可是它这个 burn out 的时候 EF 是下降的那另外看它哪一个地方厚，然后septum 是哪里比较厚，这样子有不同的 phenotype 那诊断上这个是大概就是看它的 pulmonary muscle 的 insertion， 那另外就是 SAM， 那另外就LGE 的位置这个是典型的。那我们的 case 也是差不多就是在 subaortic stenosis 有 jet， 那另外这个stoasis 这个地方是 anterior 比较厚那它的 LG 也是有一些比较亮点，可是有一些比较淡的。那这个是它一般都是它 hypertrophy 的地方会比较厚一点那 LV 的 obstruction 或是 MR， 这个可能就是有一个是 SAM， 这个其实我觉得我比较有困难的不过我觉得我大概都是看到它 aortic 跟 mitral jet， 然后 posterior， 然后这个地方有黑黑的，然后我大概就会跟他想说可能是 MR 这样子。那这个是我们的 case， 他可以看到就是这是 aortic stenosis， stenosis， 那这是那个 MR 那大概这个 MR 的 flow 这个 jet 会比 aortic stenosis 稍微晚一点那这个是 paper 上在讲说，它如果比较早的话，就是或是说它 direction 是向前的，不是向后的话，那就是要处理 mitral valve， 不是只有 Holcomb 的问题造成的。那如果是 concentric， 这个大概就是 我们的 case 也是差不多哈，它就是很均匀哈。那我们的 case 是因为我们打了药以后都会在因为要利用时间，所以打药做 Cine， 所以常常打了药很快这个 LG 还没有 late 很 early 的时候就 enhancement 了，然后它大概是 LG 大概就是一些 patch 的mid-word 的 enhancement 哦。这么年轻啊，那apical 的 hypertrophy 大概就是诊断上，这个我觉得也是有困难的哈。apex 这个地方厚，然后它定义上是 apex 比 basal 这个地方的厚度，就是13、17比到1跟2大于1.3哈。那我们东方人比较常见哈，那常常都会合并 apical 的 aneurysm 哈。啊，这是我们的 case 哈。那不过这个有时候有点困难，我觉得有点困难。那 mid-ventricular 刚刚有提过哈，它常常都是 obstruction 在中间，有 pressure gradient， 它常常造成 apical aneurysm， 然后合并了thrombus。那有时候我们打报告的时候还要评估 RV 我们 involvement， 大概有将近20哦。那刚刚Christine 老师讲的RV 的 word 大于8 minute， 我看到 paper 是6啦，所以可能也是看那个不同的参考资料这样。那另外有一些 preclinical 这些 crypt， 这个我觉得如果我们的 size 比较厚，可能会不好看。那就是我们打报告的时候特别要注意，就是 LV 的 word thickness。那pressure gradient， 我觉得我们 MRI 常常会 underestimate。我们其实有做face contrast 的 quantifiable flow 的评估那可是我们的 peak velocity 都有点低，所以我都没有特别去打它。另外看 LGE， 另外看它 EF， 然后看 apical aneurysm， 所以我觉得我们这些是可以评估的是这4个。那这是我们的经验就是它常常就是在 anterior wall， 然后有 enhancement， 然后会合并，它其实 pulmonary muscle 其实是有 involved 的那另外就是有个我们有一个我那时候也是不太有经验那就是它这个地方 apex 有一个 aneurysm那其实有时候跟ischemic heart disease 自己要做 differential 那不过这位先生他其实他的 coronary artery 的 CTA 是正常的那所以LG 它的extent 跟它的 prognosis 是有关系的那这是比较新的 paper， 它是LG 的比例大概300多个人有82%的人会有 LG， 大部分在 mid LV 的 septum那 follow 了一段时间那大概就是 LG 你可以用半定量你只是说把它分作13个 segment 这样子分4个象限 anterior septal inferior lateral， 然后来看有 enhancement 的就有一个 segment， 大于4个 segment 它大概就是 independent predictor。那另外当然也是可以用定量的大于10%几这样子来做区分，不过它是这个半定量跟定量其实都是跟它的 extent 跟它 prognosis 有关系那治疗以后就是看 ablation那 ablation 这个大概就像一个 infarct LG 有一些 enhancement， 那另外就是打完以后它常常这个地方会变薄那这是我们的经验我也是刚开始打的时候我也是不太清楚那就是这是一个HCM 的病人，他做完以后这是在 apex 这个地方就有 enhancement所以那时候我就想说他是不是合并有 ischemic heart disease， 因为他是 transmural 的，后来我才发现说paper 上其实就是有因为外科医师从这边开刀进来的所以这个是因为开刀他的开刀的配置应该在这里那这是我们的经验分享就是做完这是原来有 enhancement， 然后这个是anterior wall enhancement， 那做完以后它的 mass 就变小，不过这个地方就是开刀造成的那 CT 上它就是对于没有办法进 MRI 比如说他有 pacemaker 或者是 deep brain 的 stimulate 的病人可能是有帮助的他看 morphology 我觉得是没问题的不过他相对他没有办法做 LGE， 那比较不好看他的 jet 都是他的gradient 的地方那另外 T1、T2 跟 map 这个比较没有办法看另外他有 radiation 的问题所以他就是相对的没有 MRI 这么重要另外就是CT 来做对 HCM 的病人他就是可以做 CTA 然后评估septal 的 artery 的 anatomy， 我觉得也还不错这样 那以后还可以做的，我觉得以后如果说每一个都有配备 T1 T2 map 的话，可能会比较好去评估differential diagnosis。那另外还有人做 fractional analysis， 就是评估它的 tribulation 的量，然后跟它 prognosis 是有关系的哈。所以我的那个 take home message 就是 MRI 最不确定的病人可以 definite 去量它，然后去 exclude differential diagnosis。那如果确定的，他可以去看他的 morphology， 评估他的high risk feature， 然后来做他治疗的评估。好，谢谢。
谢谢胡主任的介绍哈。那个不知道我们 panelists 有没有什么问题？因为时间上的话，可能有一点 behind 这个 schedule。如果没有的话呢，那我们可能因为时间关系，我们进入到下一个 section 好了。下一个 lecture， 下一个是那个刘仁贤部主任。刘主任的话，其实他的学经历非常的丰富，但因为时间关系，我们可能只能简单的介绍。他是国防医学院毕业以后的话呢，曾经到多国去进修，包括德国、加拿大还有美国等知名大学的医学中心、政治中心进修那个政治和医学。那之前的话，曾经担任国民总医院核医部的主任，那也是阳明大学临床医学研究所的教授，是我们那个第4届核子医学学会的理事长，跟那个亚洲分子影像学会联盟的理事长。目前的话呢，他是我们振兴医院核子医学部的部主任，还有政治影像中心的主任。那今天的话呢，他为我们带来的就是核医的观点。刘主任，请。
谢谢主席的介绍，很荣幸有这个机会跟大家分享核子医学在hypertrophic cardiomyopathy 有关于这个 myocardial perfusion、metabolism 跟 innovation 方面检查的心得跟经验。那么我们都知道，这个 hypertrophic cardiomyopathy 它是一个很复杂的一个疾病，除了gene的 mutation 造成一些这个myocyte 的 disarray， 还有这个血管的这个 remodeling 的问题。那它主要的关键是一个 myocardial ischemia， 然后接下来形成 fibrosis， 最后呢，它整个心肌肥厚 sudden heart failure、sudden death。在 morphological diagnosis 刚才很多专家就介绍过，我就不再重复。诊断的工具当然很多了啊。那么核子医学的影像，第一个，它还是可以去评估 systolic diastolic function， 那这个现在都是这个阿多上来取代了。那么再来就是关于 myocardial ischemia， 那这里头其中一个比较关键或比较重要的就是PET positron emission tomography 正子断层扫描，在这个 microvascular dysfunction 的角色是蛮重要的。那么再来一个就是关于这个 sympathetic 跟 myocardial innervation， 那最后就是 cardiac amyloidosis 我陆续会跟各位介绍。那么这个在评估 LV 的 systolic 跟 diastolic function 超音波或者是 MR 都非常的好。那核医当然也有这个角色那不是这非常重要，是 complementary。除了 ejection fraction， 它对这个 diastolic function、systolic function 都可以做评估。那么其次是在这个 LVOT obstruction 的 case， 它都出现 heart failure， 或者是在治疗过后，比如说这个 alcohol 的这个 ablation， 或者是这个 myomectomy， 治疗过后这个心肌的这个 perfusion 的变化这是可以来帮忙的。比如说这个例子，治疗前看到这个 septum hypertrophy， 治疗以后的这个 perfusion 降低，然后有没有恢复可以去monitor 它的变化。那有一些 variation， 当然在诊断上不是很重要但是可以看到它的一个变化，像 stress 引起的 epical， 这个是这个 epical variant of the hypertrophic cardiomyopathy。在 stress 的时候，这 epical 是perfusion 降低，但是在 rest 的时候它恢复。我们在 做这个葡萄糖代谢检查，说 apical 这么大的一个 mass 啊，这葡萄糖代谢增加的。那么在没有这个 LVOT obstruction 的 case， 它有 heart failure。那么其实，在它的 myocardial perfusion 或者 metabolism 的检查，往往在早期往往会是正常的。像这个我们说 Salim 这个虽然有 septal hypertrophy， 那么 MR 也看到一些 fibrosis 的证据，但 Salim 是好的。我们看 metabolism 也还好 ，perfusion 做 PET 的这个myocardial perfusion 也是好的。可是这个时候我们做 fatty acid metabolism， 我们知道 fatty acid 的代谢是在心肌里面的 aerobic metabolism 很重要的一个 substrate。那么利用这个.123 label 的这个 fatty acid， 我们可以看到在这个 septum 它这个 aerobic metabolism 是降低的。那么这个在早期的这个 heart failure 它是有它的功用的。那么在这个HCM 里头，病人如果有 chest pain， 当然其中一个我们要看看他是不是有这个 coronary artery 的这个 obstruction。那么做 perfusion scan， 我们可以看到 reversible 或者是 irreversible 的 perfusion deficit 在这个hypertrophy 的 myocardium， 但是到底有没有这个血管阻塞？这个时候 CTA 或者是这个 angiography 就有它的重要性 ，combine 两个。知道它缺血 decrease perfusion， 但也知道 morphology 是好的，那要表示这个不是因为冠状血管阻塞，是因为它 hypertrophy 造成。如果有阻塞，那么就用阻塞的这个 algorithm 去治疗。刚才有提到就是这个 HCM 它的这个 microvascular circulation 往往是有问题的，所以在评估这 microvascular dysfunction，PET 是有它的重要性，像这个 case 这个在 hypertrophic muscle 在这个 resting 的时候，它可以看到这个 perfusion 降低，但是打了这 dipyridamole perfusion 增高，特别是在 epicardial 的 circulation 增加。那么这种有这个 the vascular dilator 的 response， 那我们叫它有这个 myocardial buffer 的这个 reserve， 这是。如果没有的话，那这个 microvascular dysfunction 就很严重那这种状况呢，它是一个HCM high risk of the cardiovascular death 的原因之一。所以利用这个 PET， 特别是有这个 dipyridamole challenge 的PET perfusion image 来看 subendocardial 的这个 myocardial 的这个perfusion insufficiency 有它的重要性。那么这种microvascular dysfunction， 它往往跟这个 myocardial scar 的多寡有关系。像这个 case， 我们在 MR 看到它有 scar 比较小，我们看到它的这个 microvascular dysfunction 范围比较少。像这个 septum 一大片这个看到它的 reversible 的这个microvascular dysfunction 的范围就是比较大，它是这个息息相关的。那这里头除了看到它的这个stress perfusion 降低之外，还有一个关键的measurement 的 parameter 就是 coronary flow reserve。那么这个 coronary flow reserve 呢，其实可以利用这个 PET 再加上一些定量的检查，去 measure the myocardium 的每一个 gram 的 tissue， 它的这个每分钟的 flow 有多少可以算出来 coronary flow reserve。那么像这个我们在image 上看不出 defect， 但是实际上定量可以看得出来。这两个 case 同样都是影像看不到什么 defect， 但是它的这个flow 一个是90几，一个就掉到30几，在这个形象学看不见。那么底下这个D 图这边有一个大的 defect，C 图只有小的 defect， 但这两个人这小 defect 它的 normal flow 只有 4%， 那么反而这个 D 图有个大的 defect， 它整个 heart normal flow 是61%，所以代表这个 defect 大小并不代表它的 coronary flow reserve 的多少。因此，特别是在HCM 的 case， 看起来是就没有什么特别的perfusion defect 的HCM case， 我们如果去测量它的 coronary flow reserve 就可以提早知道 它哪个地方的这个马卡点，它的这个 circulation， 特别是 microvascular circulation 是有问题的。那么除了这个 pollution 之外，还有 metabolism 啊，像这个 septal 的 hypertrophy stress 都是看 stress 的时候看到有这个低飞，然后这个 right heart 也看得出来啊，有 right heart 的方向也不好了。那rest 的时候它有 recovery 啊，是 reversible 的 defect。那么我们做的 metabolism 发现这个 septal 的地方，它的 glucose 的 metabolism 没有被 enhance， 也就是说它的 ischemia 啊，它并没有用葡萄糖来代偿进行 anaerobic 的 metabolism， 提供它的 energy， 所以这一块的这个马卡点的情况就比较差，预后也比较不好。那么除了一般这个临床的诊断必要的诊断之外，其实在有关于这个 HCM 的 pathophysiology， 这 PET scan 也有它的功能啊，比如说我们在这个 HCM 造成它的这个最后的 heart failure， 它有各种 intrinsic factor 有 extrinsic factor， 但是不管是 intrinsic 或者这个 extrinsic， 最后都是会造成microvascular dysfunction， 造成 ischemia， 然后再让它的这个 myocyte 的这个disarray 啊更严重 ，fibrosis 更严重，造成 dysfunction 啊，还有这个整个 heart failure。那这个关键就是在 myocardial efficiency 啊。那 myocardial efficiency 在就 PET 来讲，它可以用这个 aerobic metabolism 的 tracer 去测量它，可以计算出这个 myocardial efficiency， 可以去早期预测它会不会走到这样子的一个 virtuous cycle。啊，这个是 PET 在这个 pathophysiology 的研究上或者药物的这个evaluation 上可以提供的一个贡献。那么有关于这个 sudden cardiac death 啊，刚才很多专家都讲过。当然，它直接跟着它的 arrhythmia 是一个重要的一个现象。那它可能的原因可能是有这个 myocardial hypertrophy， 这个 fiber 的 disarray 或者是 fibrosis。那么另外一个就是sympathetic nerve 的这个的问题，有的 innervation 有问题。那么这个问题主要是来自于这个 myocyte 里面的 postsynaptic myocardial beta 2 adrenal receptor 的 downregulation。我们要观察这个 downregulation， 合意有一个 tracer 叫做.123 label 的 meta-iodo benzoylguanidine MIBG 这个 scan。那这个 MIBG 啊，它是 norepinephrine 的 analog 啊。那么它同样会被这个 beta 2 adrenergic receptor 去 uptake。那如果是有这个 autonomic 的 neural dysfunction 啊，那么它的这个 tracer 的 uptake 就会跟这个正常的不一样，它会有这个 tracer 的这个 retention， 我们可以用 scan 看出来，它整个像这个是有问题的，整个 myocardium 的 uptake 的 early 跟 late 都非常的高。有时候不是那么好看，在这个检查上面，我们会去做 early scan 跟 late scan， 然后看它这个 MIBG 的 washout， 计算它的 washout rate， 就可以知道到底有没有 autonomic 的dysfunction 啊。那这个东西除了做诊断之外，也可以做这个 outcome 的一个预测，像有很高的 uptake 这种的这个可以 predict outcome 不好。啊，那这个是正常的 outcome 比较好一点。再来一个 issue 就是这个 amyloidosis 啊。那么 amyloidosis 在临床上的诊断我就不赘述了啊。关于这个 echo 跟 EKG 的 discrepancy， 那主要是前面这个 HCM 是 myocyte 的增多，那么 cardiac amyloidosis 是 amyloid deposition。这样子的一个疾病。当然，它 gold standard 是做 biopsy， 但是在合医方面也有它的检查可以来做诊断的帮忙。我们可以用technetium label 的 bone scan agent， 像的 PYP 去做 scan， 它可以会被这个 amyloid deposit 的这个 myocardium 吸收特别是在这个transthyretin 的这个 subtype 啊。我们知道 amyloidosis 有 AL type 跟 ATTR type 啊，那特别是 ATTR 啊，这个 technetium 99 MPYP 啊，可以有很好的 uptake， 可以做区别这个 AL type 跟这个 ATTR type。那这种 uptake 随着程度不一样，我们可以分 grading 啊。那么除了这个 PET 的，除了这个 bone aging 的 imaging 检查之外，另外 PET 也可以做。我们利用这个诊断这个 Alzheimer's disease 的 amyloid deposition 的 agent， 一样可以做这个心脏扫描。如果它有 amyloid deposition， 不管是 AL type 或者 ATTR type， 都会有 uptake 啊。所以如果是用 bone agent， 我们做不出来有什么 有这个 PYP 的 deposition 在 myocardium， 但临床上又 strongly suspect 它是 amyloidosis， 那可以利用 PET 的 amyloid scan 来证实。这个 amyloid scan 啊也很有趣，它在 AL type 它的 deposition 比较高 ，ATTR 也高，但是没有 AL type 那么高，这两个似乎可以做鉴别。哦，这个有别于其他的这个 hypertrophy。那最后我再次强调，就是合一在这个 HCM 啊，主要它在 myocardial ischemia 上面，它可以帮忙做确认。那另外刚刚有提到过的关于这个 amyloidosis 跟这个MIBG scan 啊，在 innervation 还有在 amyloid deposition 上面，也可以做诊断上的帮忙，对这个 HCM 的 management 是有它的帮助的。谢谢。
非常谢谢刘主任带来那个精彩的介绍。那所以其实我们知道合一在 amyloidosis 分类的诊断上，其实占有一个非常重要的角色。那刚才听到刘主任讲说，那个 MIBG spec 啊，其实在那个 HCM 的病人对于 sudden death 的判断上，可能是不是会有一定程度的帮助？这个它有一个客观的一个方法吗？还是一个数值，还是说一个分类的方式？就是有没有需要 HCM 的病人routine 就一定要去做这个，然后知道哪一个 sudden death 的风险会比较高嘛？
这个它就是可靠的 cut-off value 啊，还没有一个大家公认的参考价值。
是，
但是我们可以根据它的 MIBG 的 washout 的 rate 去评估它的 receptor 的功能。如果的 washout 越慢，那表示它的 reuptake system 不好，那这功能就差了。那我们就可以 predict 它的 outcome， 应该它的那个 sudden death 的机会就比较大。
好，谢谢刘主任。那不晓得其他 panelists， 如果没有的话呢，那因为时间关系，非常谢谢刘主任带来这个精彩的合一的观点。那接下来的话，我们把主办交给那个我们的熊老师。
各位海峡两岸的专家学者，大家午安。下面我非常荣幸能够介绍我们阜外医院的王教授、王主任。我相信海峡两岸只要做超声或者是跟超声有关的，都听王教授、王主任的这个大名。那今天非常荣幸能够请到王主任。去年他也来参加我们台北的 BUF， 今年可惜碰不到面，但是还是我们不能饶了你，还是要麻烦您来帮我们讲一下，就是心脏超声在非阻塞性肥厚性心肌病变的角色。我们下面这里热烈欢迎王教授来给我们演讲，谢谢。
大家好，下面我跟大家介绍一下关于非梗阻性肥厚性心肌病外科手术前后的超声评价。关于肥厚性心肌病，中国与日本的发病率大致相同，在 0.16% 到 0.17%， 美国发病率在 0.17% 到 0.20%。那么肥厚性心肌病，它的猝死的比率在5万到10万分之一。肥厚可以发生在心脏的任何部位，包括单纯的室间隔，或者整个左室均匀性的肥厚，或者在心尖部 尤其增厚，形成肥厚型心间肥厚型心肌病，或者在左室中部导致了一个梗阻或者狭窄。那么也可以是在左室流出道所引起的梗阻。对于肥厚型心肌病呢，我们的治疗包括一般的这种情况的，包括药物治疗，或者呢对于左室流出道引起梗阻了以后的治疗，那么包括外科，那么酒精消融也就是介入，或者是双向起搏等。那么下面呢，我就给大家介绍手术方面的一个情况。那么这是一类肥厚型梗阻性心肌病。那么我们看到，在术前它的 SAM 现象以及室间隔这个位置增厚非常明显。那么经过了 Mayo 手术以后，可以看到左室流出道它的血流呢已经明显的改善。那么这个呢是切下来的这个引起肥厚梗阻的这一块心肌。那么对于术前左室流出道的压差可以看到非常的高，达到了93毫米汞柱。那么术后呢已经降到了12毫米汞柱，所以呢这是一个手术切除的比较彻底而且效果比较理想的一个Mayo手术的一个情况。但是对于这个心肌切多和切少它都不合适，因为切少的话仍然会遗留这个流出道的梗阻，而切多了以后呢会引起左室功能的一个减低。那么这是我们团队在这个心外科年鉴上发表的关于这个左室的这个叫逆重构，那么主要是在肥厚型梗阻性心肌病手术以后。那么可以看到他在这个术前以及术后7个月随访的时候，可以看到这个左室的这个收缩期的这个病变是有一个明显的一个改善的一个情况。所以呢，对于左室的游离壁，它的长轴的应变和它的环形应变都是明显改善的，但是对于切除部位，它的长轴应变呢是改善的，但是环形应变呢是减低的。所以切到正好让左室流出道那么明显的梗阻消除，而是最合适的。另外呢，就是对于左室中部的梗阻，那么这种情况呢，目前的诊断标准是左室中部的压差要在30毫米汞柱以上。另外呢，就是肥厚的室间隔和左室游离壁也有增厚，那么乳头肌呢也会增厚，这样子的话就导致了一个中部的梗阻，它并不是一个二尖瓣 SAMS 针所引起来的一个狭窄。那么这种左室中部的这种梗阻的话，它的情况我们这地方有个超声的图像来显示一下。可以看到这个基底段或者游离壁这个增厚呢不是特别的明显，但是在中间这一段呢它是有明显的增厚，所以呢它的一个血流加速呢是在左室中部这个位置。那么心间呢可以有庞大，那么引起一个室壁瘤，也可以呢是闭塞的一个情况。那么这个呢是连续波多普勒所测量的这个左室中部的一个高速的射流，可以看到接近4米了，也就是说在60毫米汞柱以上。那么我们用这个3维来看的时候，你可以发现这个左室心间部呢它是接近闭塞的一个情况。那么这些呢彩色多普勒主要就是想显示一下它中间狭窄的地方是非常的窄的，所以这种呢它的左室的容量也是因为这个梗阻引起了一个明显的左室容量的一个减低。它的临床特征呢，我们把这个左室中部的梗阻和左室流出道梗阻来进行比较，发现呢 这个左室流出道梗阻呢，占这个肥厚性心肌病里面呢，它是比较多的。那么左室中部梗阻呢，相对会少一点，但是它的症状会更加的重，而且合并室壁瘤的情况也会更加的多。那么在恶性心律失常还有房颤啊、性别年龄方面呢，这两组之间并没有一个明显的差异。可是对于这个左室中部梗阻，那么如果要是他尤其在合并室壁瘤的这个病人，那么他的这个猝死的风险呢会更高。那么另外，左室中部梗阻在这个目前的发病的情况可以看到，在美国呢是12.9%，在欧洲呢是10.9%。日本和这个我们阜外医院所统计的病例呢，它的比率是相当的。也就是说，在肥厚型心肌病里面，那么日本还有我们国家这边发生的这个发病率呢，都会比欧美国家要低一点。那么我们不管是看这个肥厚性心肌病相关的猝死，或者呢恶性心律失常方面，发现这个左室中部梗阻的病人，他比这个没有左室中部梗阻的病人，他都是要高的，说明呢他的危险性还是比较危险性比较大的这种情况。那么与这个左室流出道梗阻的这部分病例相比较呢，它的这个相关的猝死以及恶性心律失常呢，也都会比左室流出道梗阻的这一类病人要高。那么对于这类病人的治疗呢，我们也是可以通过药物治疗，那么或者对于合并室壁瘤啊这一类的病人进行 ICD 或者是外科手术这种治疗。那么在外科治疗的时候呢，有大约这么几个途径。一个呢是从主动脉的入路，那也就是一个改良扩大的 Mayo 手术，那么要求呢切除的范围要更远一点，那么要达到乳头肌水平，甚至乳头肌的远端。另外呢，对于乳头肌呢也要进行松解。那么切除的这个室壁的厚度，就是这个增厚的室间隔的增厚的所使的这个肥厚的心肌呢，切到范围呢也要将近一半左右。另外一个途径呢，就是通过心尖这个途径，就相当于一个室壁瘤的病人来切除他的室壁瘤一样。那么这个呢，主要是在主动脉路径没有办法达到的时候。还有呢，就是合并心尖部的室壁瘤。另外一个呢，就是心尖有闭塞。除此之外，它的切口呢是会通过双层折叠，并且呢用毛毡来缝合。还有一种方式呢，就是这两条入路联合起来，来做这个手术。那么我们比较了一下Mayo 的这个 Mayo Clinic 的这个发表的文献。来看一下，那么 Mayo Clinic 呢，对于经心尖的这条入路来做手术呢，这个比率高一点。那么阜外院呢，基本没有单纯经心尖的，那么大部分都是经主动脉，那么有一部分呢是联合这种情况。那么一会儿我们来说一下为什么会这种比例的差异。那么这个呢是一个文献上发表的Mayo Clinic 的这个他们的，你可以说先把心尖暴露出来，然后呢进行切开，那么把肥厚的这个心肌切除掉。那么术后呢，它是用这个毛毡来进行缝合的。那么他的经验呢，就是说可以通过经心尖的来切除这个肥厚的心肌，同时扩大左室的容积。那么阜外院为什么经主动脉的路径会更多一点，而没有单纯的经心尖的这种途径呢？一方面呢，我们用的这个手术刀跟常规的手术刀是不同的，这个是由我们自己大夫的专利的这种手术刀经过改良了，所以呢，这种手术刀可以通过主动脉 深入到左室里面更远的这种地方。那么这个是经主动脉和经心间两条路一起结合，才能把这个位置，这个梗阻的位置彻底解除。那么根据阜外院发表的这个文献呢，可以看到这个切除的范围我们还是比较广的，这已经超过了经典的猫瘘手术的范畴了。那么这是双路径呢是占5%，其他是经主动脉的。那么术后呢，一方面左室中部的血流是通畅的，那么左室的容积呢也是显著的增加了。另外呢，就是患者的症状明显的改善。那么下面呢，我们来说几个 case。那么这个呢是个男性55岁的病人。那么术前可以看到这个室间隔增厚的非常明显，达到34的这个毫米的这个厚度了。那么另外呢，它的乳头肌也是前移了。那么心尖部呢，可以看到这个还是有心尖的。那么左室腔它是明显的减小了，你可以看到左室舒张末期的内径是34毫米。那么中部主要是中部的一个梗阻，而不是在流出道。那么压差呢，可以发现已经达到53毫米汞柱了，所以这是一个非常明确的左室中部梗阻的肥厚性心肌病。那么这个呢是经主动脉路径来进行的这个切除这个肥厚心肌的这个术式。那么术后呢，我们可以看到这个位置呢，可以看到这个室间这个左室前壁这个心肌呢，室壁已经减薄了一点，而且可以看到运动呢也是有些减低的。另外呢，它的乳头肌可以发现比术前是减小了，所以呢也进行了一部分的切除。但是心间可以看到仍然是在这地方显示，因为这个病人只经主动脉路径，所以呢并没有对心间进行处理。那么左室腔术后呢，已经明显的等于说扩大了，但是在正常范围，在48毫米。那么我们再看彩色多普呢，显示左室中部的梗阻呢已经通畅了，没有再梗阻了。那么测了一下这个流速，在左室中部的这个压差呢是6毫米，所以呢这个是非常理想的一种手术以后的状态。那么第二个病例呢是男性28岁。那么术前呢，我们可以看到这个室间隔增厚是在这个前壁的增厚是在27毫米，那么也是有肥大的一个乳头肌。它的心间呢，可以看到已经也是明显增厚，并且呢接近闭塞了这种情况。左室腔的内径呢也是明显减少，只有39个毫米。那么梗阻也是在左室中部更靠近心间一点。那么左室中部的压差是51。那么手术切了以后呢，也是在前壁这个位置可以看到这个室壁是变薄了，这也是乳头肌在这里显示。那么这个病人的心间呢，也是没有进行处理，他只经主动脉路径来进行处理了。那么术后左心室的内径呢是49毫米，也是扩大了。那么血流是通畅的。那么压差是15毫米汞柱，所以这个病人呢，是因为他的心间的闭塞不是特别严重，所以呢没有对心间进行处理。那么我们再来看下一个 case， 这是个男性15岁的病人。那么术前可以看到这个室间隔的厚度是20，那么这是肥大的乳头肌，他的心间可以看到厚的特别的明显，那么心间呢也是几乎是闭塞了。左室内径呢是27毫米，那么梗阻也是在左室中部靠近心间这个位置。那么压差是53毫米汞柱。这个病人呢，我们就采取了双路径，那么也就是经主动脉和心间这2个路径。那么这是切除了这个一部分的这个心肌，那么可以看到乳头肌在这儿显示了。那么心间呢，也是切除了一部分肥厚的心肌了。左室腔的内径呢是40毫米，梗阻已经彻底解除了，压差16个毫米。那么我们再来看最后一个病人，这是个男性31岁的病人。 术前呢可以看到室间隔这个增厚是24毫米，那么这是肥厚的心肌，还有这个乳头肌。心间呢也是呈现一个闭塞的，几乎闭塞的一个情况。那么左室内径的话是35毫米，左室中部的是有明显的梗阻的，压差呢是51毫米，拱周的。那么这也是一个双路径的一个手术，这地方显示的手术切除的位置，那么一部分的乳头肌还有这个室壁的运动啊，也在这儿显示了。那么心间呢，也是可以看到稍微比术前要扩大一点。那么左室内径的话在48毫米，左室中部的血流是非常通畅的，压差呢是7毫米，所以这个病人也是一个手术效果非常好的一个情况。那么这是一个病人呢，主要就是想用超声来显示一下我们在2维超声除了发现增厚的这个心室壁以外，那么心间呢似乎有那么一点显示是这个庞大这种情况，或者说室壁瘤的情况，但是用3维呢就可以很明确的显示出来，其实这个病人是心间部有个室壁瘤的，所以这个病人呢做手术的时候就要考虑要进行这个双路径的这种手术了。他的室壁最厚的地方34毫米，二尖瓣的这个左室中部的这个压差的话在82，非常高，所以这个孩子呢是肯定需要手术的。最后我们小结一下，那么肥厚性心肌病引起左室中部梗阻的原因呢，一方面是肥厚的室间隔，还有呢就做较小的这个左室腔。这个病人呢，你可以他小到34毫米，甚至还有更小的。那么他的左室舒张末期的容量也是明显减低的。另外呢，还有他这个肥大而且前移的这个乳头肌，所以共同导致了这个病人的这个左室中部的梗阻。所以他有比较明显的临床症状，而且药物治疗无法缓解。那么左室中部呢压差都会比较高。这些病人不管是通过主动脉的入路，还是采用主动脉加进心间的入路，它的目的就是解除梗阻，增加左心室的容积。那么不管是前间隔这个位置以及部分乳头肌，那么不管是切除还是松解，还有呢心间部引起这个肥厚或者心间闭塞的这个心肌，都要进行处理。那么这样子的话，手术以后呢，减薄了这个室间隔，可以看到这个室间隔已经明显的等于说接近正常的，或者说稍稍的再厚一点情况。那么平均切除下来的心肌质量的话，大概在12.3克。那么左室中部的血流呢是通畅了，而且容积是明显改善了，症状也是好转。那么超声在这个里面所起到的作用呢，一方面术前的一个明确诊断，并且呢，这个包括室壁的厚度有多少，乳头肌是什么样的情况，心间有没有闭塞，这些都是需要仔细的去观察，这样才会为手术方案提供一个意见。那么术中呢，在做这个手术切除了以后呢，我们还要去看一下这个梗阻是不是彻底解除了，它的瓣膜以及心室功能等等其他并发症方面有没有什么问题。那么术后呢，包括出院之前以及出院以后的随访，我们都是需要通过超声来进行观察，这样的呢才能有个全面的评价，才能达到一个完美的一个效果。最后，谢谢大家。
非常谢谢王教授精彩的演讲，我们那个收获非常多。那个在座 panelists 有没有问题要请教王教授？如果没有的话，我先问一个问题啊，就是因为刚才我们看到你的影片都知道，其实 HCM 的治疗的话，不管是外科的手术，还是说酒精消融，或者是现在新的 Liwen Procedure 用那个 radio frequency ablation 的话，这个看起来都是非常需要经验的术者。 那今年的话，其实早上也有那个教授提到，就是我们那个对于 HCM 的治疗 Explore HCM Trial， 它那个 outcome 非常的不错，那个没有 Kenton 这个药物。那不晓得您对这个 study 这个结果的评估是怎么样？因为如果假设将来这个 Phase 3的 study 成功的话，也许对一般人来讲的话，可能大家在治疗 HCM 上的话，就有一个非常好的一个药物可以使用。谢谢，请王教授。
好的，好的，关于这个肥厚型心肌病整个这一类。一方面呢，现在的进展是非常的快，而且，最近的一个指南，大家也可以看到，我的印象就是像一本书一样，就特别的厚。那么，所以这方面的内容确实也包括很多，包括这个左心室中部的梗阻这一类呢，阜外院这几年也是做了不少的病例，那么也积累了很多这方面的经验。但是我个人的一个感觉呢，首先这些病人的这个药物治疗应该是第一位的，然后我们在超声检查的时候呢，会根据这个病人的情况来决定是不是还需要进行一些激发试验这种情况。另外呢，就不管他的手术还是术后的随访这些方面的话，超声基本上都是冲在第一线的。问题是这些病人的手术，阜外院这边的结果显示还是非常理想的。主要呢，一方面和我们的外科大夫的经验，以及这个做的例数都是有直接的一个关系。另外一个呢，阜外院作为这个国家心血管病中心所在地的话，它也是在这方面进行的研究也是非常深入的。所以我觉得我们的团队在这方面的工作，在国内还是可圈可点的，谢谢。
王教授精彩的演讲，我们学了不少东西。下次因为时间的关系，下次再跟王教授继续请教。那下面我们请黄大夫再介绍下一位演讲者。谢谢王教授。
谢谢。
谢谢。
接下来的话呢，今天第4位演讲者的话，其实是我们心脏科的后起之秀，算是青年才俊，我们的那个黄冠志医师哈。黄医师的话呢，在那个台大医学院毕业以后的话，在那个2015年升上那个台大心脏科的主治医师，那曾经在那个金山分院服务。那目前的话呢，是我们振兴医院心脏医学中心的主治医师。那同时的话，他也是我们台湾心脏超音波学会的副秘书长。那他在心脏超音波的领域上有很多的文章发表在知名的期刊上，所以在超音波有非常卓越的那个一个研究成果。那今天的话呢，他就为我们带来 TEE 的话呢，在 HCM 外科手术上的一个角色。黄医师，请。
谢谢座长的介绍。那我们主要是来分享一下在手术中如何利用食道超声来评估这个手术的效果，然后以及做这个手术策略的规划。那首先，今天早上听了很多专家的演讲，我想我们必须要铭记在心的很重要的一件事情，就是我们在做这个 myectomy 做心肌切除的时候，一定还是要记得这个心脏的肌肉呢，其实是 mitral apparatus 的一部分。所以说，其实在做这个肌肉切除的时候，一定要小心会不会影响这个二尖瓣膜的这个关闭。那很多专家其实也就是针对这个左室流出道有堵塞的这种 Hocken， 或者是说这个左室流出道没有堵塞，但是主要是以这个心输出量卡掉不足，那这2个策略来做这2种病患呢，会需要做这个心肌的切除。那首先我们先分享一下我们在这个 Hocken 利用食道超声呢来评估的一些经验跟一些小小的技巧。那这是一个食道超音波的影像，我们可以看到这是一个典型的这个 Hocken， 它这个左室流出道呢，因为这个 basal septum 非常肥厚呢，所以有堵塞的情况。那这个前叶呢也有这个收缩期的前移这个 SAM systolic anterior motion 的一个情形。下一，那我们可以看到，因为 systolic anterior motion 呢， 造成它在收缩期的时候呢，这个前后叶的 coaptation 不够，所以它同时也合并有一个这个严重的二尖瓣闭锁不全。那也可以看到左齿流出道血流有加速的一个情况。那在这样子的病患呢，传统上我们来做这个 myotomy 的评估呢，大概就像这个教科书上的图一样，我们可以利用这个10道超声的 long axis view 呢，去决定说我们要切的厚度。那我们也可以决定我们要切的一个深度，但是在切的这个宽度上面呢，常常就是会造成一个临床上的困难，因为目前的这个教科书上呢，有的人就是以主动脉瓣膜为它的 landmark， 来当做一个这个手术时候的一个参考坐标，那是从这个右冠窦呢的中间切到这个左冠窦的中间，或者是有人是以冠脉开口来做这个 landmark。但实际上呢，每个病人呢肥厚的程度，以及他这个冠状动脉或者主动脉瓣膜的形态呢，并不是每个人都一模一样的，所以要利用这种方式来做这个手术的指引呢，其实是有它一定的变异度跟困难度。那为什么在书上会这样写呢？主要是因为在经这个主动脉瓣膜做这个心肌切除的时候呢，这些结构的确就是阻挡在这个外科医师的视线跟这个心脏的肌肉之间，所以当然只能利用这些结构呢来做这个手术的这个地图的指引。那现在我们有这个3维超声呢，其实大家可以看到3维超声之后，它可以用这种类似电脑断层的方式呢，一层一层一层的往下这个 cropping 下去，所以其实它可以同时提供这个二尖瓣膜、主动脉瓣膜跟肥厚的肌肉的相对位置。我们可以看到，如果以这样子类似电脑断层的方式来做一个评估的话呢，我们大概就可以比较清楚的了解到，大概要切的宽度是多少。那这样子，其实这样子的超音波呢，除了是cropping 之外呢，它这个选定的角度呢，也是可以做这个测量的。所以可以在这样子的视角之下呢，除了同时提供这个术者他的这个肥厚的肌肉跟这些瓣膜以及冠状动脉，像这个我们可以看到这就是左冠的开口，大家可以利用这个超音波 cropping 的这个方式呢，去把阻挡在外科医师的视线跟这个肌肉之间的一些结构呢，暂时性的把它消除掉。那对于这个术前的规划呢，的想象力呢，会比单纯的2维超声呢，提供更多的一个资讯。那在评估这个二尖瓣闭锁不全呢，其实在 Hocken 的病患呢，因为它的流速是非常的大，因为肌肉是非常肥厚，收缩是有力，所以它这个二尖瓣闭锁不全的这个彩超呢，即使在3D 的情况之下呢，它其实流速很高。要仔细去探究这里面结构的变化，其实不太容易。那所以一样，在彩超呢，我们也是可以使用这种 cropping 的技巧。像我们现在把视角调整到这个 medial trigon 的位置，然后我们一样类似这种电脑断层的方式，一层一层的往下切过去，我们就可以看到说，其实这是一个典型的 Hocken， 因为它主要的闭锁不全就是在瓣膜的中间。那这个时候，我们也可以暂时的把彩超关掉，去看一下这个 SAM 的情况，那确保说这是一个 typical 的一个 Hocken。为什么呢？因为我们在做这个手术的时候，一定要确保它的二反呢，就是二尖瓣闭锁不全呢，单纯是因为肥厚的肌肉所造成的。那如果说它有其他的原因造成二尖瓣闭锁不全，其实单纯切除这个肌肉呢，是并没有太大的帮忙。那我们也可以看到说，在这个主动脉瓣膜底下，我们可以看到往前移的这个二尖瓣的前叶，在收缩期的前移。那这个当然就是一个 SAM 的一个定义。那同时呢，我们也可以这个3D 的影像呢，我们可以把它翻过来，从这个左心室的视角，就是从左室呢看向左心房的这个视角。那这个当然就是这个内侧乳头肌，这是外侧乳头肌。这底下是 LVOT 的位置，我们可以看到这个前叶呢，因为这个肥厚的肌肉呢，它在这个收缩的时候呢，它会有这个往前移的一个情况。你可以看到这个前叶的这个叶片呢，是被吸往这个左齿流出道的。那为什么会 这样子往前移为什么会造成二尖瓣闭锁不全呢？我们从这个测试图可以来看，这个地方是主动脉瓣膜的位置，这一片是我们的前叶，这后面是后叶，那这边当然是我们的左室的肌肉。我们可以看到说，在收缩的时候呢，因为这个前叶的前移，所以原本完美的 coaptation 呢，会有一个像这个我们饮料罐在开罐的这种感觉。那前后叶的 coaptation 就是因为这样的前移呢，它就露出了一个这样子的小孔。那因为心脏在收缩期的压力呢非常高，这样子的小孔其实就可以造成严重的二尖瓣闭锁不全。那如果说我们确定这个病患呢，他的前叶跟后叶并没有其他的病灶，单纯是一个这样子很典型的 systolic anterior motion 所造成的二尖瓣闭锁不全的话呢，我们就可以有十足的信心，在移除了多余的这个左室肌肉之后呢，这个二尖瓣应该是没有问题的，是不需要再做另外的手术的。所以可以看到说，我们有一个详尽的术前规划呢，那这个是我们开刀后的结果，左室流出道这个整个被开拓了不少。那这个二尖瓣呢 coaptation 也足够 systolic anterior motion 已经完全消除了。那放上这个彩超呢，可以看到其实这个二尖瓣闭锁不全几乎是可以忽略的一个情况，二尖瓣膜是不需要担心的一个情形。那我们可以看到说，这个测试图来看，原本呢在收缩期的时候，这个会往前移的前叶呢，已经完全的可以跟后叶很妥善的闭合。那这个收缩期这个像开饮料罐这种小孔呢，在这我们的术后已经完全没有这样子的现象。这个二尖瓣膜呢，当然就不需要后续的处理。那我们来看，这是另外一个，也是诊断本来是 Hocken 的一个病患。我们可以看到说，同样非常的类似，它有肥厚的这个左室的中隔，那它也是有 systolic anterior motion。放上彩超一样，左室流速道有加速，二尖瓣闭锁不全也是十分的严重。可是我们一旦用这个三维超声在检视它的时候，我们可以从这个左房就是左心房的视角就看到，后叶似乎有分开的一个情况。那我们用左室的视角可以更清楚看到，其实它有一个非常明显的一个 cleft。所以这样子的二尖瓣膜，如果术前只是看这个二维的影像，觉得它有 Hsin， 觉得它有这个心室中隔的肥厚，而忽略了这个二尖瓣膜本身的检查的话呢，其实术后它依然还是会有一个严重的二尖瓣闭锁不全。那当然，这个个案呢，我们在术前就有发现，当然就可以这个完美的在同时治疗它的二尖瓣的问题。那接下来我们再来分享一下，我们对于这个左室流出道没有堵塞，单纯是肥厚性心肌病变，如何用这个食道超声呢来做这个手术的规划。那我们其实刚如同很多国内外的这个前辈讲者所提到的，这个从心间这样子 approach 呢，它的视野其实会相对的受限。那我们除了要扩增它的容积之外呢，过多的切除又担心会影响左室的收缩能力，另外我们又怕伤到乳头肌，导致了二尖瓣的闭锁不全。那即使是用这个经位 transgastric 的食道超声来做这个影像，可以看完美的检视它的厚度，可是这样子的 orientation 对外科医师跟内科医师的沟通呢，其实是相对不太容易的，因为有时候我们的上下左右并不是那么的一致性。那当然拜现在三维超声的这个所赐呢，我们可以把超声的影像呢调整到跟我们外科大夫呢手术时候相同的视角，再利用我们 cropping 的技术，一层一层的像电脑断层一样把它切下去。我们就可以看到这是外侧乳头肌，这是内侧乳头肌，这是腱索，那这边是我们二尖瓣膜的叶片。那这样子，我们通常就是会把这个主动脉瓣膜的方位是调在12点钟方向，这样才会跟我们外科医师的视角呢，手术视角是相似的。那这样的话，其实我们就可以比较了解到说，这个心脏在正常收缩跳动的时候呢，它的这个室壁厚度的分布是怎么样？那也比较让外科医师可以做一个术前的冥想，来了解到说，这接下来的手术怎么样执行会比较顺利。那当然，我们也是要先确认说， 这个病患呢，他原本的二尖瓣膜的这个开闭呢是没有问题的。那这样子的话呢，我们就可以专心的来处理肌肉的切除的部分。那我们可以看到说，这个手术之后呢，左室容积其实扩大了不少，收缩力虽然稍微下降一点，但是呢，大体上来说，收缩能力是没有什么问题。那我们可以用这个一样术后的三维超声呢，再这样子一层一层的往下，像电脑断层切过去，我们可以看到，的确它这个容积呢是被我们开拓了不少。那这个腱索呢跟乳头肌呢，基本上是没有太大的 damage， 是没有问题的。但是呢，我们这个心脏跳动起来之后，发现怎么会有一个二尖瓣反流的一个情况？但是因为我们非常这个确信说，我们并没有伤到乳头肌，也没有伤到腱索，因为超声的检查是没有看到这样子的受损，所以我们可以理解这样子的一个二尖瓣反流呢，它主要的原因是因为左室容积扩大之后呢，这个相对会有一个类似 Type 1的一个叶片不够长的一个情况。那当然它就是一个 relative 的 prolapse 啊，并不是真正的因为腱索受伤前叶翻到心房里，它只是相对的有一个 prolapse。那这样子的因为由于我们非常确信乳头肌跟腱索是并没有受损的情况之下呢，我们就可以做一个 Alfieri 的手术，把前后叶对缝。我们可以在三维彩超看到这个 Alfieri 手术后的结果，二尖瓣反流呢几乎是完全消失。那这个病人术后的状况也是恢复的十分的良好。所以呢，现在因为这个三维的这个超声的科技呢，搭配这个跨病的技巧，其实我们可以尽量呢用三维的超声来模拟手术的时候呢外科医师的视角，那再提供一个完整的术前跟术后的一个评估。谢谢大家。
谢谢黄医师的这个介绍。那我们外科医生在做这种后肯的手术的时候，最担心的就是一个冥象，不管是 stratification approach 或是 apical approach， 那或者是说你切的那个 mass， 不够 adequate， 或者是说你去引起到其他的这个组织，所以超音波可以提供我们很多的这个 preoperative 的这个 planning 和这个手术结果的这个 evaluation， 那这是我最主要的这个想法。
谢谢庄主任的 comment。那其他的 panelists 如果没有意见的话，因为时间上的关系的话，我们可能这 section 的话呢就会在这里结束。那今天的话非常欢迎我们非常感谢我们4位的演讲者，分别就 MRI 就合一，还有就那个胸前超音波跟食道超音波在 HCM 上的应用做一个很精彩的一个阐述。那这个 section 我们会在这边结束。那等一下的话呢，我们就邀请那个许荣斌教授还有蔡依婷教授的话来做下个 section 的主持。谢谢大家。
谢谢。
好，大家午安哈。那我是这 session 就是大家我一直到最后一个最有分量的最后一个 session 啊。那这个 session 是由我三军总医院蔡依婷跟台大医院心脏外科主任许荣斌许主任一起 chair 这个 session。那除了我们 chair 这个 session 之外，我们有panelist 包括我们的那个高雄荣总的那个 杨宗龙医师，还有我们的振兴心脏科曹殿敏曹医师，还有振兴的心脏外科杨厚生杨医师、陈一成医师，还有李国珍医师一起来参与这个 session。不晓得我们徐主任要不要跟大家打个招呼？
大家好，我是台大医院心脏外科主任许宏斌医师，很高兴有这个机会来跟蔡宜婷教授共同主持这个 session。
那接着我们就请我们第一个 speaker 我们那个杨健杨教授哈。那我先介绍一下那杨健杨教授现在是我们的那个空军军医大学西京医院的心血管外科一病区的主任那看他的学经历非常丰富过去去过那个Berlin Heart Center 还有美国 Cleveland Clinic 都有进修过。那他今天要跟我们分享的题目是有关这个 cardiovascular 3D printing 在这个 hypertrophic cardiomyopathy 的部分。那就请我们杨教授开始好
了。尊敬的各位专家、各位教授，大家中午好我是来自于陕西西安，然后空军军医大学西京医院的杨健杨医生。我现在把我这个屏幕给大家做一个共享。我非常荣幸受邀请参加我们这样的一个高端的学术论坛，尤其是关于肥厚性心肌病 HCM 非常专业化的这样的一个学术会议。我也非常诚惶诚恐，因为我们在这方面其实做了一些工作，但是也是刚刚起步。非常高兴有这么样一个机会跟大家分享一下，主要是 cardiovascular 3D printing 在这个 HCM 中的一些应用。前面这些我相信我们这个 session 主要就是关于 HCM 的，它的基因学、病理学等等，我就不做介绍了，包括它的症状这些的。我们重点是讲一下我们那个治疗方面，我们有很多的专家，刚才我也仔细在听，包括外科的，包括酒精的消融，这是我目前来说是比较能够well accepted 的一些治疗方法。我们也知道这个 HCM 的话，大家现在越来越重视，尤其是我们医院刘立文主任近年来在做的一个叫 Liwen Procedure。我上午也看到立文主任有介绍，一会儿我看还有他的这种专题的演讲。它主要是这种方式呢，也是采取一个 transcatheter 的这样的一个 approach， 通过经心间然后 ablation 这样的一种效果的话，我们起到了它的治疗作用。在最早期，因为我是我们的心外科的医生，我跟我们超声科的刘立文刘主任，我们早期一直在关注这样的领域，进行反复的探讨。包括他们做最开始第一例，我们从动物实验一直到临床，从我们的最开始我们没有做肥厚性心肌病，没有做 HCM， 我们开始做的一些是 tumor， 做的是肿瘤在这种情况的话，一步一步的尝试，到现在我们已经做了100多例了，应该是这样的一个情况。具体的也收到了比较良好的效果，所以我可能更加关注于就是 3D printing 在我们如何帮助我们立文主任实施这个立文 procedure 方面，我们做了一些工作，给大家各位专家进行一个汇报。因为我们都知道，这个我们做这个 HCM 的手术，现在也种类也比较多，包括外科的切除手术，包括我们这个内科的我们时间隔的酒精消融手术，所以对于外科医生和我们内科医生都同样面临的一个问题，就是它的解剖学，包括我们有各种各样的手段，像我们常规会做超声、CT， 包括磁共振等等的显影，就是为了我们怎么样把这个个性化的疾病搞得更加的清楚。所以这是我们共同的，不管是你外科医生也好，内科医生也好，对于有一个特别的 specific 的病人，我们必须得要在术前给他如何制定一个精准的个性化的方案，一直是我们每一个临床医师所要思考的一个重要的一个问题。所以好在我们现在目前来说，影像学的数据越来越多，可以给我们的选择也就越来越多了。 3D 打印的话，因为当时我重点也在这方面做了一些工作。我们知道3D 打印最早是起源于在医学中的应用，因为它学科很广，医学中应用早期是在硬质的组织，包括骨科啊、齿科用的会比较多一点。然后当然现在随着它不断的转化，像肺科的、像胸科的，当然心脏方面也慢慢的有所突破。它的一个基本的原理就是采取各种各样的手段，各种各样也包括以 CT 为主的，还有超声的数据、CMR 的数据，经过体外的建模，然后提取、分割，然后重建，然后输到这种 printer 里面，然后打印出实物的这样的一个模型，供我们进行一个体外的测试和我们的这个手术方案的比拟。现在我们因为也知道，随着这个技术的不断的进步，工业的不断的进展。包括有非常好的专业的3D 打印的公司提供很好的这个打印机 printer， 能就像这个Stratasys 提供的 Digital Anatomy 的这样的一个打印机，它能够打印出来比较好的这个跟我们组织比较接近的这样的一些材料，而且是能够实施多材料混合的这种打印，所以给我们心血管的打印心血管的这种治疗带来了一个新的一扇窗口。目前来讲的话，我们3D 打印在心血管的应用，除了我们肥厚性心肌病以外，我更多的关注于，因为我是一个外科医生，我重点的方向是在胎位和我们的瓣膜介入方面，在这方面我们也做了比较多的工作。当然，除了这个以外，其他的结构性的心脏病，包括左心耳的风阻，包括大血管的疾病，还有很多复杂的先天性心脏病都可以去做。这是我们做的部分的胎位的手术的，这个我们看到主脉根部的这种结构，我们都把它打印出来了以后，在这个情况的话，我们因为同时跟我们立文主任紧密的合作，跟他团队紧密的合作，我们也在尝试着把这个3D 打印的技术用于我们指导我们立文术士，指导我们怎么样能够把肥厚性心肌病这样的一个手术做得更加专业化。这是我们团队简单介绍，我们做了400多例，其实我们3D 打印的已经做了将近300例，做了286例的各种各样的 3D printing， 包括我们咖位的这种我们制定这个手术的策略，进行手术的模拟。在这方面之前的话，我们先查了一些国内外的文献，也看到很多的专家学者在做，包括我们最开始查到的文献是做 3D printing 辅助下我们做 surgical 的，做我们开胸手术，对吧？我们判断它的范围，判断它这个肥厚区域的范围，判断你要切除多少，判断它的整体的这种解剖的结构，这个是发表在2015年在 Circulation 上的一个病例吧。然后它也是在体外打印出来了以后，然后包括跟腱索和乳头肌的这种关系，你要切除的范围，尤其是针对一个个性化的病例，然后打印出模型，然后制定一个个性化的一个方案。它最主要的一个优势呢，就是能够把内部的结构显示得很清楚。当然了，这是我们15年的一些工作，到17年发表这 JTCVS 上，因为它用了这种硅胶的这种打印的技术，硅胶打印技术了以后，可以把在体外进行一个模拟，就是说我们体外可以在试着先进行操作，然后再把真实的手术当中取出来做我们改良猫耳手术取出来的心肌跟它进行一个对照，能够达到比较好的一个 match。这是我们在外科的治疗上面的一些进展。同时呢，我们也知道Liwen Procedure， 其实我们立文主任会在讲，但是我觉得我一直在讲，它是一个很复杂的一个手术。虽然看的原理很简单，就是一个针进行射频，但是实际上你包括你的穿刺点的选择，包括你消融的范围，包括你选择多大的能量，甚至是几针，对吧？如果有了并发症，怎么样去预防等等，这些都需要一个非常精准的一个影像学的辅助，尤其是对于我们，因为我们要将来可能会从事这方面的工作，如果推广的话，它可能存在有内科医生、外科医生或者是超声科医生都会要采取这样的一种 mini invasive 的 approach。这样的话，它对于我们影像学的依赖会非常非常的高。刚才我们上一位讲者讲了，重点就讲了 TEE 对它的这种指导和帮助。当然，我相信除了 TEE 之外，它非常核心，包括我们经胸的超声，包括我们3D 打印 printing 技术的话，都会有很大的帮助。 我们现在每一例病人啊，因为我们立文主任的团队一个是非常强大，他分了肥心组就分了将近20个subgroup， 而且每一个 group 都在做不同的事情，所以我们外科上面主要是我跟他对接，所以我有时候显得很力不从心，但是我很佩服他们所做的工作，包括他们做的2D 的、3D 的超声、应力的超声，包括血流动力学的，以及每个病人的心电图了、CTA 了、CMR， 所以他每个病人的资料收集的是非常的全面，这也是我们为这个疾病所做的一些工作，我也非常认可这样的一种做事的这种风格。当然我们在 3D printing 方面也是在不断的合作，就是我们现在目前来说，通过体外的一个建模，最主要的一点就是个性化的模型。我们在做这样手术之前，我们要对这个病人他的解剖学的变异，尤其是我们比如说我们肥厚的时间隔，它是主要的是基底部的肥厚，还是中部的肥厚，还是它有没有 SUM 等等，都可以通过我们术前进行利用 CT 的数据进行一个重建。当然了，这个除了这个看到这样模型以外的话，我们觉得另外一个就是包括 strategy making， 就是我们做这种手术方案的演练。比如说我们从哪里进针，我们进到多深像我们右边这2个图所显示的，我们可以用这种软质的模型，对吧？我们就开始体外在计算机上去进行模拟。除了计算机模拟以外，我们打印出来的，我们还可以进行在实物上模拟。实物上模拟，比如说我们这个穿刺针，对吧？它的方向，它如何能够避免损伤到我们的冠状动脉，它的进针的深度是如何的，对吧？它会不会穿到心室里头去？还有怎么样能够尽可能的避免心包填塞等等。比如说像我们右图是一个我们国内知名的心脏中心的一个院长带领他整个的团队，然后到我们这边跟我们一块交流。像我们这个立文主任，这是我们当时的一个手术的一个场景，他在做手术，其实就是一个针的话，从体表进去以后，直接通过 apex 进到我们这个 septum， 然后进行一个消融。但是对于他来讲，可能因为他已经做了上百例甚至更多，包括动物实验，他对这个解剖学非常了解。但是对于一些其他的中心要开展的，它不像我们外科的 surgical 的在肉眼底下，当然肉眼可能也很难看到，比较深。所以这就需要我们影像学的这种指导。所以我们这个团队这张照片我觉得还是蛮好的。这个它是一个整个的一个团队过来参观这样的手术，包括内科医生、外科医生、超声科医生、放射科医生、麻醉科医生等等。我们围绕着这样的一个 story， 对吧？我们每个人可能头脑的想法是不一样。那么院长拿这样的模型的话，他会在这个自己的脑海里会重新的在一个重构，然后再理解这样的手术当然我们即刻的效果，我们可以通过我们的超声包括测压能够体现。但是每个人，我相信他对这样的一个手术的理解，通过这样的模型的话，都会有新的这种认识。这是去年我们 Martin 亮还有 Rebecca Han 到我们中心也成立了我们的培训班，合作全球多中心的合作研究。当时他也对我们这样的一个精准治疗，因为这个手术台上 table 上的这个病人呢，这个拿的这个模型就是这个 table 上的这种病人，所以我们做的这样的一个手术呢，就是为他特殊的定制。比如说他的方案，他能不能做，他可能受益，然后看到的这个结果就是立竿见影的。所以这个 Martin 看完了以后就表示着 amazing， 然后很快我们这个procedure 的然后我们立文主任就发表在 JCC 上，因为他就觉得什么事情不是光是说的好，一定是眼见为实。当然如何能够精准的治疗呢？我相信立文主任在这方面做了非常大量的工作，所以我只是更多的配合他们在 3D printing 方面做一些事情。总体来讲的话，当然除了这个术前的 strategy making， 可能术后还可以进行一个 evaluation， 可以进行术后的这种评估，包括各种各样的，因为影像学工具很方便，包括 CT， 包括超声，包括核素等等都可以。简单介绍一个病例，因为相信那个立文主任他会带来更加丰富的，这也是他们给我的一个病例。就是我们这样的一个病例，它是相对来说做手术道压差比较高，90的时间隔厚度是26，然后它的平均压差也达到60，所以我们也是在这除了我们 常规的超声学的术前检查以外，我们给他做了一个 3D printing 的一个计算机的建模以及实物的打印。我们在体外我们进行了一个精准的这种测量，看它的厚度，包括我们选择好它的进针的方向，怎么样去避免它这个冠脉的损伤，怎么样进的一个深度，到底比如前部间隔还是后部间隔的消融，针道的方向如何，这些我们都会进行一个体前的设计，然后我们按照这个设计的路线，然后我们进行一个操作，包括插入射频针，然后扩大我们这个烧的范围，前后的间隔的反复的多次的消融，形成这种黑洞的这种效应啊，然后最后我们评估它的即刻的这种效果。然后包括它这术后呢，当然因为我们都做的比较精准了，每一个病人像术前看90，术后1个月、6个月、12个月，它的压差是在不断的这种变化。通过这样的话，我们也在积累更多的经验。比如说，我们要平衡你烧的这种范围和我们以后的，比如说它可能出现你烧的范围越大的话，它可能它的并发症也会越多，时间也会越长。所以我们也在不断的积累，到是哪些部位最为关键，一定是一个个性化的这种 strategy 的这种 making 非常重要。而且术后我们也可以通过 3D printing 的方法来看它到底是，比如说它的靶向的血管，尤其是对于时间隔穿支的这种处理，冠脉的穿支的处理，还有它术后它 shrink 了以后，它这个厚度变了，它到底你这个效果是怎么样啊？能不能达到正常的？还有它最关键的这种核心的部位，对吧？比如说我们靠近 septum 的这个间隔 IVS 的话，它是否能够就是因为它主要影响这个左水流失道，所以它的压差解除其实是我们最为关注的一点啊。这样也可以通过我们术后的3D 模型来进行一个评估。总体来讲的话，我们相信啊，因为3D 打印技术也在不断的完善，尤其现在是多材料软硬结合，可以帮助我们像立纹术式这样的一种看不到摸不着的这样的手术，我们通过多模态的影像，包括超声，包括 CT， 包括我们磁共振，包括我们这个3D printing， 可能形成一个更好的 strategy， 对这样的病人形成一个个性化的一个策略，然后在术后还可以通过这样的手段来进行一个评估，可能会更加的做到个性化和我们精准的医疗。最后致谢我们的软件公司，包括 Materialize， 还有硬件的硬体的公司，包括 Stratasys。我们因为中心是有一个紧密合作的马科医疗的，也就是 located 在我们本部在西安，所以我也是感谢他们给我们提供了大量的帮助和我们非常宝贵的一些案例。这是我近期的今年4月份出的2本书，一本是中文版的，一本是英文版的，是在这个月刚出，是在由 Springer 承办的。大家如果有兴趣，可以上 online 去查到。谢谢啊！再次感谢大会组委会的邀请，感谢大家。
好，那谢谢杨建阳主任的丰富的分享。那不晓得我们 Panelists 有没有问题要提问的？
我是高雄荣民总医院研创中心杨宗龙杨医师，我可以发言吗？
杨医师请。
你好，刚刚听完杨健教授的这样的一个精辟的演讲，非常感动，因为我在我原来是一个放射科医师哈，那我在高雄总推行这样的3D 列印大概有3年的时间哈，从最早的从牙科的哈到骨头的，那最近1-2年大概都是往这个 cardiovascular 来走哈，包含这个主动脉弓啦、整个心脏啦到 aorta。那刚刚看完这个杨教授他们这个医院里面的这样的一个重装备啊，非常感动。因为他们的那个 J750啊是一个非常非常昂贵的机器，非常昂贵的机器哈，那个在台湾大概需要到1000万台币以上哈。那我们中心目前只有一台这个 J260的机器，但是260机器虽然是比较久一点的，但是基本上也能够达到某种需求，就是可以达到刚刚杨教授讲的，比如说它的这个透明度啦、换颜色啦，或者各种的模拟，但是没有办法像它的这个digital anatomy 这个机器这么的棒哈，可以做到这么好的一个视角。那我觉得他们在整个中心里面看到他们配置里面包含用的软体，用 Mimics 的软体，以及有一家这样的医疗科技公司来协助他们做后面这样的产出，事实上是蛮好的一个合作模式啊。所以我觉得他们杨教授能够有这么快的有这么多的经验，然后 patient source 没有问题，然后可以把这么多好的心脏的一个 anatomy 跟在外科跟内科结合的这样的一个所谓的经验的知识的传递啊，放在3D 列印上面去发展出新的术式出来，的确是非常的不简单。 那我觉得这2本书哈，我都会买来看一看哈，一定会买来好好研究一下。那也许以后我们就会有更多的交流。那我们在今年也是在 TSVS 有一些交流，就是在讲如何利用3D 列印来做心脏血管的评估哈。但现在我们高荣里面，我们其实上个月才拿到所谓的 ISO 13485哈，在这个 Design Development 这块的认证。那目前是着眼在我们的这个所谓外骨骼固定。但是未来会希望往这个心脏这一块来走哈，那所以这个还是一个还蛮重要的一个里程碑。那我们现在用的软体是 3D Slicer，3D Slicer 是在美国 MIT 发展出来的一个软体。那目前我们做一个心脏，如果你要做10个 segment 的 segmentation， 我们大概需要10分钟时间，10分钟时间就可以把这个 ventricle 啦，或者是 atrium 啦，各种不同的这个主要的动脉或者是冠状动脉做一些分割，让我们的医师在开刀前或者是在做 SDM 的时候，医病共学的时候就有更好的证据可以做这样的一个参考。那如果它 CT-MR 影像很漂亮的话呢，大概1分半钟就可以把一个心脏组出来。好，这个就是我们现在在这个科技上一个非常大的优势哈。所以未来我想这个我们应该有机会可以把台湾的资源把它融合在一起。希望未来我们在振兴啦，或者台大或者是高荣都会有一个很好这样的一个alliance， 可以一起交流学习把更多的 case 合在一起。因为我刚刚看了这个杨教授他们的 case 一年有这么多，哇，真是不得了哈！这都是我们这个是非常羡慕的啊。那我希望未来也有机会到这个西京医院去好好参观一下，看看他们整个团队的运作。这是一个非常棒的工作流程啊，在数位化这一块，在3D 列印这一块，我想未来可以发展更好的医材出来。这个我以前有个演讲就是很重要，就是我们在这个帮助医生上面其实最怕的就是一种3D 的手术，就是难的 difficult 的，一个是 dangerous 的，一个是 demanding 的。那现在3D 列印这个技术的确是有办法帮助外科医生避开这样3D 的困境哈。所以非常高兴今天能够参加这个论坛，非常感谢，谢谢。
那谢谢杨宗龙主任的 comment， 那也谢谢杨健杨主任的一个 present。那时间关系，我们move到下个 topic 下个 topic 就是我们杨主任一直在提到的这个 Liwen Procedure。那在这个 topic 开始之前，我先介绍一下我们这个 speaker。那刘立文主任目前是空军军医大学西京医院的超声医学科主任。那本身除了 MD， 他也是影像医学跟核医学的那个博士啊。那过去也去过那个美国的 Jefferson University 跟 Drexel University 当 visiting scholar 啊。我想他在这个这部分有很杰出的表现。那今天也很荣幸有这个机会邀请我们的刘立文刘主任来帮我们做这个Liwen Procedure 一个 present。刘主任请。
尊敬的各位专家教授，你们好，我来自西京医院超声医学科以及西京医院肥后型心肌病多学科诊治中心。我今天带来的题目是超声引导下经皮经心肌射频消融治疗肥后型心肌病。近年来，心脏性猝死逐年增多，我国每年猝死人数高达54.4万。肥后型心肌病是年轻人和运动员心脏性猝死的首要原因，占到了44%。我中心连续选取813例肥后型心肌病患者，进行5年猝死危险评分分析，发现大于4分的中危、高危以及极高危患者高达37.2%，这远远高于以往的报道。肥后型心肌病传统的治疗方法包括室间隔悬切术以及酒精消融术。室间隔悬切术是目前治疗的金标准，但是其需要开胸，创伤大，风险大，而且容易损伤到传导束，发生完全性左树枝传导阻滞，最终可造成患者发生心力衰竭。酒精消融术是一种微创的治疗方法，但是由于间隔支走形异常，酒精消融位置局限，不能有效解除梗阻，复发率高，而且酒精是液体，它容易出现外溢，而造成大面积的心肌梗死。基于以上 治疗方式潜在的并发症，我一直想寻求一种安全、有效、微创且不损伤传导束的治疗方式。酒精消融是通过消融间隔支而造成肥厚心肌的坏死、变薄而解除流出道梗阻。基于这样的启发，以及我科室于2000年就开展的实质肿瘤射频消融术，射频消融术后，肿瘤的血供灭活，肿瘤体积逐渐缩小。基于以上的启发，我就设想是否能经皮在跳动的心脏上直接进针消融肥厚的时间隔。有了这样的想法，我就开始了自己的动物实验。那么首先我遇到的第一个困难就是从哪儿进针可以确保安全。在心脏上直接穿刺，稍有不当就可危及生命。首批动物实验死亡率就高达50%。经过多批动物实验，我们选择了经皮经心间直达心肌为最佳的穿刺路径，动物死亡率也降低至0，充分证明了该路径的安全性。困难2，术中如果出现心律失常，我们该怎么办？我们都知道，肥厚型心肌病易激惹，射频消融产生的高热容易诱发心律失常。我们术中增加了12导联的心电图的监测，分析了术中近万份的心电图，得出了心电的预警信号。现在我们因心律失常终止手术的发生率由4.5%降至了0。问题3，如何消融可使心肌能够有效的变薄？我们没有可以参考的关于心脏的射频消融能量与坏死范围的最佳亮效关系。我们在近百只离体的以及载体的动物实验，我们分析其消融参数，得到消融能量和坏死范围的最佳亮效关系，从而达到射频消融治疗的最大化。我们通过200余例的临床研究，不断探索治疗的有效性。在最初，我们进行的是点消融，相当于消融室间隔的1个区。再后来，我们扩大至全间隔的消融，相当于消融室间隔的2个区。到现在，我们采用的是全间隔扩大消融法，是消融了室间隔的4个区，包括前间隔的1、2区以及后间隔的3、4区。在心电监测的保护下，最大化减薄肥厚室间隔，彻底解除左室流出道梗阻，从而有效降低复发率。我们来看一个病例，男性，23岁，2018年发现肥厚型心肌病，有胸闷、心慌、气短等症状，静息下左室流出道压差92毫米汞柱，运动后流出道压差148毫米汞柱，心功能2到3级，5年猝死评分6.6%，高危患者。首先第一步，穿刺进针。我们在超声引导下选择经心间、经心肌的穿刺路径，同时为了避免损伤心脏表面的血管，我们采用低速度血流标尺进行观察，从而可以有效地避免损伤心脏表面血管。这是我在手术室进针的情况。在超声引导下，我们可以直接观察到我的穿刺针走行在室间隔的心肌内。这是我们的利文 RF 射频消融系统的心肌活检针。我们将心肌活检针穿刺置入肥厚的心肌内进行活检，这是我们活检出来的心肌组织，很完整。第二步，射频消融。移出活检针后，保留鞘管，进入射频消融针。这个过程无需重复穿刺。我们将射频针穿刺到肥厚的心肌组织后，我们开启我们的射频消融系统， 可以看到消融区呈这种强回声影。我们消融完前间隔的肥厚组织，要改针道至后间隔，消融后间隔的肥厚心肌组织。为了保证左室流输道梗阻的充分解除，我们需要进行全间隔以及后间隔的整体消融。除了消融肥厚的心肌组织外，我们同时还消融掉了间隔支血管，从而阻断肥厚心肌的血供，从而可以有效降低复发率。这个患者的室间隔厚度是不均匀的，其厚度由17可以到26毫米。固定频率的射频消融针难以同时满足不同厚度室间隔的消融。利文 RF 可调频式射频消融针可以根据室间隔的厚度实时的调节消融范围，实现精准的室型消融，从而提高我们消融的有效性以及安全性。我们在射频消融前进行心肌超声造影，可以看到心肌灌注是正常的，并且还可以看到走行在室间隔内的间隔支血管。消融后，我们可以看到消融区没有造影剂的灌注，呈这种空洞效应，并且我们还可以看到走行在室间隔内的间隔支血管也被消融掉了。我们于术前以及术后1周给患者进行冠脉 CTA 的评估。术前我们可以看到这个患者走行在室间隔内的明显的间隔支血管，术后1周显示这个间隔支血管大部分都已经被消融掉了。我们进行随访，患者术前流输道压差92毫米汞柱，术后9个月压差只有12毫米汞柱。最大室壁厚度由26毫米下降至12毫米，接近于正常。我们将前15例的患者进行6个月的随访，其左室流输道压差由88毫米汞柱降至11毫米汞柱，最大室壁厚度由25毫米降至14毫米，基本恢复正常。我们将相关研究成果发表于2018年的 JACC 杂志。同期述评给予利文术士高度的肯定，称开创者因这项发明创新治疗肥厚型心肌病方法的发明而受到称赞，这项工作的复杂性不可低估。我们将30例患者1年的数据进行统计分析，发现患者的左室流输道压差由93.2下降至11.6，运动后的左室流输道压差由135.3下降至38.8，最大室壁厚度由24.6下降至15.6。同时，左房容积指数、二尖瓣反流容积以及运动负荷后 心电图 ST 段最大下移幅度较术前都有明显的改善。我们将利文术士与本院心血管外科室间隔悬切术1年的结果进行对比分析。两组患者在基线特征没有显著性的差异。左室流输道静息压差、最大室壁厚度、二尖瓣反流容积、左房容积指数等的改善程度，两者之间是有相同的治疗效果。而利文术士二尖瓣修复以及置换、永久性起搏器植入、完全性左树枝传导阻滞以及室间隔穿孔的发生率均为0，且利文术士住院时间短，费用更低。我们将利文术士与国际15项研究平均水平进行对比，发现利文术士可以有效地降低左室流输道压差，同时永久性起搏器植入、树枝传导阻滞以及死亡率 也是更低的。我们看一下室间隔悬切术的创口平均为230毫米，而立纹术式的创口仅为一个针眼大小，也就1-2个毫米。患者创伤小，恢复快，满意度比较高。立纹术式目前治疗全国28个省市、自治区以及包含香港的肥厚型心肌病患者。截止目前，本中心完成立纹术式治疗肥厚型心肌病275例。患者的感谢和好评是对我们团队的最大认可。这是我们的国际首例肥厚型心肌病患者，目前随访时间已经有4年半。这是中国香港的首例患者。这位是我们治疗立纹术式治疗心脏肿瘤的患者，目前已随访时间有4年8个月。超声引导下经皮经心肌室间隔内射频消融术被 Intervention 和中华心血管病杂志正式命名为立纹术式。立纹术式也正式申请到国际 PCT 专利。立纹术式是继外科和经导管之外的一个创新路径，它是在超声引导下将特制的诊疗装置经皮经心肌穿刺抵达心脏靶区，进行诊断和治疗心脏疾病的一个新术式。立纹术式除了治疗肥厚型心肌病之外，我们采用立纹术式进行心肌活检，目前已完成40例。立纹术式治疗心脏肿瘤已完成9例。诊断和治疗其他疾病，目前我们还在临床试验阶段。这是由我们中心与杭州诺诚医疗共同研发的国际首款适用于心脏的立纹 RF 射频消融系统。这种设备提供一种新的心肌活检方式。这种可调节式的射频消融针可根据室间隔的厚度实时调节消融范围，最大化程度的实现适型消融。我们来看一下一个立纹术式心肌活检的例子。我们在超声引导下，经皮经肋间，将我们的活检针穿刺进入肥厚的室间隔。到达肥厚的心肌组织内，我们按下按钮进行活检。这个是我们取出来的心肌组织条，很完整。它的病理结果显示心肌细胞的肥大、心肌细胞排列紊乱以及间质的纤维化。患者的磁共振显示室间隔中部的明显的心肌纤维化。我们在相同区域进行心肌活检，其病理结果显示该区域内有严重的纤维化存在，与磁共振结果一致。消融前我们进行活检，看到心肌细胞的肥大、排列紊乱、间质的纤维化、核大深染、肥大异形。消融后我们再次活检，可以发现心肌细胞发生凝固性的坏死、细胞裂解、脱水，也充分证明了我们射频消融的有效性。这里有3个患者，他们的 SCBI 评分均为低危患者。他们磁共振检查显示患者存在不同程度的心肌纤维化。我们对这些患者进行了立纹术式的心肌活检，发现他们也分别存在了不同程度的纤维化，与磁共振的结果是一致的。那么我们大家都知道，心肌纤维化是肥厚型心肌病患者不良事件的高危预测因子。那么，所以我们认为呢，这些患者的 SCBI 评分，因为没有纳入心肌纤维化这项指标，他们都是被低估了的。我们目前已建成国内首家 及诊断、治疗以及长期随访为一体的肥厚型心肌病诊疗中心。我来介绍一下我们中心患者的诊治流程。先诊者进入到我们中心，先进行初步的检查，包括常规心电图、24小时 Holter、常规超声以及运动负荷超声、CT、心脏磁共振以及基因检测。临床医生根据患者的症状以及 SCDI 评分进行诊断评估，推荐患者进行相应的治疗。如果患者纳入裂纹术式的治疗，还需要进行心肌超声造影、6分钟步行实验等20余项检查。所有的患者都会进行定期的随访。除了先诊者外，我们还要对先诊者的一级亲属进行诊治筛查。首先，其亲属进行心电图、超声以及基因检测。确诊为肥厚型心肌病患者，则进入患者的诊治流程。如果亲属为无症状、石壁厚度小于13，基因结果为阳性的患者呢，建议他们每年进行随访。患者无症状、石壁厚度小于13，且基因结果为阴性的患者，我们则建议他们每3到5年进行随访。我们现在已建成国内首家心肌病诊治团队，我们包含3个临床治疗组、1个运动负荷组、1个遗传咨询组、工程师组以及护理组。今年还成立了我们1个指控组，有负责国内项目的助理，还有国际项目的助理。同时，我们也吸引了国内外同行专家来参观学习，包括德国法兰克福心血管中心 Host 教授，以及哥伦比亚心血管中心马丁利昂教授来参观。我们作为 PI 单位，实施国内及国际多中心培训，目前已开培训班6期，培训单位25家。作为 PI 单位，实施国内及国际多中心培训，国内合作目前已完成30例患者。我们受邀参加了多项国际顶尖心血管大会，包括 CSI、TCT 以及 ICI。现在我来介绍一下裂纹术式治疗肥厚型心肌病的入选标准。患者年龄大于18周岁，流出道压差在静息或激发后大于等于50毫米汞柱。患者存在明显的临床症状，充分药物治疗效果不佳或不能耐受药物的副作用，自愿参加并签署知情同意书。我们中心先后在 Clinical Trial 上注册3项经皮心肌内治疗肥厚型心肌病的干预性研究。这个是我们西京肥厚型心肌病团队的合影，这是我们超声医学科的大家庭的合影。欢迎各位专家教授来西京医院超声医学科参观交流。感谢大家的聆听，谢谢。
好，谢谢刘主任的非常impressive present。那我们现在看我们 panelists 有没有问题要问？
非常恭喜刘教授这么大的成就哈。那从开始几乎是从无到有到发扬光大，到被那个国际人士可接受这样的治疗术式，真是不容易啊！很恭喜您，敬佩您哈。那个我在想说，像你做这个消融，我们不是还没有这样的经验，只是问一下，就是说，你这样消融主要是消融心室中隔的肌肉，还是试着把所有的一些血管呢，心室septal branch 把它消融掉？哪一个是主要的目标啊？那第二个呢，就是说，这个因为早上开会发现，如果做肌肉中隔切除术的病人， 它之后还会再放 AICD， 放 ICD。那你们放 ICD 的这个比例有多高，或者是怎么样去评估这个病人需不需要放 ICD？ 谢谢。
非常感谢这个曹教授的提问哈，我觉得你问的问题非常好。我先回答你第一个问题，我们做这个射频消融的目的呢，主要是来消融肥厚的心肌。目前呢，我们主要是消融室间隔，从最早的前间隔的消融到这个前间隔和后间隔同时消融，以及到今天的扩大消融，就基本上是把室间隔的整个的宽度、厚度和长度都要包容上。那当然，具体消融到底多大的体积，主要是根据这个病人的个体化。就是说，如果这个人只局限于基底，那我们的范围相对就小一点。但是大部分的病人，目前我们完成的275例的患者，应该说90%左右的病人，我们基本上消融的范围长度都在5公分左右。消的范围还是比较大的。那在消融的同时呢，我们要兼顾上，要把它这个间隔支供血的这个部位要消掉。我们消前间隔支和后间隔支。我们最早的一部分病人30例只消了就是前间隔，就是4区我们没消，4区主要是后间隔来供血。那这样的效果呢，就是并不是说像我们想象的那么理想。当我们把后间隔扩大消融了以后呢，2期的病人效果就明显要比1期要好很多。所以范围大这个是我们这个术式必须要这个做到的。您问的刚才问的第2个问题是，
就说
抱歉，
如果消融完以后还会再装置 ICD 吗？
是这样。因为我们西安呢是来自于我们国家的这个西北地区，我们国家就是这个目前呢就是装 ICD 的这个情况可能不是太一样。我们在西安这样的一个位置，像我的这个中心有6000多例的肥厚型心肌病患者，但是装 ICD 的却寥寥无几。我们是严格按着指南去评。那么超过6%就是危险分层，我们都是会跟病人去交流，建议他去装 ICD， 但是大部分的病人是拒绝的。有2方面的原因，一可能是很多患者对这个疾病我认为了解不够深，就是他老觉得好像装 ICD 不是很重要，尽管我们就是很急切的跟他沟通，但是他还更愿意就是先选择接受手术或者药物治疗。第2可能还是根据经济问题，因为目前我们在西北地区装 ICD 还没有走向这个医疗保险，所以费用还是比较昂贵的，所以大部分家庭还是要考虑这样的问题。目前我275例手术的患者，在术前呢装 ICD 的只有2例，剩下的都没有装，术后呢也没有。目前我们术后的这个整体的情况还是比较理想，我们200例的患者的分析结果目前已经出来了，最近呢正在做最后的数据的统计。那么心律失常的并发症，就是没有加重。
谢谢
您。
这样的结果看起来真的非常棒哈，还没有也不用装，也不用加这个 ICD。病人也是可以很好的存活率这样子。我还另外一个小小的问题就是说，我看您消融完以后呢，你做血管造影，或者是做那个 MRI， 看起来这个间隔支全部都不见了。那如果这样，我们是用导管的方式把间隔支用酒精烧融，多烧几条，那效果会不会类似？
我觉得，因为那个酒精消融术，我想的在座的专家是知道的，他去选那个靶血管是比较困难的。第2就是进去，因为有的血管它很细嘛，你要想把这个消融的这个导管进去也是很困难的，所以我认为是非常难达到的。即便是我们在临床上做了造影，你没有看见的间隔支，可不代表它不存在，就是很小很细小的。但是我们在消融，因为我们的第一范围是肥厚的心肌的组织，那么在这个组织里面呢，就是 就同时兼顾把这些间隔支灭掉了，尤其是后间隔。如果因为肥厚的心肌，它后间隔也是肥厚的，如果你不把它灭掉的话，前间隔支灭了之后，它后间隔支还会长上来。所以范围大是必须的。
好，谢谢。
好，那我们李国珍李医师有个问题。
刘主任，我是心脏外科李国珍。那个想请教2个最简单，比较简单的问题啊，就是第一个，病人开过刀了以后，可不可以再做这样的消融手术？比如说外科医师没有切完全的时候，这是第一个问题。第二个问题，因为根据酒精注射以前的一些文献来看，就是说比较年轻的病人随访效果比较差一点。那因为我们会用这样的经验来问一下，说做消融在比较年轻的病人，因为现在随访的时间久了，会不会也有这样的一个情况产生？谢谢。
谢谢李教授的问题啊，我觉得你提的问题，我想你可能也是不是做这个酒精消融术或者时间割旋切术，我觉得你对肥厚型心肌病的这个手术的情况还是非常了解的。我们做这个室间隔消融术失败的和酒精消融术失败的都有例子，效果都是非常理想，我们是能做的啊。目前室间隔旋切术术后的我们做了2例，酒精消融术目前做了5例啊，都很理想，因为我们是从心间经心肌进去，所以不用再开胸。酒精呢，我们也不用选择靶血管啊，那么只要在术前进行精细的这个术前评估啊，就OK 了。您第2个问题问的是，不好意思啊，
新的病人会不会跟酒精注射的一样，就是跟外科比起来，年轻的病人随访比较差一点？
OK 啊，是这样的，我们现在把我们的这个手术200例已经进行了分析嘛，因为这200例基本上就都够1年，最长已经4年多了，啊，数据还是非常理想的。因为现在我们还有另外一组临床研究是儿童的，就是都是在18岁以下的啊，那么还有8岁、9岁的，当然这个需要长期的随访。我们目前总结的经验呢，主要是要范围大，只要范围足够大了，它是不容易复发的。因为你除了把组织灭活之外，你更重要的是把它的这个供给啊，就是这些间隔支都灭掉了。所以刚才这个曹教授提到了，我看到你都在 CTA 上把那些血管都灭了，你灭的越大啊，你越接近于根部，它就越不容易复发。如果要想达到更长期的好的效果，就是要把间隔支灭的范围多，把消融的范围要消得大。就目前我们统计的结果。好，谢谢李教授。
我想这个 topic 引起大家很大共鸣啊。那虽然时间紧迫，不过我们真心陈医师还有一个问题想请问。
刘教授，谢谢你精彩的演讲。我是真心心脏外科医师。那我想请问一下，你这个射频消融对于一种阻塞型的 LVOT 的这种 obstruction 的效果非常好，因为压力可以下降。那至于对于所谓的心间型的这一种肥厚型心肌病变的话，这种比较低位、比较靠近 apex 这一种的肥厚的话，这样的射频效果不晓得如何？
我们现在对这个就是非梗阻的，包括就是心间的都进行了治疗，也通过了西京医院的伦理，目前已经完成了10余例，效果是比较理想的，尤其是就是非梗阻的啊。但是您刚才专门提到了靠近心间的，因为它比较靠近心间，我们在消融的时候，就是要会非常的小心。我想可能大家做过手术都会比较理解，因为那个你像中上部它都是比较靠中间嘛，你相对来说容易控制在消融。到心间的时候，因为你再往外消，它容易跑到心包外头去了啊。那么这个是消的时候，就能量啊一定要控制好啊。我们一般都是保留离心包外，一般是1公分到1.5公分，我们就不再消了，因为你很难控制，就是说它里面的间隔支的情况，尽管你有造影。那也不会说是那么完美，你想看到的都能看到。所以目前我们前期的临床工作，我们一般是留1公分到1.5公分的长度啊，不能够造成将来心尖儿它恢复薄了再穿孔啊。就于这样的考虑， 目前我们的情况是这样子，心尖儿我们也做。
谢谢刘教授。
好，那谢谢刘主任非常的精彩的一个Liwen Procedure 的分享。那后面还有2个 topic， 那后面2个 topic 我们就交给我们许教授来 chair。
谢谢大会的邀请哈。接下来是要跟各位介绍2位重量级的心脏外科医师来跟我们分享肥厚性心肌病变的外科手术。第一位是王水云教授，他是目前是阜外成人心脏外科的副主任，他个人拥有超过1000例以上的肥厚性心肌病变的外科手术的经验，来跟我们分享他的手术，包括 combine transapical 跟 transaortic 的 resection。王教授，请。
谢谢。我的这个屏幕可以看吗？我的这个分享现在屏幕分享好了。
还没有看到分享，还是看到你。
我看看哈。我从这上面看是放映从头。现在好了吗？
只看到
目前没有看到，还没有看到。
我共享屏幕。对，要点一下这个。OK， 现在好了，我马上放我的啊。抱歉，现在可以了。
可以的。
我从头播放。好。感谢大会的邀请。谢谢，这是我第一次参加两岸的这个学术会议。刚才那个刘立文教授非常精彩的演讲，我听过多次，我每次都有不同的感受。恭贺他取得这么大的成就。我介绍一下这个主动脉心间联合切口治疗复杂的肥厚性心肌病。首先特别感谢这个 Dr. Schaff， 他教会我很多东西。这是2018年10月19号，在东京深源心血管病医院，他在表演的2台手术。我们有幸进行了面对面的讨论和交流，有那么2天的时间。这个是肥厚性心肌病的这个流行病学的研究，我们中国的大概是0.16%，这是阜外医院的资料。这个呢是2019年阜外医院的外科年报。我们从09年到19年，我们整个的肥厚性心肌病的手术例数，去年是435例，是历史上最多的一年。其实这个将近40%到45%的是孤立的肥厚性心肌病的冒入手术，其他的都是有合并其他的外科手术的。高度的抑制性是它的特点。我们19年1月份到2000年10月份，做了43例。我本人经过主动脉和心间联合切口来治疗这个复杂的心肌病手术。这主要是还是在和Schaff 讨论完了以后我回来做的。在此之前，主要是有那么10几例有心间室壁瘤的病人，我们才用这种方法。标准有4个类型，我们采用这种方法。第一，就是肥厚的累积的范围在主动脉瓣下7公分以上，就像这是一个2尖瓣，然后从这里一直下去，它比较长，这个很长，你通过主动脉的切口很难切到它的远端。第二个就是中部梗阻的病人，中部梗阻的病人你可能能切65个毫米是有保证的。7公分以远的这些地方，如果残余的梗阻，那么意味着这些病人在随诊的过程当中，心尖部会出现压差，还是会有梗阻，甚至会心肌变薄形成室壁瘤这样的表现。第3类病人就是心间肥厚或者闭塞的这一类病人，我们通过主动脉切口，然后切它的近中部分，通过心间切口也切它的远端和中间的部分来做。第4个就是这比较典型的心间变薄了或者有室壁瘤了。其实有些病人他不能等他完全形成室壁瘤了才做心间切口，这个核磁就能报出来他已经很薄了，超声也能看出来。在手术当中你探查一下就知道，有些地方特别薄，还是需要，尽管范围比较小，有些可能是 10个毫米、15个毫米，所以那么大的直径，我们也用这种切口来做。如果你仅仅从主动脉切口，那么意味着它随诊的过程那个地方还会形成石壁瘤。这是一个几分钟的一个视频，2-3分钟的一个视频，我跟大家分享一下。这是通过主动脉切口，这是我们常规的一个手术，位置稍微低一点的升主动脉切口。然后我们用3个牵引线来显露，显露是最重要的，因为这个手术主要还是显露的比较困难，所以才外科做的大夫比较少。Schaff是用牵引线缝在它的主动脉壁上，我们是缝在它的主动脉瓣的2个交界，这是右无交界，那是左右交界，我们把它提起来，这样呢就心脏稍微会浅一些。所有的这些都是比较长的手术器械，还有拉钩啊和这个刀是我们自己特别设计的。这是2尖瓣的前叶。探查完以后，2尖瓣有没有这个病变，比如说 accessory muscle， 还有要切的这个 second carotid，然后我们开始做这个心肌的这个切除。常规的第1道线是在主动脉瓣下的中点，其实不是完全是中点，我常常还偏向右侧一点，应该还是比较安全的，偏向右侧3个毫米应该都是比较安全的。左边就是不管它的主动脉瓣位置怎么样，都是贴近2尖瓣前交界附近，这其实是左室的侧壁的，往往这个地方是比较厚的。然后再把它在主动脉瓣环下4个毫米左右给它连起来，这个范围是固定的，这样我们把它连起来。这个刀也是特别设计的，为了避免损伤主动脉瓣。还有就是这个刀柄，这个刀我们有各种各样形状的刀在大陆，最后我们还是一直用这个12号的圆刀。为什么不用？我知道Schaff啊，还有克利夫兰他们都用这个微创的这些镊子啊、针齿，包括 Tufts 医院也是比较好的。但是我觉得我不习惯用那些，我也没有用过那些经验。我这个刀柄啊，它可能能有更大的手术视野。这个刀片非常薄，所以进去以后你更多的地方能看得很清楚。刀片占据的位置空间是很小的。基本上都是整块切除，切完以后我们再修剪一下，就可以了。可能深度在这边切的基本上还能到手头肌的中度以下，这个并不是一个，这是一个普通的一个吧，可能大概有5个厘米，4个多厘米，45个毫米以远，5个厘米以远的这样一个心肌的标本。好，我们再看一下这个，不好意思，主动脉的经过心尖的切口，这个是心尖的切口，其实要注意，这个是这个是前降支，这个病人同时还合并一个比较长段的肌桥，肌桥我们大概在我们阜外医院2200多例的手术当中，我们有100几例做了肌桥的松解。这是这个松解了以后，拿6个人的普通线给它缝上，然后呢，心尖的切口也要跟冠心病的室壁瘤的心尖的切口是不一样。冠心病的心尖的室壁瘤往往更靠前、更薄，那个是比较区分比较清的。这个心尖的切口，你一定要离这个2尖瓣这个前降支的中远端要有15个毫米以上，可能是比较安全的。特别厚的这些地方往往有20个毫米，你一定要 如果不准确的话，切下去，那么就很可能会损伤在这个位置的后乳突肌以及后乳突肌的根部，就像后乳突肌的树根一样。你如果把它树根这个地方给它切断了，那么这个心脏的乳突肌将来它会受影响，它的旋转的功能可能旋转收缩的功能就会差，所以这个切口是很重要的。然后，怎么样能找到这个心腔，避免损伤乳突肌，这个是有它的特点。然后切开了以后，我们要区分前乳突肌在这个位置，后乳突肌是这里，我们要切前乳突肌到室间隔的这一部分，这是溜出道的这一部分，还有这边是室间隔的这一部分。这是以前的一个病人，这是经过主动脉切口切出来的一个室间隔的心肌，这是经过心间切口切出来的。其实这个病人是我星期四做的一个手术，主动脉切口和心间联合切口切的，这是经过主动脉切口切出的心肌。这个呢，左边的是经过心间切口切出的心肌。这个病人因为是27、28岁吧，他的纤维化还没有那么严重。左边的这个纤维化就更重一些，这是另外一个病人的切口，然后这个是我们给他双层的三明治法给他缝下来，这也是同样左边病人的，但是这个纤维化经过心间切口的纤维化呢就非常明显，这个闭塞的很严重啊。手术的要点我自己的体会也没有人教，因为我们都是自己来做。心间的切口是要把它心间整个垫了纱布以后，把它心间要提起来，让它心间冲向天花板，这样呢往下看就会更明确，不能让心间不能让整个心脏坐在这个胸腔里面，要用这个2个牵引线带垫片的牵引线把它向上提，这样它的构型会比较好，符合它生理的状态，这样垂直位置，然后就能比较准确地认准室间隔以及前后乳突肌的位置。还有在室间隔，如果它坐在下面，那么室间隔切的厚度可能会比较难以把握。如果把这个心脏给它提起来，那么我们再从心间的切口切它室间隔就会比较准确，切到中部，我想基本上还是不是很难操作的。第二个呢，要点就是切口要尽可能的避免要损伤这个后乳突肌，因为我们的心间的切口切下去就是后乳突肌的附着的室壁上的一些一些这样的连接，很容易把后乳突肌如果切的偏我们主刀的右侧一点，就很容易切断它的后乳突肌。如果一旦损伤这个乳突肌，我理解它就像大树的树根一样，你把它的树根切断几个，这个乳突肌在收缩的这个时候可能就会不像以前了，它的心脏更重要的，它乳突肌附着在它的心间位置，它是有旋转的功能，然后这个心脏的血液才会射出去。如果这个损伤了以后，这些病人可能会有关闭不全，或者心脏收缩的功能很强，但它总是会出现一些恢复的比较慢，要充血利尿，可能这些水钠出流，所以是要非常注意损伤这个后乳突肌根部附着的地方都要保持它的完整性，不仅是这个前乳突肌也是这样，要保证心脏的收缩旋转的功能很重要，就是它根部和室壁接触的这些乳突肌是必须要认清楚的。另外，心肌的切口的缝合，这个心肌的缝合跟我们室壁瘤的那个可能还不一样。冠心病的室壁瘤因为纤维化比较重，它加上毛毡片了以后，它不太会容易出血。这样的心肌它没有外面没有脂肪，也没有纤维的这些组织，它就是心肌，所以用2个零的抛磷线横切口，在它纵向90度的牵拉一下，这个心肌就像刀一样把它切割了。所以还是比较，缝合还是要比较仔细认真的，一定要在垂直于心肌的表面，可能来拉着顺着它的线拉，可能才好，要不然很容易引起这个心肌横向的切割，缝线的切割会是引起致命的一些出血。这是一个18岁的男性的一个病例，术前和术后我们看一下。这个是术前的核磁， 这其实就是一个中部的梗阻，中部梗阻发展的结果，后面一定就是它会形成室壁瘤。这病人活动量越大，它心间的地方的心肌会越薄，后面就会形成室壁瘤。这个是术前的超声。这是做完，这个是术后的哦，抱歉，刚这跳过来了。这是术后的，做完了以后，它的这是1米多一点，1.5米吧，10个毫米汞柱的压差，然后二尖瓣也还关闭的比较好，然后左室腔还好，7个呀。这是第2个病人，这些做心尖部肥厚的，其实年轻的病人还是比较多的。这是19岁的一个女性。没有心间室壁瘤，但是是一个中部的一个梗阻，术前的一个超声。这收缩，这是左室中下部的室间隔整体的肥厚。这是做完手术以后的然后是个压差，基本上没什么压差，效果。超声检查也还比较好，这是他术前的这样一个核磁中部，心间在收缩的时候也是这个心间的腔是比较小的。其实我一直在想这个问题，对于肥厚心肌病的病人，有些病人他的左室的流出道他并没有明显的梗阻，中下部的这种闭塞，以后呢，他左室他的心脏旋转的功能，特别射血旋转的功能，它就消失了。这个是手术后1年来复查，这个又做的核磁，大家可以看到这个流出道还是比较通畅的。这个是手术前的，手术前的这个核磁，它是心肌就很厚。这个是手术后1年复查。这是它的下壁，这些地方没法来切，我们要切的只能是这些地方。但是心间的形态还是有，它心间只要有这个没有闭塞，它有10毫米、15毫米的这样的直径的一个心间，那么意味着这个心间的功能可能就会比较好。它没有压差，这些地方就心肌的显微化就一般来说可以控制这个进程。这个其实就是星期4做的一个下午做的一个病人，一个20几岁那个小伙子，他那个心肌的标本，刚才我们也展示了一下，这是他的术前的核磁，其实这个中下部完全基本上闭塞的很严重，这个实际特别厚，大概有40个毫米的，这个其实都是它的异常的，这个是乳头肌。前乳头肌、后乳头肌，这个是前间隔的一些附着在前间隔上一些很粗大的基数。当然，我觉得刘教授的消融把它消了以后，这些基数的供血可能也是会受一些影响的。但基数的供血很多的时候，它是在通过室壁，而不一定完全是通过室间隔，它可能室间隔也供血，然后通过室壁的游离壁，它也这样供血。乳头肌是这样。它这个基数我们是可以切掉到这里。这个病人就是术前中部的压差有59吧，这是他切下来的，这个是经过流出道生主动脉的切口我们切的，这个是经过心间的切口来切的。这是一个食道的超声，还有一些气泡，大家可以看到这个是。这个心间的状态，心间是收缩起来就没有闭塞，它还是有一个空腔出来。这是我们简单的一些资料，其实就是因为疫情的问题，我们做了到10月份为止，到上个星期可能有差不多51-2例吧。这个病人并不是很少见，其实这2个切口一起来联合，我想可能会比以前要更做的更多一些。有流出道梗阻的，有中部梗阻的，还有流出道加中部梗阻的。 其实单纯流出道没有梗阻，中部也没有梗阻，单纯心尖肥厚的，我们做了2例这样的病人，效果我们还需要进一步来观察。左心室的这个容积是最后扩大了，我们还是需要经过核磁心肺功能的评价，然后再来观察一下怎么样。其实这个讨论能用2分钟的时间讨论一下。中部梗阻通过生主动脉的切口能做到满意的疏通吗？所以每个医生都是这会想的。也许你80%能做到，剩下的远端7厘米以上的，我觉得通过生主动脉的切口可能是很难来做得到的，所以就有必要可能真的是要通过心尖切口来看。你通过生主动脉的切口，就像。其实比喻的不太好的话，像盗墓贼在里边做操作，有时候这个很可能就把这个你穿透了，你也不知道，所以要通过外面来做可能更好。中部如果残余有梗阻，它的结局是什么？结局就是一定是心尖会纤维化更厉害，心尖会形成室壁瘤。心尖闭塞的结果是什么？心尖闭塞的结局，那一定就是心尖。部分的这个心尖的心肌会纤维化，将来会形成室壁瘤。心尖的作用是什么？我也经常在想，我们怎么样恢复这个心尖的这个功能，让它有腔隙，减少它的因为心尖的作用就像这个打网球一样，如果你没有完整的挥拍的动作，只是一个1/3挥拍，那么呢，它肯定击不出一个很有效的球。所以我想心尖的作用。还是很可能就像我们挥拍拉伸这样一个完整的动作才行。心尖缝合后会影响左室的容积吗？会增加心律失常的风险吗？这个在核磁上能看到。上午我学习了一下，核磁上看到，这个经过心尖切口缝合以后，这里还是会有纤维化的。其他的讨论呢就没有什么很特别的了。这个最早的还是。Mayo 做的比较多，他们已经做了196例这样的病人。前年在日本东京和 Schaff 见面，他特别向我推荐这样的手术方式，我也很感谢他。特别是他鼓励我们说，是不是能够延缓或者甚至能不能替代心脏移植不知道，但至少对于这部分病人可能会。延缓他做心脏移植的这样的一个进程，所以我们这个手术已经完全不能完全叫做myectomy， 它可能更倾向于左室的形状几何形状的重建。这个我的理解是这样。好，谢谢大家。
好，
没有超时好像是。
是。谢谢黄教授的分享。可以回到那个大会的。
我停止共享。
是。
徐主任，我们事实上可以看到你。
是。可以看到我哈。
是。
谢谢王教授的分享哈，跟我们分享有关那个combine transapical 跟 transaortic 的 myectomy 对于肥厚心肌病变，尤其是在中部跟心尖的肥厚的一些病人哈，尤其是他提到了许多有关手术的技巧，还有手术应注意的现象哈。不知道各位 panelists 有没有什么问题？
教授你好，我是振兴医院李国珍医师。那就是因为我们会有荣幸邀请到王教授，就是说 review 一些 paper 里面会讲到一些 expert 所在的一个 institute 里面，就王教授的名字就列在这个跟欧美国家一起在上面，所以非常荣幸能够邀请参加大会。那我的问题是说，我们在做 myectomy， 不管是从心尖或从 aortic， 我们时常会去看到一些很特殊的 popular muscle。就是在乳突肌上面，所以刚刚我看你的影像还有大家都会谈到乳突肌到底要不要去处理它，会不会处理它，要处理到哪一个程度才是认为是够的？因为这又牵扯到2件半的问题，所 所以我想听王教授，因为1000多个病人，甚至于那个刘立文教授也有谈到一些 case。那我不晓得你们这样的治疗，在针对于乳头肌异常，特别是很肥厚的乳头肌，到底要做到什么样的程度，或者是不能够去做到什么程度？谢谢。
我看那个刘立文教授也很感兴趣哈，又见到你我很高兴哈。我简单说一下，因为时间太宝贵了。您提的问题每一个病例我都是我特别关心的这些问题。我们在是不是17年吧，在 GTCVS 上发表了一篇文章，就是关于肥厚这个基数。我先不说乳头，就是左室中部的这些基数，然后呢，它在它的梗阻当中的作用。在有些病例当中，它是要切时间隔，但更重要的是那些非常粗大的基数，要把它切掉。这是关于异常的基数。第二个就是乳头肌的问题。乳头肌有多种处理方法，像斯密达尔那种说分散的乳头肌把它拦起来的那种处理方法，我也没有用过，因为我没有信心，我还不能太理解那个事情。关于您说的乳头肌特别肥厚的，要不要处理？我的意见是这样，特别是对于薄的那些病人，18个毫米、17个毫米，甚至16个毫米梗阻很严重的这部分病人，往往他见于50多岁的女性。我们在切的当中，你要把它切得够，它其实够和破已经是很相近了，够和这个已经是非常相近。它就像你在悬崖边上栽一朵花似的，你栽到它的时候，你可能就掉下去了。的确是这样，所以我一般这些病人我会留9个毫米的这种8、9个毫米的厚度，但是6个毫米也没破过，也有那么第二天早上也有破的。还有我做完了以后，我的助手有时候老是跟我说要摸一下，我摸的时候没破，他摸的时候就给我摸破了，所以这个的确是这样。从此以后乳头，我这个病人再不让切完以后再不让入口来摸了，之前可以。那个乳头肌特别粗大的乳头肌，就像人的这个腿一样，在有些病人当中，如果你已经时间隔不能再切了，也没有异常基数了，再切就很危险了。2间半的这个畸形也给他就是没有特别要处理的，那么这个粗大的乳头肌在他左室里面占的容积很大，空间很大，是需要处理的。具体的处理就是我是拿非常我那个刀，我要把它完整的竖着给它切掉一条。我因为时间我也没有不讲这个问题，你要把它切掉。这个乳头肌是非常 weak 的，你看着，你用这个镊子来夹它，你就像夹豆腐一样，很可能就把它夹碎。你如果把它夹碎它，你是没法缝合的，这意味着这个手术完全失败了。所以你怎么样提着它的腱索和它的乳头肌的顶端，然后用非常锋利的刀切掉它一部分，这叫做就是给它完全切掉一部分，它左室的空间大了，它就好了。大概我有20例这样的病人，是切乳头肌的，因为我看着他实在是太不顺眼了，我觉得我不切掉它，这个左室腔无法扩大。我不知道回答的对吗？
谢谢王教授的分享哈。的确，部分乳头肌的切除是蛮危险的动作，不过对有些病人事实上是必要的。不知道各位其他的 panelists 有没有其他的问题？
那个王教授在请教第2个问题，就是因为Mayo他们有一些人习惯做完以后会用针去测量压力差，我不晓得在府外的感觉是怎么样子？谢谢。
我回答您的问题。其实我的第1个学生他就在Mayo一直跟着 Schaff。他是不是有发表了10篇文章了？这个我一直也很纳闷，他们用针来测这个事情。我测过10几例，后来我也没再测，我还是用超声来看。他测他自然有他的道理，但是我们用超声，我们要在心脏满意的前负荷和后负荷的条件下，满意的心率的条件下。我觉得我们也测的会是比较好的。如果不满意的时候，你2间半本来它很可能是一个微少量的反流，如果他心脏跳得不好，然后心脏很胀，心率很慢，左室有点扩大，那么它可能就是一个收缩不协调的时候，它可能是一个近中量的反流，这就让你非常 confused。 要处理还是不处理？我觉得还是应该在心脏一个稳定的状态下来超声来测是好的。他那么做，也有他的道理，但是我没有完全想明白。你们做吗？
谢谢。
你们测吗？测吗？
我个人是不做了。
是
超音波应该可以看得很清楚。
是因为我记得在我20年前我们做4联症的时候，我们都是右室和肺动脉都来拿针来测，那个是常规。好，谢谢。
谢谢王教授的分享哈。因为时间的关系，我们可能要马上 move 到下一个讲者哈。下一个讲者是魏征魏院长啊，他是目前是振兴医院的院长，他是我们台湾心脏外科界最有名也是经验最丰富的一个外科医师。今天他要给我们的分享的主题是他做myectomy在肥厚性心肌病人的经验。魏院长，请。
好，谢谢各位。那么当然了，我们台湾的病人没那么多哈，我就跟大家分享一下我这个经验。但我特别指的是非阻塞型，也就是非梗阻型的心肌肥厚的手术治疗啊，把我自己出钱的一些经验跟大家分享一下。因为我一直觉得我们这种非梗阻型的心脏肥厚，只有一种状况需要开刀，就是它的输出量，心脏打出去的这个血不够了。啊，那么很简单的一个概念，就是因为它太厚了啊，把这个心脏的这个腔室变小。那么比如说它腔室在舒张期只有30cc， 那你至少给它加个20cc 吧，那就变成50cc， 那这样它就够了啊，它就至少它勉强它可以够它的应用。所以我们就怎么样来增加它的这个在舒张期的这个容积就对了啊。那么我简单稍微讲一下我们这边的大概的发生率哈，但这个不是很准哦。为什么？因为这个是用在我们医院做的超声波检查的这个人数来讲的哈，包含健康检查的啊。比如说2018年到3月到12月这几个月里面，我们有29000个这个超声波的检查，那这里面有87个啊，我们发现有心肌肥厚，那几率大概是300%哈。那么当然这个是大家知道梗阻型跟非梗阻型的哈。那么我就不再花这个太多时间讲这个事情哈。那么主要的目的不是为了要怕它堵塞的问题，是我们讲非梗阻型主要是心脏输出量不够啊。那么这两个病当然不用再多讲了哈。那么手术的目的哈就是增加它的容积。那么在梗阻型哈。当然，在目前，我们的经验哈，就是说，其实这个经验是有点我们的做法是根据我们的经验有所改变的。那我现在目前啊的做法是这样，梗阻型的就经主动脉来做哈，非梗阻型的就是经过心尖啊，有时候是混合型的，就主动脉加上心尖哈。那么今天我讲的题目当然只讲梗阻型，所以我现在梗阻型都是用心尖，不经过主动脉。啊，以后的做法大概也就是这样子。那么早期就是在我讲的早期就是在跟着 Dr. Schaff 哈，跟他沟通过之前啊，那个之前我们梗阻型的其实不多，77例啊。那你看这个做法好像都不是，以现在来讲我不会这样做了哈。那么心肌切除的6个，2间半置换的12个哈，那么心肌切除加上2间半置换的53个，所以我们当初都很多都做了2间半的这个置换啊，其实这个不是太标准的做法啊。那么我们在过去30年，我们有做了将近600个心移植，其中有7个呢，就是因为非梗阻型的心肌症做了心移植。那现在呢，我们大概也不会拿来做心移植了啊。那么我们讲近期，就是从这个2019年2月开始，去年2月开始，我们跟 Mayo Clinic 那边有了交流之后呢，哈，发现到我们要做改变了哈。那么梗阻型的，这段时间有31个哈，那么到今年11月的时候31个，啊，梗阻型有15个，非梗阻型有16个哈，所以经验不是很多。我们很羡慕 阜外医院这么多的患者可以让我们开刀哈。那么其实我现在最喜欢开的刀，最想开的刀就是这种刀哈，就是大家比较不熟悉比较新的技术的这种手术。那么谈到二尖瓣呢，有12个是换了二尖瓣，有19个是二尖瓣保留的哈。那么切除的心肌的这种重量呢，梗阻型的大概3到7克，非梗阻型的是15到39克哈。我们有好几个病人是都超过30克的哈。那么因为在我的概念来讲，要多切一点啊，你切了39克，它是多了39 cc 的这个容积嘛哈。这个我讲一下我们的手术技术，跟大家一块分享一下。这个当然是一个非梗阻型的哈。那么我们在心尖切开哈，这个大概花10分钟。这个影片我们今天主要讨论的就是手术技术哈。那么这个病人还是好一点，他在一切开很快就看到心室腔了。这个地方不是太厚，它是比较厚，是稍微下面一点的位置。我们当外科医生其实就是怎么样把结构把它做好，就是把这个结构把这个解剖弄好就行了哈。那么这个开始我们先切这个肌肉，当然没有错，有些人怕一开始切破了嘛，所以当然一开始还是稍保守一点，不要一下切太多啊。我们先把这个切了一部分之后，让这个我们的视野看得清楚以后，再来继续往再多切一点这样子。大家看到我们现在先把这个靠心尖的部位把它先切掉一部分啊。那一般我就是用这个尖刀再加上剪刀啊，当然剪刀在剪的时候稍微留意一下，不要掉一些这个碎的肉掉到心房里面去，到时候找都找不到了啊。所以切的时候呢，一定剪刀上面有东西一定要擦干净哈，不要等到后面再去找这些东西。所以每一刀每一剪哈都要要看得很清楚啊，不要让那东西掉下去。所以这个光线很重要，我们头上戴的这个灯一定要看得很清楚里边的这个结构啊。那么第一块我们就先切了一大块下来了哈。那因为这一块一定很厚嘛哈，所以就放心大胆去切啊。所以我们做这个心肌切除的时候呢，胆子都要大一点啊。那么但曾经我做了有一个早期做了一个梗阻型的，不小心切破了。自从那次之后就有点怕了哈。其实后来胆子就又慢慢又变大了哈。所以切这种非梗阻型的话，一定胆子要大一点啊。你只要胆子小的话，切了10公克下来，那就几乎等于没开刀，没有什么用的。所以就放心大胆剪吧。但是，刚刚有人问到这个一个问题，就是说，心脏没有在跳的时候，你怎么知道它有多厚？你要怎么决定你要切多厚？啊，其实我这块切掉之后，我们就手指头就可以进去摸摸看了哈，摸一下看这个到底还有多厚啊。但你摸的时候，可能以这个心尖来讲，你摸的时候，你可能连这个右心室的那个厚度，你也可能也摸到了哈。所以你假如连右心室一块摸的时候，那你自己心里面有个数，把右心室那个厚度把它扣掉啊。所以其实这个手术讲起来做熟练的话呢，是一个非常简单的手术哈。其实我们做了还不到20个吧，就已经觉得很简单了哈。所以这个摸一摸厚度就行了。就是其实有很多东西完全要靠外科医生的手吧。你看这里可以看到那个这个腱索啊，所以这个时候该进去看看，先把这个整个里面的结构先看清楚，腱索在什么地方，它的乳头肌在哪个地方，都先把它标示出来了，把乳头肌标示出来啊。标示出来之后，你待会你用一个，你标示出来之后，你后面事情就不会伤到它啊。刚才谈到那个乳头肌的问题啊，乳头肌有时候占了很大的这个容量哈，有时候我会把它切掉一半，啊，就是在基底的部分，只要觉得它不会影响到它结构的话，可以切掉一部分，我个人是这么觉得，不影响到它的功能的话，这个再往下继续切哈。所以首要的呢，就是这个看得清楚。 当然了，我是建议要为了看清楚呢，甚至于要在左心房摆一个抽吸管啊，让底下的这个瓣膜呢能够都看得到，这样子你就不会伤到瓣膜。至于要不要去发明什么新的这种器械或刀子呢，也可以，大家可以去思考一下。应该我也觉得现在用剪刀跟这个尖刀呢，11号刀片还不够理想，应该去发明一点新的东西。类似于像什么圆锹一样、铲子一样的这个东西去做，应该会更容易一点。但是这种器械又不能太大，因为大的话你就挡到你的视线了。这个其实我现在发现到，从心间来做的话，你一直可以做，一直可以看到主动脉瓣膜为止啊。但主动脉瓣膜不会直接这样看得到，是要把那个肌肉往左边推一点，它可以看到主动脉瓣膜的时候，那大概就是差不多你就做到那个瓣膜下面了啊。所以就尤其对这种非梗阻型的来讲呢，你根本就不需要把这个主动脉给它切开来做啊，不需要用两边啊主动脉跟心间一起来做。所以你看我一路一直到切到最下面，像左手边这边它的下面就是主动脉瓣膜啊，那么右手边这边呢，当然现在剪的这个切的这个位置的右边，你看我做了一个记号的地方，那个就是后内侧的这个乳头肌，那个乳头肌你避开，不要去切到它就 OK 了，因为你看乳头肌也很容易分辨吧，因为它有连到这个腱索的就是乳头肌，没连到腱索的你就放心大胆去切吧。所以理论上来讲，这个手术假如做熟练一点的话，它是一个很容易的手术，应该很快就可以做好，而且通常不需要去动到这个二尖瓣啊。所以你看我这个画的这个做记号的，就是用刚刚用那支笔去画一下这个乳头肌。但今天画的目的，一方面待会可以让大家看到，就是说画了那个乳头肌的位置。但这个病人我们还不算切的最多，我切完之后称了才17克，自己都觉得还不太够。其实我们切的比较多的，大概切到39克嘛。啊，这个我画了一下，就是我摸了以后，左手你看到画那个蓝色的部位，我觉得摸了之后这个地方还厚，还比较偏厚。画了之后，因为你手一出来之后，你有时候就看走眼了哈，所以你画它一下，然后你再去切它。就这个地方还是偏厚的地方，应该我就分了好几次来切，就切完之后摸一摸它这个厚度，你觉得哪里还不满意，再切。假如我们左心是这种切法，假如在我的标准，我认为至少要切到15公克才算。只要切太少，就第一个就代表可能这个病人根本不需要开刀，要不然就是切的不够。当然了，还是都要强调，在切的时候，因为底下白白的那个腱索，千万别切到它。切到的话，你这个瓣膜就得要修补或者要换了，那就浪费时间了。所以宁愿做慢一点，看清楚一点。但现在我们看的这个伤口的靠手术者的这个方向，当然这是属于这个正下方哈，这是6点的方向，一直到10点的方向，这个大概差不多都是在心室中隔的这个位置哈。那么其实有时候在这个12点的方向哈，比较靠近这个free wall 这边呢，有时候也是很厚的这个肌肉，也是可以把它切掉一部分的。只要你觉得在安全的范围，像我这个动作是把那个抽吸 suction 哈，把这个头摘掉，再把它清干净，怕它有掉落的这个小的这个肌肉碎片掉在里头啊，把它都抽干净，或者是有些地方还有 不是太牢靠的一些肌肉，切了之后快掉下来这种，就还是要把它吸干净。这个像这个位置，就是在游离壁就是 free wall 这边，这个地方切实在太厚了，我们还是也可以切掉一点，但你要注意一下那个不要切到那个乳头肌其实平常这个乳头肌不在这个位置，是在差不多在4点、5点的方向。所以乳头肌这个部分呢，我是觉得，只要你看清楚了就很安全。你主动脉不打开有个好处就是你时间方面比较节省了嘛。但我强调的当然就是说这个还是非阻塞型非梗阻型的。那你梗阻型的那种有梗阻的话，那你势必可能还是可以考虑把这个主动脉打开来做。我刚刚讲我这样切的话，一直可以看到主动脉。或许以后做熟练的话，梗阻型的也说不定可以这样做，就是混合型的啦，就是或者是这个心室中间这种型的那么它有造成梗阻，它假如你从这边切能够看得够清楚的话也或许可以这么做。还没这么做这个尝试。那目前梗阻型的话，我还是会从主动脉那边给它打开来做的。所以这个地方关起来就好了，这个地方没有什么太特别的。我通常是关2层，第一层就是用 horizontal mattress 第二层就是用 running 这样子缝就可以了。那这个地方很少会有问题。但我平常做的时候，我有因为这个心室打开了嘛，有空气的问题。我平常一开始还没有在打开之前，我就先把右上肺静脉给它先，用个带子把它勒住让这个气不会跑到肺里边，这样的话就排气就会很简单这个是我手术的方式。主要今天跟大家分享的就是这个手术的一种手术的技术。那么这个谢谢大家，谢谢。我讲完了。
不好意思，徐校长，听不到你的声音。
谢谢魏教授的分享尤其是Trans-apical approach 做 myectomy 的大胆的 myectomy 的方式的介绍不知道各位 panelists 有没有什么问题？
我能请教一个问题吗？
好，谢谢王教授。是
王教授，
好，那个就仰慕您的大名。那个是我请教，刚才您说，你那个排气的时候要把右上肺静脉事先给它阻断，勒着。
是，我解释一下，我这样做已经做了数十年因为我发现我们平常手术过之后有这个气的问题，有时候排了半天排不掉。我后来发现到这个气最后都从肺里面跑出来的。那为什么气会跑到肺里面？就是它从肺静脉跑到肺里面去了。那么我发现这4个肺静脉只有右上肺静脉它的走向它是往上走的当你心脏左心房一打开之后它这个气马上它从这个气会跑到右上肺静脉往肺里面走。那等你要后面都做完了，排气是排半天，你都已经排完了，结果那个肺挤一挤又跑出一些气来，所以通常会有2个原因，一个是这个地方肺里边，一个是左心耳所以我现在所有的只要左边心脏打开的这个手术呢，我都把右上肺静脉先把它 loop 起来，先把它 snare， 就是在你打开心脏之前先把它勒住了。那么你等到做完手术的时候这个气非常好排，为什么？因为第一个它肺里面没气所以这个左心耳的气你只要把它翻过来，让它排掉一下，然后在左心房弄个洞嘛这个地方排气，这样就排得很快通常我这样排气几乎都在主动脉夹放掉之前 我稍微把血给了他之后挤一挤，大概就差不多了，几乎不太需要排气了啊。到后面看用超声看的时候，大概很少。那假如把这个地方没有把它勒住的话，有时候排气，大家有些经验，可能排个10-20分钟都排不完啊。我认为这个问题出在这儿。
谢谢您宝贵的经验。那个除此之外，除您之外，还有什么医生用这个方法吗？
在我们医院好多个医生都这样在用，
我星期一我就试一下，谢谢啊。
谢谢，是可以很容易就可以分出来，稍微小心一点就是了。右上肺经嘛，右上肺。
我是振兴医院杨厚生，那我有一个问题想跟院长请教一下，就是今天我们这个整个 schedule 下来就讲到有一个关于3D 列印这个东西啊。那刚才院长已经示范了个手术过程，那有很多事情是在手术当中用手去触摸了。那我自己一个想法是不是说，如果今天我们如果3D print 在这个技术上得到已经比较好的进步的时候，是不是在手术前我们大概也可以第一个定位做你刀切进去那个地方就直接进到心室，不会去伤到 pubic muscle。那第二个是说那个厚度的话，大概也可以一整，就一个事先的计划，就不用像我们现在目前还有一个技术上就是一块一块，那就有可能碎屑掉下来的问题。
对。
那这个是不是院长对这个也有一些期待？
是现在我们医院现在已经刚刚成立了一个叫做医学影音中心啊。那你坐你旁边这个陈大夫，他现在就是已经是这个负责这个部分的主任了哈。那么其实我早有这个想法，因为这个想法其实看到这个杨健哈，这个他的这个做这个3D 哈，杨健这个杨教授哈，做这个我非常 impressive 哈，就是说这个在这个一个手术的计划里面来讲啊，你有3D 列印哈，这个先把它列印出来呢，先心里面有个数是最好，当然没有错了。这个手术当你做熟练的时候，你可能不需要了，不需要啊。那么可是这个3D 列印可以应用在其他很多地方啊，在你日后还有什么研究啊、发展啊、新的这种创新，都可以经过这个3D 列印来有做一个很好的一个演练哈。那么刚刚这个，我想这个地方，但是待会那个杨教授还可以再补充一下。我是觉得这个是我们非常急着要开始要发展的一件事情。
感谢魏院长，感谢魏院长的那个对我们工作的认可，感谢各位专家的点评。因为我们也是刚刚开始，主要是结合着我们刘立文主任的这个新技术。我们其实从我个人来讲，因为我是做外科医生，但是我们因为专业分组分得很明确，我们有专门的一组专门做这个肥厚性心肌病的手术，我参与的并不是很多，但我对于我们刘立文主任这种minimally invasive 的 approach 是非常感兴趣的，因为我主要是在做瓣膜，做在他位，我就是在想他位这个，就沿着刚才那个话题，也是一个个性化的，因为每个病人是不一样的。我想，这也可以同样的适用于我们肥厚性心肌病的病人。刚才我也听到王水云王主任也在讲，很多要基于经验，但是我们以后的那些如果有更好的影像学的话，我们可能在decision making 这个环节上，我们有更多的考虑了以后，我相信就可能会在手术时间的缩短，包括病人的安全性上会有更大的这种进步。而且从肥心的角度来讲，从建模的角度来讲，应该比瓣膜啊什么的话，有它的特点，反而不会是那么难。我觉得从技术的难度程度来讲的话，应该是还是一个非常有前景的应用的一个领域。好，谢谢。
谢谢，因为我是担心立文这个方法再下去，大概我们外科医生对那个梗阻性的就没刀可以开了，现在只剩下非梗阻性的。
没有问题，还有房颤，还有肌桥，还有冠心病合并的所以还是。
不过你那个方法真的是我们都在期待哈，将来是不是可以对患者来讲，我们其实医生应该不要考虑到我们的这个手术量的问题，应该要考虑到这个患者怎么样一个最好的方法是最好的。
可以请教各位专家，因为刚刚那个王水云教授谈到房颤这件事情，因为我们会遇到一些肥厚性心肌病变的人又合并房颤，那如果要开刀或者是做消融这件事情的时候， 你们怎么去处理这个房颤这件事情？就说外科医生进去做切肌肉的时候，像王水云教授，你们怎么去处理房颤？或者是那个刘立文教授，你们在做消融的时候，你们怎么去同时处理房颤这件事情？谢谢。
要不刘主任先回答？
我先回答哈，那我就试着回答一下。在我们这个组里面呢，有1/4左右的病人都有房颤，而且在我们这个随访的这个过程中哈，就是术前这个左房比较大的，对于这个术后逆转、左室流出道压差都会有影响，它会延长时间啊，所以术前我们来这个就是了解患者有没有房颤，左房大小到底有多大，这是非常重要的一件事情。那我实际上在术中做的时候，有房颤的病人呢，我是就是不在意的，就是我是可以去做的。那术后呢，就是我还是会常规用一些这个治疗心律失常的药呀，像氨碘酮这样子。那随着这个左房的这个缩小，因为我前面的这个200例的数据已经出来了，还是非常好的。因为左房的这个大小因为逆转了嘛，所以有一部分病人他之前的这个就是比如说是房颤，或者是一些其他的这种心律失常，都会有这种能够可以不加重，还有部分人还有逆转的这种趋势。因为我们把左室流出道的这个压差缓解了，舒张功能改善了等等这样的功能，左房会变得小，理论上也是能够逆转的。
我相信应该有这个，对，应该是会的。至少有一部分，至少也有相当一部分的，大概自己会变好。我想外科刚刚王教授要补充嘛，对，就是外科手术，当然外科手术我们大概就直接就做这个消融吧，是吧？
那我简单说一下我的这个意见，因为关于肥厚性心肌病合并房颤的问题，我们也做了这么些年来，一直有不同的学生在随诊做这些研究。我们的观念还是，左房的这个大小容积，预示着它术后并发症的这种跟它的发生率是有关系的。还有就是这个有没有房颤，跟它随诊的这个中期的这种预后类似事件是有关系的。所以房颤是必须要解决的。在目前我们这个阜外医院团队是我和宋永虎教授两个人在做，我们2个人做了84%的病人在阜外医院，所以我这个是只要有房颤的，最近3-4年来我都是用外科大夫标准的迷宫4的手术，用这个双击的夹子和单击的笔来做这个房颤，所以一般来说，特别是这种很肥厚的这些病人，我需要差不多阻断将近3个小时，要用50分钟的时间来做这个标准的这个迷宫4右房双房，而且心耳是完全切掉的，切掉以后还用6个零带线来缝，然后房间沟也有切口，这个也是要缝的，这个确实要灌注2次，差不多就要50分钟、60分钟的时间，然后再通过生主动脉切口切它的基底部的这个肥厚的室间隔，然后再通过心间的切口来再切它的中部和心间肥厚的，所以这2个加起来2个半小时就到了，光阻断就需要2个半小时，所以我是多，但是我坚信每一个动作它都是每一个都做到位，都是精细的，它这些对病人的预后是有好处的。我是还坚持着一直在做，所以我们是110例的这个类似这个房颤的外科手术和在肥厚心肌病里面。
好，那我
谢谢，
是让徐主任先。
没有，谢谢王教授哈。因为时间的关系，我们最后就把那个 closing remark 交给魏院长来主持。
好，谢谢。这个今天非常高兴呢，大家参加这次的会。那么，不管是在我们在台上的，或者是在线上的啊，那么也有很多的我们的专家学者有在参加，甚至于还有国外的，我知道那个 叶剑教授可能也在上头哈，可能我不知道他睡觉没有哈。那么这个我们这次的会呢，我们日后的会可能这种形式来办都是非常好，因为比实际上来参加呢的人数可能更多哈。那么尤其是这样子一种经验的交换啊，就是一天就可以完成的这个会，今天尤其是又把这个 Mayo Clinic 他们的几位专家学者呢，又做了一些演讲。让大家可以学习到一些这个在美国那边的一个进步。那我们中国大陆这边几位呢都非常，你们讲的东西也非常让大家听了之后都可以学习到很多的东西。特别感谢我们几位那么多位的 speaker 啊，让我们今天开会就到这里为止。那么希望大家今天周末呢快结束了，大家还有几个短的时间能够好好用个晚餐。谢谢大家。好，
谢谢吴院长邀请，谢谢。
好，谢谢。
再见，
周末愉快，谢谢。